and there is a boom that is attached to the jig, which gives a sizing for your femur, and there's a posterior referencing while doing it, and also the anterior referencing. They say that while doing an anterior referencing, chances that the chances of notching are very less. So coming to the tibial component, how we do it? So tibial cut has to be again taken 0 to your anatomical axis or mechanical axis, because both the axes are same in this. So it should be measured twice and it should be cut once. Never do a mistake of thinking that like tibia will perceive you while cutting it. It will be very difficult later. And always check for your slopes while cutting it. So while doing it, once he puts the boom, your assistant check that it's not in a valgus or varus position, and make sure the slope while doing it, prior to cutting it, see the X-ray once. Make sure that you are not cutting too much of a slope. If you cut too much of a slope, chances that you give a flexion instability to that patient. Okay, so as we discussed, the tibial cut will always be taken at 0, and it should be perpendicular to mechanical axis of the tibia, and both the intra and extramedullary jigs are available for the cutting of tibia, but not for femur. For femur, it's only intramedullary jig. Okay, so that's how we do it with the tibial cut. So once you do all these things, okay, so you should have symmetrical balance as seen in the left hand figure. If you see this kind of trapezoidal figure, so your balancing is not right. Okay. So maybe that you have not cut too much of a tibia, or you have gone wrong with your measurements, pre-op measurements. So you have to go back and check whether you are done everything right. Once you think that everything is done right, then you should go and check for the soft tissue balancing. Before doing that, you should do something called dissection from the medial aspect of the tibia. Remove all the osteophytes so that the tenting of the NCL is released, so that the balance again regains. Okay, and how we do that? And you go on the posterior-medial aspect of the tibia, you release all the soft tissues there, and also the semimembranous attachment. Okay, so that when you get a rectangular gap back again. Still it is not done, still you are not getting the rectangular gap, you do reduction osteotomy of the tibia on the medial aspect. Okay, so that the tenting, whichever the NCL is there, you make it, when the tenting is released, and you get a rectangular gap. So we are done with all the gaps and all. Now we have to place the tibial components. There are several ways how you can put it. The one which has to be done is you make sure that tibia is in line with the medial tibial tuberosity. It matches with the medial 1/3 of the tibial tuberosity, your axis of the component. If it is not, then chances that you are increasing the Q angle by the rotationing of the tibial component. Okay, so which should never be done, which increases the increases the Q angle. So whenever you put that, you try to externally rotate the tibial component. Never do an internal rotation. So patella is usually not replaced, but half of the world population, half the world surgeons does it, and other half doesn't do it. So we do it only if patella is too worn out and if we are not tracking the patella properly. So only that time, depending upon the thickness, we replace the patella. Okay, it should be such that button replaces your composite thickness, and it should be symmetric section that you should cut the lateral side first. Okay, and then you check for the tracking. What should not be done to maintain the Q angle? You should never rotate the femoral component internal side, and never medialize the femoral component, and never internal rotate your tibial component. These are few of the things that should be taken care while putting up the implants. Okay, so how do we put the patella component? It should be at the center or medialized, should never be lateralized. Okay, and if you do that, if you medialize, it usually increases your Q angle again and causes a maltracking. And everything is done, you test it with the trial implants, and lastly cementing the original implant. That's the final implants that goes into the patient. So first thing is, it should be bone dry completely. There should not be even the blood on the your bones. Okay, and there should be finger pressure techniques that is there, and coat the implants with the cement and remove all the excess cement either from the posterior aspect of the femur and from the condyles that is there. So finally, once we are done, we check for the stability inside, and we also check for the tracking in the OT itself. That's a free thumb technique that we use, so the tracking is really good. Okay, and then we also check for the medial and lateral stability finally before we close the knee. Okay, that's how it's done. Okay, so after everything is done, so how do we make the patient to go back to their life? So there is something called rehabilitation and the rehabilitation. Rehabilitation is before starting for a TKR. Okay, so we advise for the patient for the quadriceps, static and dynamic exercises, and also active walking, range of movements, and hamstring exercises. Okay, and post-operatively it is divided into different phases, from phase 0 to phase 1, phase 2, and phase 3. In a phase 0, we do a pain management, and flexion is up to 60 degrees. We make the patient to walk on third day itself. There is no rest, and patient is made to walk with support. And phase 1, between 2 to 4 weeks, we at least ask the patient to run, means walk up to 30 steps, and if the patient is independent walking, is able to do it, he can carry on with it, and the come out training, everything is done. And next is phase 2, where there is we can push the patient if the patient pain would have been subsided too much, so we try to increase the flexion up to 100 degrees, and only closed chain exercises are advised, no open chain exercises with weights and at any cost. And cycling, stationary cycling is advised, and complete independent walking. Majority of the patients will not come for follow-up beyond this. Okay, so after this, up to phase 3, that is after about 1 month to 1.5 months, the patient comes to you, you try to make them that if you want to achieve further, you can go up to 120 degrees of flexion. So this is the patient from Jeglu. She has a severe varus deformity, and we can have a discussion on this. So do you have anything you want to add on to this?
So basic thing is before seeing the X-rays for the benefit of the audience, how do you consider the pain of the knee joint to take for TKR?
How do you?
What do you consider regarding the pain? How much pain? When to take for surgery? So instead of before seeing the X-rays, yes, you have to consider the pain.
Yes, sir.
So how do you decide depending on the pain?
Yes, sir. So one thing is, at the age of 55, there is a severe gross pain when the patient is not able to even go to a washroom. That is less than 10 to 15 steps of her daily activities. That is activities of daily living. If it is reduced, and then there is a gross varus deformity, then we take her for the procedure. That's the ideal candidate to take up for procedure. I told that not less than 55, but there are many patients at 48, 50s also having a severe deformities. So then we definitely take up for the procedure.
What are the advantages of robotic assisted surgery?
Sir?
Robotic assisted surgery.
Yes, sir. Robotic assisted surgeries are new concept now. It has come within last 1 year. So it gives a early mobility of the patient, but if you see on the long-term studies, that is at around 2 years of follow-ups, both have equally good results. There is no difference in the results at the end of 2 years.
What is the percentage of implant allergies?
Very less, sir. We have hardly out of 100%, you see less than 2 to 3% of the patients that are going for an allergy. That is with the cobalt and chromium, not with the titanium and the zirconium that we see. So if the patient has an allergy, definitely we need to go for a titanium. Titanium allergies are there, but very least that is there in this world right now.
Do you have any methods to decide preoperatively regarding metal allergy?
Metal allergies, we can ask for the silver, that is if they are wearing any implants previously, we can ask them if there is any blackening that is happening to them, or anything if they have any other atopy that is running in their family. like asthma or anything, we can have a skin test that is done from the dermatology department from the different metals. So that can be done, sir.
So, okay, thank
If you go for desensitization,
Yes, sir.
desensitization to the allergy.
No, sir, that is not done. The only thing what we can advise them is go for a titanium implants, but with a caution that too. But titanium allergies are very rare.
So, audience, please be ready to ask a question.
Yes, sir.
So, before that, do you advise the surgery before the patient develops severe deformity?
No, sir, not at all. Like only if it is grade 3 and grade 4, complete restriction of the movements, and also there are chances that at the age of 55 or 56, if the patient wants to go for a single surgery, I don't want any other surgeries in my life, and you get an MRI, all the meniscus are gone, and ACL is gone, worn out, and articular surface is worn out, then only advice we can give him is knee replacement. If his ACL is sustaining, the chances that unicondylar knee orthoplasty can be done.
Which is the friendly approach for the surgeon for surgery?
For us is medial parapatellar approach, sir. That is most commonest one, sir. Because everyone are used to doing orthotomies in the things. So finally we have some case discussions. So this is gross varus deformity, almost subluxated knee. Okay. And she came literally walking with the help of walker to us, and she is unable to walk. You can see that she holds the chairs and she walks. After giving few analgesics, she is able to walk. You can see she is not able to flex her knee at all. Okay. So this is how we managed it. Perfectly balanced knee, and we went with the max freedom implants. No notching, and all the osteophytes that were there, that were removed, all the joint line is restored perfectly, and this is at the end of 4th day of her follow-up. She is able to walk independently, and we achieved the flexion of at around 60 degrees on day 3 to day 4, and this is at the end of 1 month. She has come for follow-up. She can do all her activities, and all her routine activities are restored with flexion up to, she is doing really good with 90 degrees, and she is able to walk independently, and you can observe that before that she used to keep her right knee very stiff. Now she is able to do all her activities and doing a good flexion. Okay. So this is the patient from Prostate. She came to me like after going to many doctors, rounding about 9 years. She was very scared of getting a knee replacement done. So, which led to her right knee is quite deformed, and so we can see that there are multiple osteophytes that is there. So patient wanted, I need both knees. Left knee I did not advise them. We thought we'll wait, but the patient is like, no sir, we will want to get that one shot. But then we did it. So this is how she was walking, and both knees you can see that there is a FFDs is there. Right knee is much more affected than the left. So this is how we managed it, and right knee is balanced well on the left knee, and this is just at the day of 8th day of follow-up. She is able to do literally right knee is at 100 degrees, which is a fantabulous results we got. And left knee also she was complaining little bit pain, but yeah, still she is doing good. This is her son sending me the video on the left side on the when she went to physiotherapy. I never advised for independent walking on day 7. This is herself, she did. She was very comfortable going for bilateral, means without your walker. Usually the bilateral knee, once you do it, the recovery is speedier, because one side the pain is very less and patient feels very comfortable to walk. Only the wound pain will be there. Other than that, she is able to do good. This is her coming on the staples remote. She is able to walk complete, means without pain. And all her cycling, everything I started doing early comparatively. So she is doing really good. So this is one more patient. She is from Chitradurga only. We did it in Bifurcation. She has bilateral ONE, you can see. But only concern was for us was the right side. There's you can see there is a condyle, there is little deficiency. I thought like maybe we need to have arguments or something like that. It was also a long-standing case. And also the medial aspect, you can see the osteophytes are there on the MCL. These osteophytes are quite dangerous. Like if you try to remove them without seeing anything, you may lose MCL. Okay, so whenever you see these kind of things, make sure that you go in the OT room thinking that like very cautiously you should remove the osteophytes on the MCL. Okay. So these are the things which we have. And this is the post-operative X-ray, and all the osteophytes, everything removed, we could achieve in the OT itself around 100 to 110 degrees, and very good flexion and extension gaps. And this is the one, she came to me, this is around 2 years old case. Okay, she had achieved all the things. She never came back to me after about 2nd or 3rd month of her follow-up. I had to call her to get these videos. So she is able to do all her activities. She has traveled all over India right now for all the arms and all. So yeah, the last, so as you asked, like what's new in TKR is we have all the robots now. So there are 2 things. One is like we have a semi-automatic and fully automatic ones. So the JJ and that is Johnson & Johnson, they have come up with Rosa, and Stryker with Mako, and also Cubis from Merrill. So these are the different robots. They are depending upon the how they do it. They are classified into semi-automatic and fully automatic. The fully automatic once you feed them the CT scan, they and also the points that is asked by the system, they will cut the bones after you do an exposure. So that's a fully automatic ones. The semi-automatic ones are the one where you cut the bones with the haptic feedback on your hands. So that will be under your control. Okay, and few of them are like accelerometer based knee replacement, that is ortho-align system that is there. So this one will give you an edge to compare to you. So it gives a perfect resection angles. So at the end of the day, there was a meta-analysis done to complete the follow-up by these guys, Alzaran. So he did a randomized meta-analysis of all the studies for all. At the end of 2 years of follow-up, there is no difference of outcome. So there is no difference as such. Only advantage to that of the robot is early mobilization of the patients that is there in the current scenario. So thank you all.
It was a nice presentation by Dr. Ashish. So
Thanks.
To complete, he is practicing at Bifurcation Medical College Hospital and Santosh Clinic, Chitradurga. So this is we thank him immensely for the nice presentation, the first presentation of the conference.
Yes, sir.
So we congratulate you.
Thank you, sir. Thanks one and all. And I thank Angioplasty sir and all the delegates from the Compost to giving an opportunity to present all the work we have done. And I also thank the Dean and our MS sir and the HODs to allow us to do all this kind of surgeries and providing us the amazing OTs in the OR, and also the things that have been provided to us. We have been given orthoscopies and all the instruments. So thanks one and all. Thanks again.
Thank you for that enlightening session, sir. May I now request the chairpersons to kindly do the honors of felicitating the speaker.
request Dr. Rajesh MS, Medical Superintendent, Basveshwara Medical College and Hospital, Chitradurga, to felicitate our chairpersons. Thank you all.
Moving ahead, it's time for the heart of the matter. The next session brings us cardiology updates.
We welcome our speaker, Dr. Karthik RS from Indiana Heart Center, Chitradurga. This session will be chaired by Dr. Mukund Rao, Senior Physician, Chitradurga, Dr. H.S. Shivarna, Holalkere IMA President, Dr. Manjunath C.H., Holalkere IMA Secretary, and Dr. Vinay C. Sachin, Holalkere IMA Treasurer. I request the chairpersons to kindly introduce the speaker by reading his CV.
Good morning, everybody. Karthik is a very dynamic cardiologist. I know him from his 40s days. And is a consultant interventional cardiologist at Indian Hospital and Krishna Multi-Speciality Nursing Home, Chitradurga. He has got 10 years of experience and has performed more than 10,000 coronary angiographies and angioplasties. He is skilled in advanced techniques such as IVUS, OCT, FER, FR, rotoablation, and C2 interventions, and is internationally trained in complex procedures. He also specializes in structural cardiology, including TAVI, Tibia, and EVR. He completed his MBBS from Sri B.M. Patil Medical College, Jaipur, followed by MD General Medicine and DNB in Cardiology. He has worked in Aster Hospital and Fortis Hospital, Bangalore, and earlier served as assistant professor at Sri Basveshwara Medical College, Chitradurga. Karthik has published research on CRP, diabetes, and presented at major conferences such as CSI and EPICA, contributed to both academic and clinical cardiology. Over to Dr. Karthik.
happy with what we are doing. So with that, I'll begin my presentation. So on to the my talk will be statistics, cardiology status before and now. What's a cardiac emergency? What do we do? Coronary artery disease forms majority of our cardiac emergencies. Details would be the same. Other interventions also are done here, and what's the field to scope? Typical coronary artery disease, plaque, rupture, and clot formation. Acute capillary syndromes, classified as STEMIs and NSTEMIs. This is a chest pain protocol. I think most of them will be aware of this. Probably the whole this one will be that protocols are there for a reason. Say any hospital, any clinic or a nursing home, I think should follow a protocol where ECGs are kind of taken care of within the required time and classify them as acute coronary syndrome or not, and depending on that we can kind of go about it. Something we always like to talk about is dosing protocols of various antiplatelet drugs. There are a lot of myths about it, so we want everybody to know that aspirin 350, aspirin will be Dispirin if it is 350, can be given directly, probably in a glass of water works. If it is enteric-coated aspirin, it has to be chewed or at a kind of crush, and then only it should be given. Clopidogrel often not the go-to strategy. No, we are preferring Inaugural or Prasugrel in the expected doses. So again, various antiplatelet drugs in various scenarios. So this is a strategy in Chitradurga. So from 2024 onwards, I kind of put up this for reference. I think we are doing reasonable number of cases here. Every month we are slightly on the this one. So last month we have done some 36 angios and 88 plasties. So intervention cases, I would not like to kind of present a lot of things what has kind of happened anywhere else. We want to present whatever we have done here. So this is for IMA forum, so we like to dial it down. So 30 years old male school teacher presented with chest pain for 1 hour, diagnosis anterior MI. PTCA is angioplasty. So percutaneous transcatheter coronary angioplasty. So we will be using some of these short forms. I've been told that a lot of people don't understand them, but we would like to clarify it now. That see, there are 3 coronary arteries. Technically 2, left side we divide into 2 more. So left coronary artery divides into left anterior descending, that is LAD, and left circumflex artery. So these are 2 branches, and multiple smaller branches we'll be talking about in later on. So right coronary artery is a single artery, that's RCA. So usually I'll be using these short forms. Please bear with me. So this guy is a smoker, apparently not known to the family. Eventually ended up having an anterior MI, and primary PTC was done with good results. I'd like to kind of show that this one. This is your simple garden variety angioplasty. So LAD, you can see there is a thrombotic occlusion in the osteoproximal segment. So eventually stented, and this is your end result. Multivessel PTCS. So in a patient with cardiogenic shock, 60 years old patient with chest pain for 2 hours, BP was hardly 60 on arrival to the ER. In spite of inotropes, his BP was picking up to 90, and we had to kind of convince them to kind of go about for primary angioplasty. So this was his angiogram. You can again see that LAD, there is a near total occlusion, and there is a lesion in L6 as well. So LAD was kind of angioplasty was done. Then we had to take up L6 as well, because this is a case of cardiogenic shock where we like to do multiple angioplasties to give the best outcomes possible. So this was his result. I think he did have a RCA lesion as well, which we kind of tackled in the same scenario. Something which is not done routinely, only cardiogenic shocks we tend to do it. So here there's a middle-aged patient, bank manager by profession, previously had PTCS done to LAD twice actually, and quite compliant to medication, but whenever he was never on clopidogrel to begin with. See, we have to notice that why is clopidogrel gone out of favor is because there has been documented this one that 0.4 to 0.6% of our patients have some resistance to clopidogrel. So in India, obviously our trials are not that great where we have not documented exact numbers, but this is what general acceptable this one is. So this is something which we are suspected in this guy. So he again kind of came in, LAD was occluded, LAD stent was occluded, had stent thrombosis. So we had to, this is the LAD stent, this one which is occluded. PTC was done. Come back to this. Yeah. PTC was done. And this is the next one. LAD result was good, then we had to do the LCX PTC as well, LCX to Y PTC as well in his case. We have started him on Tibial. I think Tibial 90 mg BD was given for 1 year. Then we had to give him this guy. So Tibial 90 mg BD was given, and then we have given 60 mg BD for 1 more year. And it has been almost 2.5 years of follow-up. As of now, no recurrent stent thrombosis or no further issues. He did have lower GA bleed once, which was taken care of, and he is kind of active doing his activities well. So something called as thrombus aspiration. There's a lot of debate about this. There's a lot of controversy about this, telling that is it actually essential? Should we do it? But whenever you see a large thrombus burden, we tend to do it. So this is your thrombotic lesion, and that is the end result, the next image. Yeah, this is the thrombus, and this is how the thrombus has been taken out. There's a specific catheter for this. We go in, take out the thrombus, eventually the thrombus has been documented as such. So this was how it is, and the right frame is showing you the thrombus aspiration with a single dot. There are various catheters for it now. Previously we had 1 or 2, now we have multiple companies coming up with multiple catheters. So eventually it was stent with post that. This is your end. There is some thrombus there as well, which will be taken care of by geometric reasons. Then comes in the bifurcation angioplasties. These are a bit more difficult. We did come up with specific stents for it where they were kind of taking care of both the vessels, but unfortunately the results were not that great, and most of the companies did stop doing that because results were not that great. And there are various strategies. Some of these cases have been done here as well. This is left main in the sense LAD proximal, where we kind of were tackling this one where 2 stents were put in the LAD. Post that, diagonal was a significant stenosis, post balloon dilatation, that is the result. So then we had to put in a stent there. So this is a guide extension catheter which is helping us with the stent. And the second frame shows the result. So this is non-left main bifurcation, a bit more non-risky compared to this one. Elderly population, 83. See, our oldest patient here is 95 years old female. I think 2 years before we had done the angioplasty. As of now, she is kind of mobile and doing her activities. So anything above 75 elderly population is not very unusual for us cardiologists, because our interventions are very minimal, where blood loss is less, and compared to all this surgical risk, interventional risks are very much less for cardiology because of the reduced blood loss. So in this, LV was 25%. Coronary angiography showed critical left main bifurcation disease. Advised high risk left main distal bifurcation plasty. Daughter of the patient had a discussion. This guy, the whole this one was previously his wife had an angioplasty exactly 1.5 years before with us. That time we we did speak to him about at least kind of getting himself checked. He did not do that. I think she was a chronic COPD patient, so her husband. So eventually the wife died because of COPD. Then the family could arrange some money to kind of take care of him. So this is how it was. So you can see the left main bifurcation. His LV was just 25. So when that low LV function, left main bifurcation, you always are a bit skeptical. We did discuss to them about everything in detail. They were waiting for a procedure and they just wanted to go ahead with it for the sake of his improvement per se. So you can see the right side frame where we put in a left main stent. And in this frame we are trying to tackle the LCs. So you can see the right frame is showing you the kissing balloon inflation. Usually in bifurcation lesions, the most important thing is kissing balloon inflation so that the expansion is proper. And this is your end result. So he's been also in follow-up for almost 2.5 years now. He stays in Bangalore now, but for follow-ups he is kind of very particular and very regularly coming in here. His LV has improved to somewhere around 45 now. In last check, maybe 1 month before, 45. Left main PTACS, previously we were kind of very ridiculous in sending these cases to surgeons. But of late, with advances in technology, with results kind of being shown where our long-term results are good, we end up doing left main PTCS as well. This is a simple left main PTCA where the region is from left main, extending it to LAD. The whole deal about left main is that when you are doing the angioplasty, you are putting a stent from left main to LAD. So then the problem with LCX will be there. If at all it gets occluded, you have to have a backup strategy. So this was the result of the patient luckily. LCX, there are some this one stenosis, some narrowing, but nothing much to kind of warrant a stent there as well. So this is a 68-year-old female presented with chest pain, class 4, started an NIV diuretics, typical of problem as an ADHF with ref. Pulmonary angiography was done, which showed distal left main 95% stenosis. We ended up doing her PTCA, but I think this patient was referred by Mukund Rao as well. So her hemoglobin was 5.4 actually. This was post angioplasty. She had a left main to LAD stent done. You can see the stent going in the right frame. Yeah. There is the stent going in. And there is a stent implantation. This is the end result. She is doing well as of now. She had some lower GI bleed for which gastroenterologist had to kind of do certain procedure to fix it. And after that, there were no further issues. This is an 88-year-old male presented with chest pain from 6 hours, diagnosed with acute renal syndrome, NSTEMI, had pulmonary edema, settled in some time. They had a slightly on the higher side. So post that, he was taken for CAG, which showed ostial left main 90% stenosis. The whole idea of showing this is that only ostial, this one was occluded. There is a problem, proper disease in ostium, 90% ostium. Other than that, he had significant disease in all the other arteries. We never touched anything, only ostial left main, whatever was required, a single stent was placed with good result. So it's not as if you have to do everything possible. What is required at that point of time, you do it and leave it for another day. You can always come back and fight the battle. Post-CABG interventions, because we had worked in our high-end centers where CABGs are quite common. Obviously, once the CABGs are done, there are some of these patients who do come back for post-CABG interventions as well. Because 95% of our patients, once you do a procedure, they don't come back to you with any further problems. They are just on follow-up and you don't have to do anything much. But you definitely have 5% of the patients who come back to you recurrently because they are non-compliant with medications, somebody has not kind of, in the sense that family is not supporting, the cost issue. There's so many factors which will be there. Their diabetes will not be taken care, they are not strict with their diet, the exercise is not there. So with all these factors, they do come back. So this 74 years old guy had Rheuma to LAD graft, Rheuma to RCA, presented with NSTEMI. CAG with graft study showed left main to LCX, had right stenosis, Rheuma to LAD and Rheuma to RCA being patent. We had to just plan because LAD is a protected vessel. So you can see the left main is very tight, and you can see extending into LCX. This is Rheuma short right side. It is kind of connected to the RCA. Rheuma is right internal memory artery. So this patient, we had, go back. The second image, the second image is our stent implantation. Most of the CABG patients will have very badly calcified disease. So you have to have some backup plan if at all you will not be able to deliver stents, calcium modification tools, and this is your end result. So this is one patient, probably we will be presenting this in one of your national forums as well. 15 years old patient, CABG 15 years back, smoker, continues to smoke, diabetic hypertensive, presented with anti-roll MI. CAG with graft study showed focal lesion in the distal LAD with thrombus. He had VT, he had arrest, he had all sorts of issues while doing. So this is your Lima graft which had a radial Y. So they have connected Lima to LAD. You can see there is a focal disease here. Pointer will be there. Please, sir. In this, okay. Oh, is it? Okay, sorry. It's okay, that's okay. So there is one LAD focal stenosis was there. So on this, in the second frame, you can kind of appreciate it better. So this guy, actually we took a guide catheter. So you can see the whole, this one, we went through his Lima, left internal memory to LAD graft. A lot of times when you are kind of student or when you are even reasonably experienced, people will tell you not to touch these patients. So you can see the Lima graft, how tortuous it is, and we had to go in all the way into LAD. But the problem here was that we were not able to go into the whole LAD because our wires were not going through enough. So what we had to do is, whatever top you are seeing, in the next image if you see, we have gone through inside the Lima with a catheter. So there is always a risk of Lima tearing off. So that's how it was. We were able to do a balloon dilatation of this, pain relieved, symptoms improved, but he did have a VT and he had arrested. 5 minutes downtime, recovered on some small doses of inotropes. Eventually we came back. We were not able to put a stent in this. So then we had to kind of go back and do something called as FDG PET, so as to see what's his viability, is there any inducible ischemia in the territory. Once all of that was done, it came back that there is apical territory, hardly 1% there is some infarction. Other than that, the whole artery was viable and there is no inducible ischemia. So we left him there and he's doing well. He was 1 year, 3-4 months for retirement and eventually retired from government service. Elderly patients, post-CABG. So this is one of our doctors. So post-CABG, but luckily his disease was in the RCA, so not in the graft or anything per se. So he had a distal RCA disease. You can see it in the left, this one where he had a distal RCA disease. But to reach the distal RCA, we had to first put a stent in the proximal segment of the RCA where it was very calcified. And then eventually we could kind of reach there and put a stent into the distal RCA. And this is the end result. So this was one of our oldest patients done in Chitradurga. 93 years old lady, presented with inferior MI, calcified vessels. Distal RCA was balloon dilated, but stent could not be tracked down. So we had to use something called as guide extension catheter in this. So proximally, a lot of this one was there where we had to kind of stent the proximal segments, do all this one to at least get into the distal segment per se. you can see the second image is of the stent in the distal segment. So the next, yeah, this is the stent in the distal segment eventually with after all this circus. So this is the end result. She is 96 now, 95 and a half, and doing her own activities. Another case where we had to use guide extension catheters, so stent was not tracking down again, the RCA where support is less, so that was where. Complications are technically part of your, this one where any treatment eventually ends up with complications. See, one of the great cardiologists had kind of told Dr. Anthony Colombo that if you're not having complications in your practice, that means to say you're not doing enough cases. So if you are doing interventions, you will end up with complications is what the instruction was. So this is a female patient, came in for STEMI, LAD, significant disease was there. We had kind of thought it is a straightforward case where we end up stenting it, and we took the adequate size stent and eventually stented. And the patient had perforation. This is class 4, type 4. So you can see in the second image, there is some extravasation into the pericardium. So eventually she kind of collapsed. Then we had to kind of take a covered stent, put in pericardiocentesis catheter, which is a one catheter which is up and above. So we had to kind of do emergency pericardiocentesis and salvage her. This patient also is on follow-up, and actually she is doing well. A lot of times we would have heard that covered stents have significant degree of restenosis, but as of now she is doing well. It has been more than 2 years, and as of now she is doing well at least. So coming to some of the latest developments, see optical coherence tomography or coronary imaging. See, we have seen the coronary from outside, say how it looks, say usually white and black. So you see the lesion, you see the severity, and kind of go ahead and do whatever is required. But optical coherence tomography is a tool which was used in ophthalmology probably before. Then it came into coronary, where you can go inside the coronary. The whole problem with our coronary is that there is blood. So it is not colorless. So if it is colorless, it would have made our life very much easier. But it is blood where you can't see anything. Only with these tools you will be able to see it from inside, like a cave. So 60 years old female presented with SVT, AVNRT, reverted with adenosine ER, first top was 68, admitted to CCU, repeat drop was done, which after 6 hours it was 132. Advised CAG, which showed ostial LAD and LCX tight stenosis. Offered CABG versus left main bifurcation PTCA. Family was educated, did discuss with us what best can be done, and eventually we told them that OCT assisted PTCA to be done with something called as DK technique. So with a good result. So this we had advised. Yeah, I'll show the images first, and then we'll go ahead and talk about the other things. So if you see, she had distal left main bifurcation gone in. We imaged it with an OCT catheter. That's the right side. The multiple dots are there. That is an OCT catheter. We did go ahead and image it, and we did image the LCX, left main to LCX as well, just to see how the bifurcation is. And eventually we had to stent and DK crush. So we went from left main to LCX first, then left main to LAD. The whole thing was done, and eventually this is the result. So now we go back. So this is the OCT catheter. You can see that is a catheter, that red, whatever light you are seeing, that is the imaging module. So that is the this one, Abbott, I think Abbott has this, so OptiView. So in that, you can see this is the catheter. This actually goes into, inside the coronary artery and images. This is how the image looks. I'll show it in detail in next this one. And below part of that image, you can see how a stent is. If it is white, that means to say expansion is good, apposition is good. If it is red, that means to say there is some malapposition or under expansion in the territory. And in the right, one more image is there where you can see white dots. That is your stent struts. So you can see this one in 3D. So this is how the console is. This is the catheter, this is the console, and this is this is your image. So to get this to Chitradurga was a this one where they had to kind of had a lot of issue with mobility. So then on a Sunday, because other people in Bangalore and all will not be operating on Sunday, so on Sunday we could kind of get it here. So this was shown to you. I'll show the whole image next. So this is how it looks. Above, you can see a 360 degree, you can go through, so there is a flyby. Yeah, it will play like this. So we come from distal to proximal. As you come to proximal, you can slowly see the lesions. So there's some narrowing and there is significant narrowing there before the bifurcation. Then we took the same run from LCX. So you can see the whole coronary from inside. Okay. So then, once the stent has been implanted, this is our image. This is how the stent looks from inside. Can you see the reverberations? So that's how your stent looks from inside. So once this is done, we had to optimize and post-NC. This is how the result is. You can see below there are some red dots in at the origin of LCX. So that we had to fix later. So that's how the image is. You can see your stent, how you have expanded in 3D view. So you can kind of see where your this one wires have gone, we have gone through distal bifurcation or not, everything can be documented in this. So this is how your flyby is. You can see the whole thing from inside. That was a distal stent and this is a proximal stent. This is of one more patient, not the same one. So you can see each thread. So now we are coming to an era of stentless angioplasties or drug-eluting balloons. So this is where metal was always our constraining factor, where a lot of times when you put stents, you always see that the stent artery would have grown post your stenting. So there will be remodeling and eventually narrowing of your artery, where stent is the only limiting factor, the other part of the artery has grown. So slowly there are data coming in where only balloons which are drug coated can be used in these smaller lesions. At least the guideline right now is that in a lesion which is in a vessel which is less than 3.5, we can use drug-eluting balloons. It did really well in stent thrombosis cases where we did not have to put one more lining of a stent. We can just use a drug-eluting balloon and do the angioplasty and get away with it. Then it came in for smaller vessels, distal vessels. So it is doing well. Still more data is kind of required for proximal and larger vessels as well. This is a 65-year-old patient. Recently we did this case 1.5 months before. Hypertensive, diabetic, dyslipidemia, obesity, severe OSA, CPAP. So depression, insomnia, all the risk factors possible were there. He is a retired educational luminary. He is an ex-principal as well. He is an author of multiple books. So he had unstable angina, preserved ejection fraction, angina and breathlessness, which is limiting. Class 3 symptoms were there for a week. So advice CABG versus multivessel PTCA, we do calculate something called a syntax scores. Previously there was syntax 1 score, now we have syntax 2 score, where we have risk of 4-year mortality for PTCA, that is stenting, and risk of 4-year mortality for CABG. So his scores for PTCA was 36.5, that means to say mortality, 4-year mortality of 11.4, versus CABG mortality was somewhere around 15. So we discussed with him and they wanted to take an opinion from a CTV surgeon as well. So they went ahead, CTV surgeon spoke to us telling that, agreed, there is triple vessel disease, you want to do something. What next was the question. So because distal vessels where there is disease, proximal vessels if there is disease and CABG has to be done, they will be very happy to do it because distal vessels are good, they will put a good graft and they will get away with it. But this guy had significant distal disease as well. So you can see LCX in this image, where LCX is hardly flowing, there is almost near total occlusion of LCX and a very tortuous LCX. And LAD, yeah, this is an image where you can kind of make out. So LAD, proximal there is disease, mid there is very tight disease, after that till the apex, there is multiple lesions even in the apex. So this is why the surgeons were scared that we may end up putting a stent in somewhere on the mid to distal segment, but result won't be great. So then all the discussions happened. Eventually we did discuss with them and told that probably drug-eluting balloons are the way to go, not for the proximal segments. Proximal to mid we plan to put 2 stents, and the apical segment will do a drug-eluting balloon, and LCX also will do a drug-eluting balloon alone. So this was the distal stent which was kind of put in. Then we put a proximal stent. You can see the deployment of proximal stent here. So once this was done, you can see that only the apex part is not is the one left. See, usually in apex we don't put in stents because long-term restenosis rates are very high. So here we took something called as a guide extension catheter. You can see a small this one which is coming in, and next the balloon comes in. The whole idea is that you should take this drug-eluting balloon within 30 seconds from outside to wherever it is supposed to reach, because the drug delivery, there is some issues where there is some loss if you kind of leave it more time in that, with leave it more time tracking it down. So this is the drug-eluting balloon. You can see we have to keep it inflated for at least 45 to 60 seconds. We did everything as instructed. So whatever guideline was there, it was followed, and you can see the whole inflation. Luckily that guy tolerated it well. A lot of them don't tolerate long balloon inflations where you have to kind of deflate and again do it. So it was done, and this is your end result. So TIMI-3 flow. And as planned, this is the L6, where again the same procedure was followed, where a guide extension catheter was taken, along with that drug-eluting balloon was delivered. So we expand this. LCX, we have not put any stents there, only the drug-eluting balloon. So once that is done, you can see the result. Now LCX is flowing. There is some, this one there in the proximal segments, but we always expect that to grow and have no restenosis. Probably if we recheck the angiogram at the end of 3 months, we'll be able to kind of find a better picture. This guy eventually ended up getting an RCA stent as well after 48 hours. So the whole, this one was completed and sent home. So luckily, because of drug-eluting balloons, he required 3 stents and 2 drug-eluting balloons to complete the procedure. So this is the drug-eluting balloon mosaic. So it's actually a bit more expensive than our stents, but in the longer run may be beneficial. You can see the this one drug-eluting balloon in the right frame, where drug is coated on top of the balloon. You are not supposed to touch it. So permanent pacemakers are also being done here. So this is your typical permanent pacemaker wound. So hardly we take 4-5 centimeters of cut, done in local anesthesia. This is done here. First frame you are able to see a temporary pacemaker there. Then eventually permanent pacemaker has been put and closed. Pericardiocentesis. In some of these complications we did, and this one pericardiocentesis were done, but this was an interesting case where very rare organism was found out. You can see pericardial effusion, how the heart is getting compressed by fluid around it. In the right picture you will be able to see it better. Heart is hardly able to contract. So once this was eventually Burkholderia cepacia was found out. In a non-immunocompromised patient, this is one of the very rare entities. And post your pericardiocentesis, this is a 1 month result. At the end of 1 month, you can see the heart fully expanded and there is no further fluids. Way forward, yeah, there are a lot of things to be done here because everything we do here is new. So whatever you do here, and it kind of ends up being first time in Chitradurga kind of thing. So it is a bit like that. So we had kind of started TE program here for all these valvular structural cases. AHD closures are being planned. As of now, we are not yet done here. And catheter-based TAVI towers can be planned, as I am already trained in TAVIs and towers. So cardiology is very fast growing branch with advances being developed every day. Need to grow with global advances to give best cardiology care to our city in particular, so that Chitradurga cardiology is also seen in national and international levels. Luckily, there is a beginning. I have been invited for a national conference as a faculty, recognize that somebody is practicing in Chitradurga rather than just an individual achievement alone. Thank you, everyone.
Thank you, Dr. Karthik.
Any questions? I would be happy to answer.
Thank you, Dr. Karthik. I see you as a very successful cardiologist in Bangalore at major hospitals like Fortis and Aster hospitals. But you decided to come over to Chitradurga, and I think Chitradurga is lucky to have your expertise, and Chitradurga people are very lucky.
Thank you.
So I have a few doubts, Here, have you come across any stent thrombus?
Sir?
Stent thrombus.
Yes, sir. We do come across. Yeah, the problem is that stent thrombosis.
Here, in your experience in Chitradurga.
So stent thrombosis we see here very, very frequently compared to Bangalore. Basically, the issue is that stent thrombosis in Bangalore is very rare, obviously for various reasons. But here in Chitradurga, we do all these scheme cases. There are a lot of issues where this one is like cost of the medicines is the whole this one. Whatever the government has kind of struggled to make it cheaper or more economical for patients, still a lot of people end up stopping it. See, in 1 year, if you kind of stop dual antiplatelets, you will end up with stent thrombosis. That's the problem. We do see it very, very frequently here. So what we do is, one, stent thrombosis is there. The whole idea is one drug-eluting balloon or at least a plain balloon. If not, then comes in your stent and to talk to them about drug compliance. If they are very non-compliant, they are not going to be, again, regular with medications, then it makes it very difficult for us. Obviously, there have been latest this one where there are few stents where only 1 month DAPT indication is there. 2 antiplatelets have to be taken only for 1 month. After that, you can take single antiplatelet. But the problem is those stents are expensive. The stents, what we normally do in scheme cases are our regular drug-eluting stents, which don't have a single month DAPT indication. So that's why we end up seeing it. Only this one will be if they are compliant to medications. Chances of stent thrombosis is extremely low. But if they are not compliant, they are not taking medications regularly, then definitely we see it. Not very unusual, sir.
Any role of intracoronary thrombolytics in such cases?
Intracoronary thrombolytics, yes, sir. But the whole point is if they are ready to intervene. The problem here is that we see this in low socioeconomic status where we have done it in BPL or something. And second time, if we have to intervene, then a lot of times BPL approval doesn't come. So they end up not doing intervention at all, and we give IV, our thrombolytics. And lot of them will have resolution if they have come acutely, where there is a problem with stent, where there is a problem with thrombus, nothing with the stent. So that is resolved. But see the whole, this one about if at all they are taking medications and still they have stent thrombosis, then we suspect some technical issues. Distal edge dissections, under expansions, all of these things will be there, where again coronary imaging is mandated to do so that find out any technical problems and correct it. But most of the times here, the problem is with drug. 1 month, 2 months, they would have left medications and come. So, but with if the drug compliance is good, chances are very less. And with ticagrelor or prasugrel, stent thrombosis is extremely low.
So in our times, we are told that in single vessel disease or two vessel disease, we will go for PTCI. And if it is 3 vessel disease, the only CABG is the alternative. What is the latest scenario about that?
Sir, the thing is that we do calculate what is called a syntax score and eventually come about how bad the disease is. See, to simplify it, if it is not a diffuse disease where everything is diseased, if it is more focal where you can fix, see the idea of putting stent is to put from normal segment to normal segments with stenosis in between. So if you can do that, then stents do very well. You put 2 stents, you put 3 stents, you put 4 stents, no problem. There's one of our patients, we put 7 stents, 2 from outside, 5 here. So even day before we have put a patient on 5 stents. So but the whole idea is how good a result can you get? If at all it's a diffused disease vessel where you don't know where to start and where to end with a stent, doesn't make much sense. Usually in the syntax scoring also, that's what has been told, that if it is diffuse disease where your results are not going to be great, then still bypass is preferred. But the guideline to bypass has become very, very, this one no. Hardly this one is that if at all you are not able to put a stent, if at all you are not able to give a good result with a stent, then bypass. Or else most of them stents. Where stent technology is improved, your results are good, your medications are good, then stents are the go-to. But in a month, say probably if we do 90 to 100 angioplasties, 1 to 2, at the maximum 3 patients go for bypass, where we could not put a stent. Then definitely required. So.
Okay. One school of thought is there, like our Reverend BM Day. After MI, there's no, and if the patient survives, there is no point in going for any PTC, any interventions, because suppose in an anterior wall infarction, LAD is the culprit, damage is already done. There is no point in going for angioplasty for that person. How do you evaluate? How do your opinion?
So the whole, this one is, if LAD is infarcted, eventually, if the patient comes to you probably after 1 day or 2 days, then the whole idea is viability. If at all viability is there, you do an angioplasty, it helps the patient. If viability is not there, that area is thinned out, then whatever you do, angioplasty is basically cosmetic. It doesn't really help.
Yes,
but the whole idea is the damage is already done. But lot of these patients, there is some retrograde filling or there is some flow, because body tries to dissolve clots most of the time. So there is some flow. If flow is there, eventually when you do an angiogram, in these cases, say after 48 hours, a patient comes to us. There is still flow. That means to say the area is usually viable. Okay? So if we suspect that viability is not that great, then they do something called as a cardiac MRI will be done or PET scans will be done to document viability. If viability is there, yes, no problem. If viability is not there, then it doesn't help.
But can you evaluate the viability? Like thallium studies and all that, in every case, is it possible?
No, sir. In viability is done only when we feel that it is not viable to begin with, in the sense that that area is thinned out. There is already a scar which is seen, and then usually it is not viable, then we evaluate for it. And depending on that, we take a call. Second, the whole issue comes in is multi-vessel disease, anterior wall MI, LCX, RCA, we don't know the status. Do an angiogram, you see that there is 90% block in those 2 arteries. Then we check for viability to see, should we kind of send him for bypass or should we stent these 2 arteries and get away with it. So then the viability question comes, and viability is not simple. The problem is that it has to kind of go to one of these centers in Bangalore, get the viability, come back. A lot of them won't agree. So that's an issue. Simple, our own this one is that in echo, a lot of times you will be able to at least assess approximately if the areas are viable or not. So that gives us some clue.
Okay, in some cases, what we have found is the enzymes are elevated, but ECG will be normal. In some other cases, ECG will be very positive, but enzymes will not be raised. If enzymes are raised and ECG is normal, or in such cases, what is the method we should follow?
Sir, enzymes are raised, then we have to look for any other cause for the enzyme rise, first thing, to rule out false positive cases. And then if at all it is not, it is still true positive, then go ahead and do an angiogram, see if there is a problem or not. So your straightforward answer. So enzymes are raised because of other reasons, say some septicemia, some other issues, myocarditis. So then you don't have to technically do much. So, and a lot of times the other way around, where ECG changes are there or symptoms are there, but enzymes are kind of not raised.
Yes.
See, I remember a patient in Fortis. So, yeah, multiple times enzymes were done, normal. Echo was done, normal. So, he actually insisted telling that, no, I want angiogram to be done. So, eventually the consultant got fed up. He told, okay, do his angiogram. Yeah, this one distal, LAD, proximal, and 90% stenosis. So this is how it is. So clinical suspicion makes the most sense. So if clinical suspicion is there, always go ahead and do this. Second, LCX territory. Lot of time LCX occlusions, LCX narrowing may have enzymes rise, ECG, no changes whatsoever. So that's one thing always we have to suspect.
Yeah. Respected
Thank you.
chairpersons, due to shortage of time, can we continue the discussion during the tea time or lunch time? Yeah, okay,
Only
sir.
one comment,
One
sir.
last question.
I'm very happy, Dr. Karthik, you are doing wonderful job. Actually handling here in left main, thrombus lesion, bifurcation lesions, reduced LV function is 25%. It's not that easy. Angioplasty looks very simple when we have succeeded the case. Actually, that 1 minute will be so crucial. For example, when you have seen the perforation, usually it occurs when there is the calcium. Passing a stent is not easy. Covered stent to take, it will be little larger than the usual stent. In that 1 second, if you cannot succeed, you are going to lose the patient. So you have done a wonderful job. I congratulate you.
Thanks.
It's easy to work in a places like Jayadeva because you don't look at the money or any such thing. In a private sector, it is not that easy. So you are doing a wonderful job. Thank you very much.
Thanks, sir.
Thank you for the highly informative session, sir. I request the chairpersons to kindly do the honors of felicitating the speaker.
Thank you all. I now request Dr. G.T. Tippareddy, sir, Senior Dermatologist, to kindly hand over a token of appreciation for our chairpersons. Next, we dive into a field that is advancing every single day, and that is oncology.
Our distinguished speakers are Dr. Prashant Ganesh, Urologist, and Dr. Anand Kumar K, Hemato-Oncology and Bone Marrow Transplant Specialist from Spurs Hospital. This session will be chaired by Dr. S.T. Yavagal Sir, HOD Department of Cardiology and Medical Superintendent, Sri Jayadeva Institute of Cardiovascular Sciences, Bangalore, and Dr. G.T. Tippareddy Sir, Senior Dermatologist, Chitradurga, and by Dr. T.K. Srinivas Shetty Sir, a well-known pathologist who works in Vasavi Lab and Vasavi Blood Bank, Chitradurga. I request the chairpersons to kindly introduce the speaker by reading their CV.
Can you connect? It's popping out. It's not.
can directly.
Dear friends, we have got a very interesting session ahead of us. Good blood and bad blood. Let us see what is that good blood, bad blood. I request my colleague to introduce Dr. Anand Kumar.
Why is it not displaying?
Hello, good morning to everyone.
I have a plugin extra.
I am very happy to introduce Dr. Prashant Ganesh to our COMPOST-2025. Prashant Ganesh is a leading and senior consultant in urology at Sparsh Hospital, Yeshwantpur. He is highly experienced urologist with 19 years of experience. He holds qualifications including MBBS, MS, General Surgery, DNB Urology, Fellowship in Endurology and Laparoscopy, and has trained as a robotic surgeon, robotic surgery fellow with expertise spanning urology, uro-oncology, andrology. He has successfully performed more than 16,000 urological surgeries, covering advanced laser procedures, complex female and pediatric urology cases, and cutting-edge treatments. Renowned for his precision in managing intricate urological conditions, Dr. Ganesh is skilled in innovative techniques like robotic surgery and penile prosthetic surgeries. His dedication to the advancement of urology is reflected through his publications, teaching workshops, and commitment to the patient care. Widely regarded as one of the best urologists in Bangalore, he stands as a trusted choice for comprehensive and advanced urological treatment. Thank you very much, sir. It is up to Dr. Prashant Ganesh to take over.
Yeah, thank you for the organizing committee to give me an opportunity to come and speak in Chitradurga. Thanks for all the dignitaries here and fellow colleagues. I have come here to share my knowledge in urology with whatever experience we have. And today I will be talking about advances in urology. I have tried to put it short. Most of the urology work revolves around stones and prostates, but that's not the end of it. Urology is a very wide spectrum of a field where a lot of aspects are being covered. And mainly urologists or surgeons, there is a common tendency to get confused with the nephrologist who actually treats the medical condition. And in urology, we treat kidney and kidney related problems surgically, prostate disorders, cancers pertaining to any urological organ, kidney, bladder, prostate, external genitalia, and kidney transplant. Nonetheless, it's one of the most emerging, and I'm happy to say we have completed more than 100 and going towards 200 right now. And andrology and sexual dysfunction is itself a major field in urology. I think you also have a talk in andrology in the late evening. So these are some of the few achievements which I was able to be a part of. We started with the Kidney Stone Institute, Prostate Institute, urological cancer, kidney transplant, female urology, stress urinary leaks, where we have been taping with minimally invasive incisions, and andrology and infertility clinics, and pediatrics. Nonetheless, children have urology problem too, like pelvic junction obstructions, PU post-urethral valves, vesicular reflex, where we have been treating it, and we are advancing towards very minimally invasive. Coming now, there has been an introduction of robotics in pediatrics too. So the basic idea is to create a center of excellence of urology. And once the patient comes, it should be the end point. So coming to the major adventure in urology with lasers, Lasers are used in all the field, but urology has extracted it more. Starting with the 30 watt, 80 watt, 100 watt, 120, now we are advancing to CyberHo, which is 150 watt. I'm happy that we have the best laser in the world in our institute where we are offering the care. And coming to the main topic now, prostate problems. So I think everybody here knows what is prostate. It is a small gland which is of a walnut size, which is just below the bladder, which doesn't usually bother much to any individual in his early years of life. As he passes 45, 50 years, every man has to go through this venture at some point of time. So what is the incidence? How common is the prostate enlargement, and who requires the treatment? Like prostate rarely causes any problem before 40. Symptoms are caused by 50% of men at 60 years. When they reach 60 years, 50% will have some form of bothersome LUTs, we call it, lower urinary tract symptoms. And by the age of 70, most of the 80% of the men will have symptoms. Excuse me. Sorry for that. Yeah, what does it do basically? It's just a small gland sitting just below the bladder, which slowly grows over the size and causes the compression on the urethral tube, which is the tube where the urine is passed. And it produces a lot of symptoms. So exact cause is not known, mainly due to aging. If there is a strong family history, yes, certainly we'll consider it, and hormonal imbalance. So other factors like medical conditions, genetic factors, increasing age, dietary factors, physical activity, all matters. So when do you go and see a doctor? So normally when the patient has symptoms, they reach the urologist. So what are the symptoms? Weak urinary stream, difficulty to start. It's called hesitancy. Patient goes and stand and is not able to start the urination for some time. So on intermittency, there is a start and stop of urine. When he starts the stream, it won't be a complete stream. It will be always intermittent. At the end, they will hold a lot of urine and dribble. And normally the first symptom where the patient comes to us is with frequency and nocturia. Night, they have to wake at least 2 times, 3 times after the age of 50, 60 years. So, and straining, and in the late process, they may have retention of urine and urinary tract infection, and if you left for sufficient long enough, they can form bladder stone and bleeding. So, who requires surgery, who requires medical treatment? Not every patient, because prostate is a normal organ, not everyone requires treatment for prostate. Patients who have bothersome symptoms, and they are not relieved by medications, or they end up in complications. Only these patients require surgical care. Most of the patients do well with medical treatment. The complications are retention, like the urine is completely stopped, and the patients have significant residual urine and are producing recurrent urinary tract infections, or the urine is sufficiently staying inside so it can form stones, or the bladder is weakened, the urine is going back to kidneys and producing renal insufficiency, that means renal failure. Decompensated bladder means bladder is unable to compensate. Normal capacity of bladder is 300 to 500 ml. Decompensated bladder means patient will come to you, he will have a large lower abdomen. When you put a catheter, he will drain 1.5 liters of urine. Basically, bladder has overstretched itself and lost its tone and bleeding. So these are the patients who definitely need surgery. So this is a small picture of retention of urine, how it presents. And some medications also affect or aggravate the lower urinary tract symptoms, like allergic medications, which you normally use for common cold, and alcohol. So how do you diagnose it? The best way to diagnose a prostate enlargement is by doing a digital rectal examination, where we pass rectal examination has been done and we see the prostate, examine the prostate. So the ultrasound urinalysis, urinary flow test, and PSA. PSA is a tumor marker test which we do, and rectal ultrasound. So now the latest advancement is to do an MRI and ultrasound fusion biopsies to find out even the smallest of the smallest prostate tumors with ultra precision. It's called transperineal MRI fusion biopsies. So how is BPH treated? Most common treatment for moderate is everybody starts with alpha blockers, and 50 to 60% or even more than that responds well to the prostate alpha blockers by relaxing the smooth bladder muscles. The common complications include dizziness, nasal congestion, postural hypotension, some retrograde ejaculation, very rarely memory loss, tremors. So surgical procedures, whenever the medicine is not indicated or medicine is not tolerated by the patients, or prostate which really requires obstruction of the flow, and depending on the size and severity, we strategize. There have been a lot of revolutionary changes. So definitive treatment for prostates has come up, like starting from the open laparoscopic bipolar TURP, which has stood the standalone time for many years. Now upgoing lasers, a Eurolift, there has been a passing of band-like structures which hooks and retracts the prostates. And there's one more technology called as Rezum technology, where we use water vapor therapy. And the latest is aquablation, which is yet to come to India. So there is a lot of revolutionary changes. The role of AI seems to be in aquablation morely. And this is a small demonstration of HoLEP. HoLEP is holmium laser enucleation of prostate, which we regularly do. And this is how it looks. So this is the cystoscopy showing the urethra going into this is the prostate, which is the occlusion where we are seeing. And the bladder, that's the ureteric orifices. That's the veru montanum, that's the splentric area. So this is the laser. This is a 120 watt holmium laser, where we are cutting with exact precision. We take a nice lower incision. So what it stands beyond TURP? TURP was the previous technique where you used to take a loop of current from whether it's a bipolar or monopolar, and we used to chip it from inside. But the chances of the bleeding and the chances of removal of the tissue is better in laser, where we are using the laser enucleation. Basically, we are removing the prostate from the capsule with making, and the capsular planes are where the vessels enter, the blood vessels enter the prostate, that's the area. And why holmium laser is, it produces a best parting effect. It basically parts the tissues, and it cuts and coagulates at the same time. So before even the vessels could enter and branch out, we are actually coagulating and cutting the tissue. So you can see absolutely, prostate is a very bloody organ, but there is absolutely no bleeding here. We are cutting with, that's why it's called as laser precision. So this is the capsular area, absolutely no bleeding, separating one, we have bivalved prostate, we made the prostate into two halves. Now we are going to cut the prostate on one side, literally bloodless. Literally bloodless. I think some of you might have experienced who has undergone prostate surgery, patient comes to emergency with a lot of bleeding. It happens rarely, but this is the precision and hemostasis which we get from the laser. And the most important advantage with the laser is size is no bar for the prostate. We have done up to 300 cc prostates in laser with a single day admission and discharging the next day. Almost bloodless. So that is the laser, one lobe separated, one lobe of the prostate separated very clearly. The capsular vessels are cut and coagulated at the same time, almost with nil bleeding. So size of the prostate is no bar. precision cutting, bloodless feed, and the amount of tissue we can remove from the prostate is amazing. In TURP, we cannot remove, it's 1 gram per minute. So roughly, a prostate of 100 cc will be considered very big, but in this, the size of the prostate has no limitations. And for smaller glands, it doesn't matter whether you are doing with laser or TURP, but it takes well into induction or precision if you are using the bigger glands. This is the morcellation process. That's how we remove it. We make it into small pieces and suck it out. So basically, patient has no incisions. Everything is done endoscopically. Complications are very less. Previously, we used to see a lot of TURP syndrome, where water is absorbed through the venous channels and patient had hyponatremia, water intoxication. Those things are absolutely stopped. So this is one of the another latest modality which has been up in light now. It's called steam therapy, water therapy, or Rezum. Basically, we do a cystoscopy where it's a very small cystoscopic instrument. This procedure has an advantage where we can do even with pudendal block or local anesthesia. Laser require anesthesia, this doesn't even require anesthesia. So the white thing at the tip which you are seeing, this is an animated video running by the side, that how it works. We go inside the bladder, come back. Basically, it injects the water at very high temperatures and causes liquefactive necrosis of the prostate area. So you can see the needle. We protect the bladder neck because bladder neck is very important to prevent retrograde ejaculation. We come 0.5 centimeters behind. We inject into the lateral lobes. You can see the needle going inside, and 9 seconds is the time where we inject. The whole procedure would be roughly taking about 10 to 15 minutes max. Patient will be on catheter for about 3 to 5 days or a week. The advantage of this technology, water vapor, steam, Rezum technology, is that we can do it in local anesthesia, even in high-risk patients, where patient is unfit for surgery. The disadvantages are it has a prolonged catheter time compared to laser. Laser, we can remove the catheter within 3 days or even on a single day if it is a small size glands. But this requires prolonged catheterization. And in laser, post-op dysuria and other symptoms are less. In this, because it is undergoing a liquefactive necrosis, small tissue keeps on coming, and the area, when it gets necrosis, there may be a period of first 3 to 4 weeks or up to 3 months, the patient may have intense dysuria. What we have observed is, and this has become very popular in Middle East, and it's an office procedure which is done in UK and USA. But unfortunately in India, we are not still able to do. We see a lot of patients with chronic prostatitis. Somehow our patients have a kind of prostatitis, there are no clear planes, and they produce with a lot of symptoms because of that. So, and we Indians believe in instant care. So not many people will really agree for keeping the catheter for a longer duration. But why popular in Middle East? Because this has an edge in retrograde ejaculation. We can actually prevent retrograde ejaculation with this method. Especially if you want to preserve the ejaculation, I think we should go for Rezum. So, to put it in short, patients who are already on catheter and patients who are unfit for surgery, and now it has been advised as patients who wants to go on medication, even before medication, they can go for this. And second thing is, the gland tissue removal is not on par with the laser. It may be little less here because whatever the needle trajectory is there, only that gland is liquefied. The rest of the gland remains around the capsule, so it may grow back in few years. So, coming to the second spectrum of urology is robotics. Robotics is an important innovation coming. We have a Da Vinci X robot here. So, it is a cutting-edge technology. It produces 7 degrees of free motion. It takes out the edge of human natural tremors. So, suturing intracorporeally, that means inside the abdomen, is made very easily. Most challenging intracorporeal sutures have become very, very easy now. So, this is how the robot works, you can see the tips of the movements. It's got two angles where there is a 7 degrees of motion. What we are showing is in the pelvis. It's a very narrow, tight space, hardly 4 to 5 centimeters inside depth tissue. We can go very deep inside and literally cut and coagulate, and we can become ambidextrous. Both the hands can be used to dissect it. The left hand, which it has been operating, is bipolar, and the right hand is using a monopolar energy with a precision cut. Most complex surgeries in any department, like even in gastroenterology, surgical oncology, not only in urology, everything can be done with high precisions in deep spaces, including gynecology, with robot. And I think it is minimizing the very difficult procedures, trauma, and nowadays we do radical prostatectomy. We send patient on 3rd day home, which we never used to see earlier, which was a supramajor surgery. Suturings in radical prostatectomy, we remove the prostate, seminal vesicle, capsule, everything, and suture the urethra with the remaining bladder, neck. So we used to see a lot of incontinence, positive margins, and doing in that space in laparoscopically was very challenging. Now that edge has been completely taken out and driven out by robotics. And it is not only in prostate surgery, it can be used for any organ in the abdomen. We do partial nephrectomies, nephron sparing surgeries that we can only remove the gland even if it is of a considerate size. Previously we used to think 7 centimeters, anything less than 4 centimeters, then only we will attempt partial. But now size is becoming less and less bar, and we are going nephron sparing. And it also has an edge in robotic cystectomies, lymph node dissections, and where we normally humans have a lot of tremors, and reconstructive surgeries, including pediatric urology for pyeloplasties, where requires a lot of suturing. This we can use, and we can suture it with ultra precision. It has an immersive vision, 3D image, where we can literally sit inside the abdomen. It will give a feature of literally sitting inside the abdomen and suturing. So these are the cancers which we operate in, including reconstructive procedures. This will be the end result. Patient walks home in 3 days. The blood loss will not be more than 100 after certain learning curve. And compared to earlier, it gives an amazing result. It has changed the whole spectrum of urology actually. So coming to kidney stones, I think everybody at some point of time, or some of your relatives, you would have seen kidney stone. Kidney stones are just clumps or crystallizations which happens because of supersaturation inside our pelvic calyceal system, and varying depends on size and the metabolic abnormality it forms. The common environment is changes in the pH. If the urine is more acidic, then the chance of kidney stones or crystallization is more. Urinary stagnation because of some tube narrowing, metabolic abnormalities. Most likely we get away with drinking enough fluids. This is exactly how it is formed, by increasing more crystallization. So what are the symptoms? It is considered as one of the worst pain an individual can suffer with and come with. And it produces, in complicated scenarios, it produces infection. Infection with obstruction is a deadly combination in kidney, because kidney is one of the most filtering organs. And whenever there is a blockage and infection, it directly enters the bloodstream, and urosepsis, everyone has seen across, it's most notorious. So when should we come to a doctor? When we smell bad in the urine, blood in the urine, extreme pain, fever, chills. How do we see? We examine the patient. Sometimes flank tenderness, urine shows blood cells, pus cells, sometimes crystals. So normally we do ultrasound. If we find any swelling or there is a suspicion of kidney stone, we do a CT. CT is a confirmatory test or more higher specificity to locate the stone, give the maximum information about the kidney status and hardness of the stones by Hounsfield units. And sometimes it helps in our surgery becoming very, very easy. So these are some features of stagon. Stagon means that the stone is taken the shape of the renal pelvis. All the calyces, including the pelvis, it signifies the stagon of the stag. So how it is treated? Normally we ask them to drink good amount of urine. If the stone size is if stone size, depending on the stone size and the location, we organize the treatment. So this is the probability of stone passage. If it is in the lower ureter, less than 5 mm, there is a 74% chance. As the stone goes higher up and the size goes higher up, the chance of spontaneous passing will come down. So basically we cannot try medications in those cases. So initially we used to do ureteroscopy where we can reach only up to the lower ureter or the mid ureter. So now the things have changed, and the stones which were in the upper ureter and in the kidney, we used to send them for shockwave therapy, which was very famous, and it was misnomered as laser also. So now large stones, we used to do PCNLs, percutaneous nephrolithotomy, where we used to puncture in the back, enter the kidney directly. Even that has been minimized to mini PCNL or mini perc, what we call as. So we directly bore a small hole in the kidney, go to the particular calyx, break the stone and get it out. So these are some features. But the problem is again high chance of bleeding, because kidney is a very vascular organ. When you puncture the kidney, the chance of bleeding also comes with it. We have to accept the risks. So how are we advancing for it? Now RIRS has taken the main stage since the advent of laser, as already mentioned. So the laser has taken out the edge. Now RIRS is basically, we are using a flexible ureteroscope where we enter through the urethra, enter the ureter, enter any part of the kidney. In fact, upper calyx, middle calyx, lower calyx, wherever the stone is there. And even if the patient has one stone in the tube, multiple stones in the kidney, we can go and clear everything in one setting. So considered as a no hole, no cut, no blood stay, no blood, 1 day stay, safest procedure for kidney stones. It's a live small video of Moses technology being demonstrated. So the laser literally powders the stone completely. So this is the ureter. Now we can advance into any part of ureter, reach there. Because of the flexibility of the instrument, we can go anywhere, see with it, we can fragment or dust at our own will, and we can grasp the remaining fragments. So we can literally enter any part of the kidney. As it's going through the ureter, getting to the different calyces, the lowermost calyx is considered to be a little difficult. Upper medial calyx is considered to be some of the difficult places where we can go, even with non-contact. Now the technology is so advanced that even with non-contact, we can literally make the stones into powder. This is how the real video looks like. So dust comes out, we put a stent after the procedure, the dust comes out. The size has become a no-bar theme actually. Whatever the size, the highest size we have operated is 7.2 centimeter. So the RIRS initially we used to use for a size which is about 1 centimeter, 2 centimeter. Now with the high watt laser, latest technology being coming up, Moses technology, Cyber 150 watts, water blast technology, we are going with multiple settings, we are able to do even bigger stones. So now we have completed nearly 30 second stones, where the patient comes one day to the hospital, walks out the next day, abandoning PCNL completely. PCNL used to be the mainstay for larger stones. Now we are doing everything endoscopically, no blood, no cut, no hole. The patient walks away in a day from the hospital. So we are minimizing and maximizing the care, minimizing the injuries and maximizing the care. So how much to drink water? Depending on the urine color, I think we can decide as a common note. And how to prevent it, at least 3 liters of fluids. Citric acid usually brings the pH up and prevents stone crystallization. Drinking enough fluids and avoiding reducing the animal protein, meat, legs, restriction of salt intake, avoiding inactivity. I think this is what I could sum up. I was told that it was about 30 minutes presentation, so we're restricted only to stones and prostates. Still, urology is not just this. We are doing renal transplants. We are going to the robotic renal transplants, higher up, and robotics is coming up in a big way. I think it will be the future from now onwards. Yeah. Any questions? I'll be happy to answer.
Thank you very much. That was a very informative talk. What is, for hypertension, diabetes, we ask people to get screened once a year, at least whether they are having a talk.
Sorry, sir, I could not hear you completely.
I just wanted to know, for example, for diabetes or hypertension, we ask the public to get screened at least once a year so that they can recognize early. Like that, for prostatic enlargement, you want elderly people to undergo something screening like that, or only when they develop symptoms they should approach you?
Sir, mainly criteria for prostate treatment is not the size of prostate. For example, I have seen patients with a size of prostate 100 grams coming to my OPD without any symptoms. Just because some screening test detects prostate and the physician who is doing health checkup refers to us. When I take a uroflowmetry graph, it shows a very good curve. So in those patients, if the patient doesn't have symptoms, if the patient is not bothered by it, and if his urine flow is good, and if there is no residual urine, after passing urine, the patient should not have much residual urine. 10% is, for example, 100 ml, 10 ml is okay. If there is no significant residual urine, there is no need to treat the prostate. We can just keep him on follow-up once a year, uroflowmetry and PSA, and come back to me next year without any medications. In contrary, I have seen patients with 25 cc coming to us with severe obstruction, leading to retention, and his uroflowmetry shows a curve of average flow less than 4. Normally it is 10 to 15, 8 we consider it as okay, but less than 3 or 4. It is basically the prostate which is growing intraluminal, median lobe, which is causing the obstruction of the tube and compressing the urethra, causing the bladder to overwork. In those patients, even if it is 25 cc, we require treatment. First we start with the alpha blockers. If it is not working, we'll go ahead with all the other regimes. So symptoms, residual urine, flowmetry. These are the 3 deciding factors, not the size.
Sir,
yes.
In Chitradurga, we have got a large number of patients with renal stones.
Yes, sir.
So, what shall be the chemical compositions are in all renal stones? Whether it's mandatory to check biochemical investigations for renal stones?
No, sir. The major stone formers are calcium, oxalate, phosphorus, and uric acid. So these are the 4 main things. So many times in Bangalore, even though it doesn't favor stone, but we see a lot of stone cases. There is a deficiency criteria where there is a magnesium and citrate deficiency also lead to stones. They are called stone inhibitors. So naturally, it is not because of the chemical composition. I think because of the dehydration, the heat, the stagnation, the lack of water drinking may lead to stones rather than it. In the same household, everybody having the same food, one person may have stones of large volumes, one person may not have. It also depending on how your kidney is metabolizing and what concentrates of calcium, oxalate, uric acid and phosphorus is coming in his urine and the amount of citrates and magnesium he has got. So what we practically follow is in all recurrent stone formers who comes to us with bilateral kidney stones in young age, we do 24 hours urinary metabolic evaluation. We check all these metabolites, including intact PTH, and if anything is raised, for example, calcium or uric acid is raised, so we give a diet, we prepare a diet chart to restrict that particular thing in for him, and try to follow other things where increase water intake, take more of citric acid juices, and some patients we put on magnesium citrate substitutions also to prevent future stones.
Yes. Sir, we, as a laboratory man, I am telling, we get lot of urine samples with calcium oxalate stones, crystals.
Crystals, yeah.
What does it mean, sir?
So he has a high potential for forming stones. Yes. Because his kidney is processing a lot of crystals. It's coming, it's a matter of time. It starts with a small crystal, slowly it forms a enucleation and becomes a stone of considerable size. If untreated, it grows on bigger.
Yes, sir. So you are all, I think, plus 70 here.
Yes.
I want to know which will be the best prostatic surgeries we advise.
Sir, I think depending on the patient comfort, I think what I just told you, the criteria is how the latest technology, aquablation, there is one more thing which is upcoming aquablation. It's not yet come here, it's still in the developing stage. I think laser still stands the time tested. TURP used to be the one, but now since a lot of people are developing the skills to do laser enucleations, it is giving one of the best results and reducing the length of stay, fastening care, lesser complications. I think I would definitely prefer laser surgery, laser enucleation in particular, sir.
Sir, lastly, as I told you, I am a laboratory person. What will be the early tests we can do we can rule out prostatic cancer, sir?
So, right now we are doing only prostate-specific antigen, sir. So that is the only thing. We see the levels. If it is more than 4, as you see, if it is plus 80, then more than 6 we consider. And prostate cancer is not becoming a very bothersome problem now, because even though it is a most common cancer, it is known to grow very slowly. It is known to grow very slowly, and at some point of time in screening, if we pick up, since the advent of robotics, the surgeries have become very doable. We can completely cure the patients even with locally advanced prostate cancers.
Yes.
So normally we pick it up by PSA. Even though if PSA is high, then we put a finger, do the rectal examination. Only if we see a nodule. If it is even less than 10, we give a trial and repeat the test after 3 weeks. Because PSA can be arbitrary. Sometimes it can abnormally rise even in infections. And in very big prostates, also it can be raised. Then, if it is serially in the rising trend, then we go ahead and do an MRI, which is called a multiparametric MRI. And there is a staging criteria like pyrites 1, 2, 3. There are 6 parameters the radiologist checks in that and gives the scoring system. If the lesion is pyrites 1 and 2, we don't do anything. We consider it mostly likely to be benign and we leave it as it is and we keep him on follow-up.
Yes.
If it is 3, it is intermediate. 4, 5, it is likely to be a cancer. In 4, 5, we definitely would like to do a transrectal biopsy or transperineal biopsy.
Yes.
Now there is a fusion technology which has come where we can fuse and locate even the smallest tumors. So if it is proven to be anything with a Gleason's, there is something called as Gleason's grade. If it is 3, anything above 6, 7, 8, 9, depending on the grade, we take it down. Higher the grade, we act more faster.
Yes.
If 3 plus 3, sometimes we can still keep patient under observation. Yes. Low-grade prostates are not harmful. Even with cancer, we just keep them under observation. There is no need to do anything. Because if the patient is 80, comes with a 3 plus 3 prostate cancer, I would say go and live your life. Don't do anything.
Yes.
For example, he has even 80 years old with a Gleason's 9. I would say at least we need to channelize it, give him hormone treatment.
Yes.
Not do a major surgery. But if a 50 or 60-year-old man comes with a Gleason's 7 with good lifestyle, yes. He's walking, not much of comorbidities, even with comorbidities, that is going to be a problem. In them, we advise robotic surgery.
Yes.
This is how we individualize the care.
Yes. So thank you very much. You have enlightened us about the prostatic cancers and also prostates and also renal stones, which I think Chitradurga is a capital city of renal stones. So every time you are saying, thank you very much for your guidelines. Any questions from me? Yes.
Yes. Sir, if there is bilateral renal stones, we suspect another 50, there is a recurrence of 50% in 5 years. That is the probability. That is what statistics says. Means there's some metabolic abnormality is there in that person and it can come. Ureter. Uric acid mainly is because of proteins, animal protein. Any form of proteins, the end product is uric acid. So we cut off a lot of animal products. Basically, we tell that red meat should be reduced and anything like dry fruits, red meats, these has to be cut down in the diet, sir. All kinds of dry fruits and red meat. Dry fruits. Yes. This will produce a lot of proteins are there. The end product is uric acid. And we start a medicine that febuxostat, as you know, to reduce it, but it's only temporary. We have to manage through diet and increase citrate and magnesium, so it reduces the chelation of uric acid to calcium. Uric acid alone forming stone is also very uncommon. It always tends to catch up with calcium. So calcium will be the primary precursor, uric acid more, it forms stones. Uric acids are generally very soft stones. Radiolucent also, yeah. Yes, sir, certainly, because vitamin C increases the pH. It lessens the crystallization. Yes. Thank you.
Thank you very much. I think we'll move on to the next talk.
Thank you, sir. Thank you. I know, sir. I know. Sir?
What is your experience with fans?
Sir, right now, if the ureter permits, fans is flexible access sheath. Basically, when we are doing this flexible ureteroscopy, RIRS, we use access sheets to ureter to introduce the scope. Fans is something new which has come in last 2-3 years, where the tip is flexible and we can pass it through the ureter until pelviureteric junction. So it helps in reducing the trauma to the ureter, and we can powder the stone and suck the fragments at the same time, because fans has an adaptable suction catheter where it allows and suck at the same time. Previously, we used to powder the stone and leave it as it is. We used to depend on the normal peristalsis to come. Now, we can tell the patients, if the fans get passed in, I can clear the stone in one sitting. Sir, in my experience, I have done more than 30 stagons now. Before fans, we used to take 4 sittings, 3 to 4 sittings on an average. Now, it has become half. If it is a 3 centimeter stone, recently in a female multiparous, good ureter, I was able to pass the fans. One sitting we have cleared, 3 settings. So fans is an amazing invention. I think if I get an opportunity, I would like to show the fans also, some videos. We are regularly using it, sir. Regularly using it, actually.
Yes, as you told, actually, it has made a huge difference, especially
yes.
RIRS.
Especially RIRS.
RIRS.
One more thing, in kidney, the pelvis is very small. The normal pelvis has a capacity of only 7 ml, 7 to 10 ml. Imagine we are running the irrigation all the time, so kidney absorbs. In RIRS, initially everyone was not using it because of the infection. Mainly little infection, RIRS used to be abandoned. Now this advent of fans and different access sheets, minimizing the scope size, helps for the retrograde flow of the irrigation fluid what we use and keep the pressures less. So the duration is extended. So it has made the surgery very smoother, less chance of infection, and recovery is excellent.
Thank you.
Thank you.
Thank you very much. We'll move on to the next talk.
Thank you. Thank you for everyone for giving me the opportunity to come and talk here.
Thank you, sir. I now request Dr. Anand Kumar K, Hemato-Oncology and Bone Marrow Transplant Specialist, to please take over. I request the chairpersons to kindly introduce the speaker.
Good morning again. I am very happy to introduce one of our eminent speakers, Dr. Anand Kumar, who is a hemato-oncologist. He is a very well-known hematologist in our state. He did his MD Pediatrics in BJMC Ahmedabad, then did super specialty training in hematology at Sri Gangaram Hospital, New Delhi, National University Hospital, Singapore. He has worked as a consultant in various prestigious institutions like BGS Hospital, Kengeri, Fortis at Bangalore, Bannerghatta. At present, he is working as a super specialty hospital in Yeshwantpur, Sparsh Super Specialty Hospital. He has been a faculty in various national, international conferences. He has contributed various chapters in books, published articles in various journals, in national and international journals. His main interest is in benign hematology, malignant hematology, and bone marrow transplantation. Now it is up to Dr. Anand Kumar to take over.
Thank you, sir. Thank you for the kind introduction. And I would like to extend my thanks to the organizing committee of COMPOST-2025 for the invite. So I'll be talking about hematology topic, good blood and bad blood. So why I choose this topic is when you know what is happening in the blood, you're on the good side. And when you don't know what's happening with the blood, you end up in the bad side, and it ends up causing threat to the life. So before I go into my topic, I would like to introduce my team, because whatever I'll be presenting is my teamwork. So basically, as Sir said, I'm working at Sparsh Super Specialty Hospital. So this is my colleague, Dr. Mahesh, most of you will be knowing. And my other colleague is Dr. Sunil. This is myself. And we have another consultant, Dr. Purnima. So recently, Dr. Vikram, who has cleared his DM Hematology from Madras Medical College, has joined our team. So this is a team, so basically it's one of the largest hematology and BMT teams. We have a dedicated nursing staff, blood bank specialty, and other various specialties like urology, like Dr. Prashant mentioned, and to support the high-end care that we are doing. So this is a glimpse into our hematology unit with state-of-the-art BMT units and a dedicated nursing staff. So we have a large support system through which we are able to deliver the state-of-the-art care to our people. So we not only are sitting at Bangalore and treating patients, we are reaching out to many district places in Karnataka, wherein we are bringing hematology care to bedside, to the doorsteps of these patients. I myself am doing Chitradurga OPD since almost 3 years at Bifurcation Medical College Hospital, and I've been treating many hematological cases in Chitradurga, and I've been doing bone marrows at Vasvi lab and everything. So with this introduction, I would like to go into my actual topic, good blood versus bad blood. So it's basically a case-based approach. So I'll be taking through some of the case scenarios wherein, so most of you may be aware of who is a hematologist, but I would like to introduce to the day-to-day work of a hematologist and how we see the cases and how we deal with them through this presentation. So when we talk about hematology, we talk about blood cells, blood cell lines. So what are the blood cell lines we have? Red cell line, white cells, and platelets. So where do they originate from? They originate from the bones. This soft spongy structure in the bone known as bone marrow. It is like a blood factory. So in the blood factory, there is an engine known as stem cell, wherein this is like a mother cell from which all the red blood cell, white blood cell, platelets are produced. So let's go one cell by cell, try to see what is the problem in that, and try to go it through case base. So first we'll be dealing with the red cell. So what is the most common problem? We all agree that anemia is the most common blood-related problem, right? So let's see how to approach anemia. So what is anemia? It is decreased hemoglobin. So broadly, the things can be classified into decreased production. So what are the causes for decreased production? It could be nutritional, like iron, B12, folic acid, or hemoglobinopathies like thalassemia, sickle cell, or a marrow failure like pure red cell aplasia or aplastic anemia, or infiltrating disorders like leukemia, lymphoma, or solid tumors. Then it could be increased blood loss, like in a young female coming to you with anemia, severe anemia. The first history that you would ask is there any history of menorrhagia? So that gives away the cause, that there is a blood loss due to anemia. But there could be increased destruction also that's happening because of hemolytic anemias. So this is how you will broadly have a picture in your mind when you come across a case of anemia in your practice. So this is how we are used to seeing this this thing. So two things that you have to remember is, one is when the MCV is low, there are two differentials, main differentials, beta thalassemia trait and iron deficiency. but we can differentiate with the RDW. When the MCV is increased, it could be megaloblastic anemia or immune hemolytic anemia, but the differentiating factor between aplastic anemia and MD is again the RDW. So I'd like to give you the very practical approach whenever you see a low hemoglobin. So you have to, don't do just a hemoglobin, always do a complete blood count, because when one cell line is affected, you have to ensure that the other cell lines are not affected. Then when only there is anemia, you see whether it is hemolytic anemia or non-hemolytic anemia. What are the two tests that you do to differentiate these two? So one is reticulocyte count and the LDH. So if the high reticulocyte count, high LDH, you know that hemolysis is happening. So then what you have to do is, you have to see whether it is an autoimmune hemolytic anemia or a congenital hemolytic anemia. What is the test that you do to differentiate? You do a direct Coombs test. If a direct Coombs test is positive, you are dealing with the immune hemolysis. Otherwise, you are dealing with a congenital hemolytic anemia. So the most underrated blood investigation is peripheral smear, but it gives you the most vital information. You see, I'll be talking about this peripheral smear in detail whenever we go to the cases. So with this, I would like to introduce you to some cases that we have dealt over the years and try to see how simple things can be illustrated with simple blood tests at your own clinics. So there's this 18-year-old girl who was referred to us for recurrent anemia. She did not give any history of any excessive blood loss. She didn't give any history of any blood transfusion in the past. But however, on evaluation, she had some itchy rash over the upper limb and lower limbs. And also, she has been worked up for chronic diarrhea in the past. But she's symptomatic for anemia. That's why she came to us. So when we examined her, she had this skin rashes. Pallor was present. Otherwise, there was no problem in the systemic examination. So now, when we did this initial investigation, the hemoglobin is low, MCV is low, but white cell and platelet is normal. So how do you investigate now? So you have a microcytic hyperchromic anemia in a young girl who's having low hemoglobin. So what are the tests you do? You do a peripheral smear, it shows microcytic hyperchromic. You have a low ferritin, low transferrin saturation. So are you satisfied with the diagnosis of iron deficiency anemia? So is it a simple case of iron deficiency anemia? But this patient has now skin rash with a chronic diarrhea. So when we dig deeper and we found that the itchy rash was suggestive of a malabsorption syndrome, probably due to celiac disease, the IgA anti-TTG antibody was positive. So the final diagnosis is iron deficiency anemia due to a malabsorptive syndrome like celiac disease, which is commonly associated with dermatitis herpetiformis causing rash. So simple things can give away clue. She was started on dapsone and gluten-free diet. There was significant improvement in the symptoms as well as the hemoglobin. So don't just end up saying that it's iron deficiency anemia and do away with iron tablets or blood transfusion. Try to think deeper and correlate all the symptoms and try to explain all the symptoms with one diagnosis. So let's move on to the other case. So there was this radiologist who was referred from Tumkur for refractory iron deficiency anemia. So he didn't give any history of any blood loss, no history of any jaundice, abdominal pain. He had one transfusion in the past, but otherwise systemic examination was normal. So when we did the investigation, the hemoglobin was low, MCV was low. Again, PS showed microcytic hypochromic anemia. As he was, iron profile would suggest low serum iron, low serum ferritin, low transferrin saturation, everything, suggestive of iron deficiency anemia. So this is relatively young male with the iron deficiency anemia, which is recurring, but there is no history of any blood loss. But still, we went ahead and did the upper G endoscopy to see if there is any blood loss. It was normal. Stool occurred blood was negative. Okay, and we also did the malabsorption syndrome workup like celiac disease, but it was also normal. So what do you think is the cause here? So what next? So we have this refractory iron deficiency anemia, but no blood loss. So whenever you're stuck with your diagnosis, go back to the history. So when we went back and asked him, he said that occasionally he gave a history of passing dark-colored urine, almost a cola-colored urine. So what does it indicate? It indicates intravascular hemolysis. Okay? So when we investigated further, the hemolysis was not due to immune, DCT was negative, but definitely he was hemolyzing, LDH was high, retic count is high. So there is only one differential with iron deficiency anemia with a hemolytic picture. What is the diagnosis? So the diagnosis was PNH, paroxysmal nocturnal hemoglobinuria, wherein he had a very high neutrophil monocyte PNH clones, and he was treated with steroids, and he is doing well now. So let's move on to other case. This is a very elderly female who was referred for again recurrent anemia, received blood transfusion 6 months back. She denied any symptoms of blood loss, abdominal pain, weight loss as such. Her medical family history and social histories were unremarkable, and she was hemodynamically stable. She looked healthy without any jaundice. Systemic examination was normal. So again, low hemoglobin, low MCV, white cell is normal, platelet is normal, peripheral smear again same microcytic hemi picture, iron deficiency anemia. Retic count is 0.3. What does it indicate? It indicates underproduction anemia, right? When there is iron deficiency, you will say underproduction anemia. Vitamin B12 is normal. So this is an elderly female with iron deficiency anemia. What do you think? You would always rule out occult GI blood loss. Okay? Elderly females coming with, elderly male or female coming with a recurrent iron deficiency anemia, always rule out occult GI blood loss. So upper GI endoscopy was normal, but colonoscopy showed a ascending colonic growth, suggestive of a CA colon. So always to evaluate GI blood loss, many of my gastroenterology friends suggest you do a endoscopy, colonoscopy, CT abdomen pelvis, or a capsule endoscopy. So as a hematologist, I would suggest that whenever you are faced with recurrent iron deficiency or a refractory iron deficiency but no bleeding, you always think of these causes: H. pylori, autoimmune gastritis, celiac disease, or refractory iron deficiency anemia due to a mutation in TMPRS, which is very rare, but we have seen a couple of cases wherein only IV iron works. So this was regarding with the iron deficiency anemia, which is the most common anemia that we see across the age groups. So let's go to another case, again an anemia case referred from Bangalore itself. She had anemic symptoms in the form of weakness, dyspnea on exertion. She was a 70-year-old female. She also gave history of significant weight loss, but no blood loss, jaundice, or bone pains. On examination, she had pallor, she was cachexic. There was no any lymphadenopathy or organomegaly. So how do you start investigating this case? So again, just we will do a underproduction causes like vitamin B12, folic acid, ferritin, and retic counts are low. So here the nutrient things are normal, but retic counts are low. It again shows that there is an underproduction anemia, but not due to nutrient deficiency. So we thought it's an elderly age group, MDS still could be a possibility. So we went ahead and did a bone marrow aspiration. So this shows that there is no red cell precursors at all. So it's a case of pure red cell aplasia. It responds beautifully to steroids and cyclosporine. But there was a catch in this situation. There was a twist in the tail. So I told you in the history that she has significant weight loss, cachexia symptoms. So don't stop at diagnosis, but always try to combine all the symptoms and see is there anything that can be associated with the diagnosis. So we did a chest X-ray. It showed a huge thymoma. So the final diagnosis was PRCA with thymoma. Okay, so here the management changes completely. There is no need for steroids and cyclosporine also. You just remove a thymectomy, the PRCA resolves automatically. Okay, so this was one of the rare associations wherein the acquired PRCA is due to thymoma and the PRCA reversed when we did a thymectomy. Okay, so let's proceed to another case. This again, a 30-year-old lady referred from Belur for anemic symptoms, but this lady had anemia and icterus. So this is a new combination now, anemia along with icterus, and there is a mild splenomegaly. So when you see the CBC, there are two cell counts that are low. What is that? Low hemoglobin and low platelet. So two cell lines are low, there is anemia and there is mild icterus and mild splenomegaly. So what are the differentials that you can think of? So anemia with jaundice with splenomegaly indicates that it's a hemolytic process. So you start with retic, LDH, both are indicative of hemolysis. You do a Coombs test, it comes positive. So what is the diagnosis? You have an autoimmune hemolytic anemia with thrombocytopenia. The diagnosis is Evans syndrome. Okay? So again, you have to do a bone marrow because it could be an underlying leukemia or lymphoma that could be triggering these things, and you have to evaluate and treat these things. So now we have dealt with low hemoglobin, but we often in Chitradurga, every time I come to Chitradurga, every OPD, I see at least 3 to 4 cases of high hemoglobin, right? So it could be due to polycythemia vera or a secondary polycythemia wherein smoking is the most common cause. What is the problem with polycythemia? 20% of the cases can present with CVTs. Okay, I have seen a young male in 20-25 years coming with 23 hemoglobin with a stroke. So it is a preventable cause. Every time I come to Durga, cardiologist refers me saying that he has a MI case with a hemoglobin of 21. So it is a well-known cause that thrombosis, so don't neglect it. So we say that we have a good high hemoglobin, why to worry? So Kannadalli ಒಂದು ಗಾದೆ ಇದೆ, ಅಮೃತ ಕೂಡ ಜಾಸ್ತಿ ಕುಡಿದ್ರೆ ವಿಷ ಆಗುತ್ತಂತೆ ಅಂತ. So that's what we have to remember. Anything high, so we have to stay in a homeostasis always, right? So let's take up this case. 50-year-old lady was referred from Bangalore for high hemoglobin. She had a history of CVA in the past with CRAO, and multiple blood reports showed a hemoglobin varying from 18 to 22. Otherwise, white cell and platelets were normal. So the classical symptom when the person with polycythemia walks into your OPD is congested conjunctiva. When you see a red eye and a person walking into, you almost know that this person has a polycythemia. And of course, there can be mild splenomegaly. So how do you evaluate for this? So this patient already has a CVA, and she's a female, no history of smoking, we asked. But so you try to evaluate in terms of polycythemia vera. So first thing that you do is erythropoietin. So erythropoietin is low in polycythemia vera, and you do a JAK2 mutation, it comes positive. So how do you treat? You start hydroxyurea, you do phlebotomies to keep the hemoglobin less than 16, and you start blood thinners to keep the blood thin. Okay, so it's a simple thing, like any diabetes, hypertension, nothing to worry. But sometimes after 10 to 15 years, they may progress to secondary myelofibrosis or a myeloid neoplasm sometimes. So we have dealt with one cell line, that is red cell line. Next, let's see with the second cell line, that is the platelets. So thrombocytopenia again is the second most common problem in hematology that we see, especially with dengue season and everything. We see predominantly thrombocytopenias. We get a lot of calls from all over all the medical hospitals and everything concerning thrombocytopenia, how to manage and everything. So these are the broad causes. So let's take up a case. So this was a young lady referred from Bijapur, wherein I do again outreach clinics since almost last 7 years, with a almost high platelet count of 8 lakhs. She was completely asymptomatic. When you see the CVC, there was slight low hemoglobin and low MCV, but platelet and white cell count is completely normal. So how will you proceed? So since there was microcytic hypertrophic picture, I did an iron deficiency, is a young female. So low ferritin, iron deficiency anemia, the platelets could be reactive thrombocytosis, right? You will not jump on primary thrombocytosis, essential thrombosis right away. You treat with IV iron, but we repeated the CBC. Now, despite treating the patient with iron, the platelet counts are 10 lakh, and still she is asymptomatic. Do you still think it is reactive thrombocytosis? No. So this is a red flag. When you have treated the underlying cause, you have cut down the stimulus, still the platelet count is increasing, then it is not probably a primary or a secondary cause. You have to think of primary cause. So we did a MPN panel. It turned out to be CALR mutation positive. So this is a case of essential thrombocytosis. She was started on hydroxyurea and ecosprin, and she did well. So whenever the platelet count crosses more than 10 lakhs, one thing I would like to say is don't start on antiplatelets or anticoagulants, because there's a risk of bleeding. So what we generally think is high platelet means thrombosis risk. Paradoxically, when the platelet count increases more than 10 lakh, there is an acquired von Willebrand disease that can happen and lead to bleeding. So what you have to do in the situation is try to find out the cause and start cytoreduction therapy with hydroxyurea rather than be in a hurry to start blood thinners. So that is one of the learnings from this case. So there are many surgeons in this group, I think very pertinent to this forum. So there was a 16-year-old boy referred to a surgeon for evaluation of, actually for hernia operation. On routine evaluation was found to have 19,000 platelets. So he didn't have any significant symptoms, or on examination he didn't have any problem at all, no positive family history, no bleeding tendencies, anything. So I'd like to give you some choices wherein what you will do in this case. So first, do you think that the patient has ITP and stat steroids? Or you say, I don't want to worry about the cause, I'll just give platelets and go with the surgery. Or you think, why to take the headache? We'll refer to hematologist. Or you will go to your friendly pathologist and ask him to review the smear. Yes, so always go to your nearest pathologist, be friends with them, and ask them what is there in the peripheral smear. So here, when you see the platelets are clumped, it's a case of pseudothrombocytopenia. Okay, falsely the platelet counts are low on the manual platelet, whatever counters, and when you do a manual platelet count, the platelet counts are normal. So it's a case of pseudothrombocytopenia, which can be easily negated with simple peripheral smear examination by a friendly pathologist. So these are some of the cases of pseudothrombocytopenia. So let's take up another case. There is a 23-year-old girl coming with petechia and ecchymotic patches. Platelet count is 10,000. She is just walking into your OPD with all these symptoms. You have done the examination, there is no organomegaly, you have done the blood test, blood, white cell and platelet, everything is normal. ESR is normal. So what do you think is the differential? What is the diagnosis here? Isolated thrombocytopenia in a healthy looking individual coming with petechia ecchymosis. There is no organomegaly, there is no other issues. So a bone marrow suggestive of increased megakaryocytes. The diagnosis is ITP, immune thrombocytopenia. So always we get asked whether to do bone marrow in ITPs or not. So as per the international guidelines, there is no necessity. Especially in pediatrics, these questions get asked because why you have to subject the bone marrow to a child to a bone marrow and everything. But it becomes necessary when these symptoms are there. So how do you manage ITP? With steroids, with IVIG, anti-D. So we have got these newer things like chronic ITP for L-trombopag, romiplastim and everything, which have made treating this ITP very easy now. So let's go to another complex case actually referred from Raichur. So this was a 24-year-old primie in the last trimester presenting with fatigue, jaundice and one episode of seizure. She had a lower limb pain and evaluation found to have DVT. So she was started on Clexane for the same. So now on examination there is pallor, mild icterus, hypertension is there. So on evaluation hemoglobin is low, platelet count is low, indirect hyperbole is there, urine albuminuria, creatinine is elevated. So there are at least 2-3 systems that are involved. Blood, there is low platelet, low hemoglobin, and there is a CNS event like seizure, there is a kidney event like AKI going on, right? And there is a clot that's happening. So what is the diagnosis here? Any other things? So DIC PT-APT was normal. So there is 2 cell lines that is depressed. So there is anemia definitely. There is hemolysis that's happening because jaundice is there. Okay, so we did a LDH is high. Okay, but DCT was negative. Then, so there are only few conditions wherein a patient can have thrombocytopenia, also have thrombosis. So like sir mentioned, it is DIC is one of the things. Anything else? TTP, good. Next. Anything else? Okay, so we have heparin-induced thrombocytopenia, we have Evans syndrome, we have DIC, we have catastrophic aplasia, and TTP. Okay, so here a simple peripheral smear, again from a friendly pathologist, would give us the diagnosis. You see a schistocytes, helmet cells on the peripheral smear with a high LDH, DCT negative. There is no other diagnosis than TTP, right? But the story doesn't end here. So the most common cause of TTP is acquired TTP, right? So this is because the antibodies against the ADAMTS13. So this patient was initially referred to a nearby hematologist who presumed that this is a case of acquired TTP and did plasmapheresis, give rituximab and everything. She initially responded, but again she came back with anemia, jaundice. So when the patient is not responding to a set line of therapy, you have to start questioning the diagnosis. So then we went back and did the ADAMTS profile again. You see the ADAMTS activity is almost 0. And you see the anti-ADAMTS13 levels are very low. In acquired TTP, anti-ADAMTS13 levels would be very high. So this is a case of congenital TTP. There are only a handful of cases in the world wherein there is a congenital TTP. They first present in childhood or during pregnancy. So it's a case of, we also did a genetic workup and found there was ADAMTS deficient mutation was there. So it's a case of Upshaw-Schulman syndrome, congenital TTP. So the treatment entirely changes. You have to do just give FFP. Okay, fondaparinux was given for DVT, but otherwise no plasmapheresis, no role of rituximab. So that is the importance of just seeing a peripheral smear and be thorough with your evaluation. So we have dealt with 2 cell lines. The third cell line, of course, I think we have 10 more minutes I will take. So leukopenia is again a very important symptom that we see. So we see with nutritional causes, marrow failure or infiltrating causes. Sometimes in sepsis also we see leukopenia. So there was this one 20-year-old boy referred from Gulbarga for us. So he had this weakness, gum bleeds. There was this pancytopenia that was there. So vitamin B12 is low. So do you think these symptoms can be explained by only vitamin B12 deficiency? So there is pancytopenia. He's a vegetarian also, which can be there, and weakness and gum bleeds and ecchymotic patches. So one thing you have to remember is vitamin B12 deficiency can cause pancytopenia, but the red flags are bleeding symptoms, and second is the lymphocyte, neutrophil lymphocyte ratio, which is very much skewed. Neutrophils usually 70%, lymphocytes 30%, here lymphocytes 80%, which says that this could be a more graver problem than only vitamin B12 deficiency. So bone marrow was done, there's an empty marrow. So diagnosis, aplastic anemia. So this patient underwent bone marrow transplant unit and is discharged now. So there was this, again, patient referred from Mysore with pancytopenia. He had all this pancytopenia picture was there. So we did a bone marrow in this patient. It was suggestive of AML. Okay, so this patient was started on treatment. He responded, he went into remission. But just doing a bone marrow and establishing the diagnosis of AML is not good enough now. I just put up this case to send the message that now leukemias are almost completely curable. So what we need is a risk stratification that we should do upfront. We have a lot of genetic markers that says that this is a good leukemia or a bad leukemia. So in this case had this ASXL1 positive, which is a high risk. So we took up for transplant even though he was in remission. So this shows that just don't end up just doing bone marrow at your center and saying, okay, leukemia, there's nothing to do. There are a lot of advances in the field of leukemia, lymphoma, hematology to ensure near complete cure in these patients. So again, there was this 18-year-old girl referred to us for fever of 1 month. Most hepatosplenomegaly was there, pancytopenia, LFTs were deranged, PTT was elevated. She was referred to us to rule out leukemia, but bone marrow did not show any blasts. So what did we see there? We saw hemophagocytes. So the diagnosis is HLH. Okay. So HLH again is a very not an uncommon problem. You have to start suspecting it whenever there is life-threatening syndrome wherein because of immune reactivation. Okay. It is characterized by prolonged fever, peripheral cytopenias, and splenomegaly. So the last problem that we see is leukocytosis. So it could be reactive or it could be malignant, as in leukemias. So there was a 78-year-old female referred to us for high white cell count of 1.8 lakh. So this patient, when we did a FISH for B cerebral, came positive, confirming the diagnosis CML. So would you like to treat this case? She is already 8-year-old with leukemia. Do you want to treat this case? Yes. So the entire treatment thing has changed. So with a simple drug called imatinib, she can have a near complete this thing. She can live another 5 to 10 years of her life, complete her lifespan with this simple drug. So I'll just skip this case. So apart from the cell lines, we also deal with lymphomas and myelomas. Okay, due to the deficiency of time, I'll just go to the last part of the my talk. There are many interesting cases that I'd like to go on and on, but due to the lack of time, I'll just skip to the last part, which is the transplant, which most of us will be interested to know what we are doing in the field of bone marrow transplant. So bone marrow transplant is something that we deal with. So we do autologous transplants, wherein we take the stem cells from the patient itself, cryopreserve it, give high stem cell dose, and give it as a rescue. We do allogeneic stem cell transplant, where the donor can be a matched family donor or an unrelated donor, a haplo donor. We give chemotherapy and then give the stem cells as a rescue again. So like I said, allogeneic transplants can be match-related, unrelated, or a haploidentical transplant, wherein half-matched donor like a father and mother also can be used as a donor. So these are some of the diseases that we can use where bone marrow transplant is done. So I'd just like to share one interesting bone marrow transplant case that we did recently. So there was this 8-year-old boy referred for pancytopenia. He was from Guntkal. On examination, he had this microcephaly syndromic phases. So on evaluation, he was found to have aplastic anemia and ectopic kidney. So with all these things, we suspected that could be an inherited bone marrow failure syndrome and did a FANK gene mutation. It turned out to be FANK-A positive. So the final diagnosis is Fanconi anemia. So the transplant in Fanconi anemia with aplastic anemia is a bit tricky because Fanconi anemia, they have a DNA repair problem. We cannot expose them to high-dose chemotherapy. Otherwise, they will end up in a lot of toxicities. So we were lucky. He didn't have any matched family donor. We did an unrelated donor transplant. He had a relatively uneventful pre and post BMT. At day 100, he had a GTCS wherein he had a drug-induced thrombotic microangiopathy, which had a near escape from death. This is 1 year post-transplant with the parents that he was there. So I would like to leave you with this one last case, which the parent of this patient himself shared this. So there's this 17-year-old boy who has this high-risk AML who underwent half-match transplant. He developed all the complications that we could, we read in our textbooks, we came across in our fellowships and higher education like steroid-refractory gut GVHD, CMV reactivation, drug toxicity, extrapulmonary TB. So at the end of treatment, he was like this. So one could wonder why should a person subjected to transplant to lead such a pathetic kind of a situation wherein he's almost bedbound, sitting on in the home itself. But the story doesn't end there. So after 6 months, his recovery started beginning, okay? And now, after 11 months, he's almost recovered, going to the college. Then he went, after 4 years, he went on a bike ride alone with his friends on a 7-day Leh Ladakh bike ride. This is his first time outside home. So this was a very inspirational BMT journey that we could see from almost knocked out and coming out strong and leading a near normal life. And we have many such cases wherein transplant patients have undergone and they come out of this problem. And we also did one transplant for an unrelated donor. We got this donor from Great Britain and we were able to do the transplant. So with this, I'd like to end my talk. Thank you for your patient hearing. I'd like to take up any cases. Thank you.
Thank you, sir, for sharing your valuable insights. I request the chairperson to kindly do the honor of felicitating the speaker.
Due to shortage of times, you can have the question answer session a little later. Yeah. Yeah, volunteers.
I request Dr. Prashant sir also to please be seated on the dais for felicitation.
Thank you, everyone. I now request Dr. Veerbhadraya sir, President-elect IMA Karnataka State Board, to kindly felicitate our chairpersons.
We will shortly begin with the formal inauguration. I request everyone to please stay back here as tea will be served in this hall itself.
All students to stay back. The tea will be served here in the hall. Yeah, please don't leave the hall. Okay.
ನೀನು ಬೆಳಕೆನಿಸೋ ಸಂಜೆ ನೀನು ಎದೆಯ ಧ್ವನಿಗೆ ಬೆಳಕು ನೀನೆ ನೀನಾದೆ ನೀನಾದೆ. ರಸ್ತೆಯಲ್ಲಿ ಸಂತೈಸೋ ಅವಳಿ ಗಾಳಿ ಸಾಗರದ ಬಾನಿನಲ್ಲಿ ಕಂಗೊಳಿಸೋ ಅವಳಿ ನೀಲಿ ಸಮಯ ನಿಂತೋದೆ ಅವಳ ಅಂಗೈಯಲ್ಲಿ ನಾನು ಶರಣಾದೆ ಅವಳ ಗುಂಗಿನಲ್ಲಿ ಸೋತೆ ಹೋದೆ ಸೋತೆ ಹೋದೆ ಸೋತೆ ಹೋದೆ ಸೋತೆ ಹೋದೆ ಸೋತೆ ಹೋದೆ ನೀ ಮೊದಲ ಕೊನೆಯ ಆಸೆ ನನ್ನ ಎದೆಗೆ ಹಿಡಿಸೋ ಭಾಷೆ ಅನುರಾಗದಲ್ಲಿ ಕೊನೆ ಬೀದಿಯಲ್ಲಿ ನನಗೂ ನಿನಗೂ ಮನೆ ಮಾಡಿರುವೆ ಒಳಗೆ ಬರಲು ತಡ ಎಂದೇಕೆ ಕಿಟಕಿಲೇ ನಾಕಾದೆ. ಕನಸಲ್ಲಿ ಯಾರೂ ಇರದಾಗ ನನ್ನವಳ ಮನಸ್ಸಲ್ಲಿ ನನಗೆ ಬೇಕಿತ್ತು ಜಾಗ. ಹೃದಯ ಮೌನ ಕಾಡುವಾಗ ಮಾತು ಹೇಗೆ ಆಡಲಿ ಹುಡುಕಿ ಹೋದೆ ಎಲ್ಲೋ ಕೂಡಿ ನೀನೇ ಸಿಕ್ಕ ಶಾಯರಿ. ಸೋತೆ ಹೋದೆ ಸೋತೆ ಹೋದೆ ಸೋತೆ ಹೋದೆ ಸೋತೆ ಹೋದೆ ಸೋತೆ ಹೋದೆ ನೀ ಮೊದಲ ಕೊನೆ ಆಸೆ ನನ್ನ ಎದೆಗೆ ಹಿಡಿಸೋ ಭಾಷೆ ಅನುರಾಗದಲ್ಲಿ ಕೊನೆ ಬೀದಿಯಲ್ಲಿ ನನಗೂ ನಿನಗೂ ಮನೆ ಮಾಡಿರುವೆ ಒಳಗೆ ಬರಲು ತಡ ಇಲ್ಲೇಕೆ ಕಿಟಕಿಲೇ ನಾಕಾದೆ. ಸೋನೆಯಲ್ಲಿ ಸಿಕ್ಕಿಕೊಂಡ ಅರಗಿಣಿಯ ತರಹ ನನ್ನ ಮನಸ್ಸು ನೆನೆದೋಯ್ತು. ಸಂತೆಯಲ್ಲಿ ತಪ್ಪಿ ಹೋದ ಮಗು ತರಹ ಮನಸ್ಸು ಕಂಡ ಕ್ಷಣವೇ ಕಳೆದೋಯ್ತು. ನನ್ನ ಕನಸಿನಲ್ಲೂ ಬೊಗಸೆ ತುಂಬ ಪ್ರೀತಿ ಕಂಡಿದ್ದೆ. ಇನ್ನು ಮುಂದೆ ಎಲ್ಲ ನೀನು
Hi, this is R. Madhavan. The songs and album of our film Aap Jaisa Koi has released on Spotify. Download.
ಬೆಳಕಿನ ಕವಿತೆ ಬೆಳಗಿಗೆ ಸೋತೆ ಬೆಳದಿಂಗಳೇ ಮೆರವಣಿಗೆ ಹೀಗೆ ತಾನೇ ಪ್ರೇಮ ಸೆಳೆಯುವ ಗಳಿಗೆ ಬೆಳಕಿನ ಕವಿತೆ ಬೆಳಗಿಗೆ ಸೋತೆ ಬೆಳದಿಂಗಳೇ ಮೆರವಣಿಗೆ ಬಿಸಿಲಿಗೆ ಅಂಗಿ ತೊಡಿಸಿದ ರೀತಿ ಹಗಲಿಗಳು ನನ್ನೊಳಗೆ ಹತ್ತಿಯಂತೆ ಇವಳು ಈ ಮುತ್ತಾದ ಬೆಂಕಿನ ಗಂಟಾಕಿದಂತ ಶಿವ ಯಾರೋ ರೆಪ್ಪೆಯಲ್ಲಿ ಸರಸ ಸದಾ ಕಾಲ ಸಮೂಹಗೊಳಿಸುವ ಹುಡುಗಿ ಒಂದೇ ಒಂದು ನಿಮಿಷ ಹಿಮಾದಿ ಕೈ ಬೆರಳು ತಾಗಿ ಸರಿಯೋ ಕಾಲ ಕೂಡ ಸರಿಯೋ ಕಾಲ ಪ್ರೀತಿ ಮಾಡೋ ಹರಿದ ಮಜನೂ ಹೀಗೆ ತಾನೇ ಪ್ರೇಮ.
everyone.
Hello, hello.
Hello, hello. Good afternoon, everyone. We welcome you all once again to COMPOST-2025. After an enriching morning of scientific sessions, we now gather for a landmark moment in today's conference. Myself, Dr. Sanaha.
Myself, Dr. Shashank MS. It is our privilege to be your host for today's event.
The Indian Medical Association Karnataka State Branch, in collaboration with the Chitradurga District Branches, Academy of Medical Specialities and Basaveshwara Medical College and Hospital Chitradurga, proudly announces COMPOST-2025, the annual conference of the Association of Medical Specialities, IMA, Academy of Medical Specialities South Zone Conference and Teachers' Day celebrations of IMA Karnataka State Branch scheduled today. This conference is designed to advance healthcare professionals' career by equipping them with essential skills, resilience and commitment to safe, ethical and efficient practices in the age of artificial intelligence. With the motto, engage, educate, empower and entertain, the focus areas of COMPOST include change management, overlap management, ethical marketing, professional development, organizational efficiency, safety and team building.
Yes, now it is time for Academy of Medical Specialties South Zone Conference Inauguration. This event is collectively organized by IMA Chitradurga, IMA Chalkere, IMA HoLEP, IMA Hiriyur and IMA Hosdurga, IMA Karnataka State Branch, Academy of Medical Specialties Karnataka and South Zone. This marks a new chapter in our academic and professional journey. To grace this occasion, we have with us a galaxy of eminent leaders of IMA. It is now time to invite our distinguished dignitaries to the dais.
I request Dr. Pavan Yeredi to escort the guests onto the dais. Dr. Palakshaya L., President, IMA Chitradurga.
And now I request Dr. Tanmay to escort the chief guest, Dr. Prahlada NB, Honorable Secretary, IMA Chitradurga.
I request Dr. Pavan Yeredi to escort Dr. V.V. Chinivalar, President, IMA Karnataka State Branch.
I would like to request Dr. Rishita to escort Dr. Suriraju V, Honorable Secretary, IMA Karnataka State Branch.
With due respect, we now invite the Honorable Secretary of IMA Karnataka State Branch and Honorable Secretary IMA Chitradurga to kindly adorn our esteemed President with the prestigious IMA Karnataka State Branch medallion.
Thank you, everyone. Now, I request Dr. Samprati to escort our chief guest, Dr. G.B. Bidinal Sir, National Vice President, IMA.
I now request Dr. Pavan Yeredi to escort Dr. Venkata Chalapati Sir, Chairman-elect, IMA Academy of Medical Specialities Headquarters.
I request Dr. Pavan Yeredi to escort Dr. S.Y. Mulki Patil Sir, Chairman, IMA Academy of Medical Specialty, Karnataka State Branch.
I request Dr. Tanmay to escort Dr. Veerabhadraya, TA, President-elect, IMA Karnataka State Branch.
Now, I request Dr. Samprati to escort Dr. Shankar Narayan Sir, IMA Karnataka State Branch Treasurer.
I now request Dr. Pavan Yareddy to escort Dr. Prashant G, the Dean of Basveshwara Medical College and Hospital, Chitradurga.
Now, I would request Dr. Samprati to escort Dr. Yuvraj B.Y., the Director, Chitradurga Institute of Medical Science and Research Institute.
I now request Dr. Pavan Yareddy to escort Dr. Rajesh M.S., the Medical Superintendent, Basveshwara Medical College and Hospital, Chitradurga.
Now, I request Dr. Samprati to escort Dr. Manjunath Nekar Sir, Honorable Secretary, IMA, Academy of Medical Specialties, Karnataka State Branch.
I now request Dr. Pavan Yareddy to escort Dr. Narayan Murthy C. and Dr. S.P. Ravindra, Organizing Chairman of Academy of Medical Specialties Conference.
Now, I request Dr. Tanmayi to escort Dr. Renu Prasad Sir, District Health Officer, Chitradurga District.
I now request Dr. Samprati to escort Dr. Shilpa, Treasurer, IMA, Chitradurga. I now request Dr. Samprati to escort Dr. Yogendra and Dr. Megha, Organizing Secretaries. Thank you, everyone. May I request everyone to welcome them with a big round of applause as they take their seats on the dais.
Now, I request Dr. Bhavana to sing a divine invocation on this occasion and seek blessings of His Almighty for the success of this conference.
ನಮ್ಮಮ್ಮ ಶಾರದೆ ಉಮಾ ಮಹೇಶ್ವರಿ ನಿಮ್ಮೊಳಗೆ ಹನ್ಯಾರಮ್ಮ ನಮ್ಮಮ್ಮ ಶಾರದೆ ಉಮಾ ಮಹೇಶ್ವರಿ ನಿಮ್ಮೊಳಗೆ ಹನ್ಯಾರಮ್ಮ ಕಮ್ಮಗೊಲ್ಲನ ವೈರಿಸುತನಾದ ಸುಂಡಿಲ ಹೆಮ್ಮೆಯ ಗಣನಾಥನೇ ಅಮ್ಮಯ್ಯ ನಮ್ಮಮ್ಮ ಶಾರದೆ ಉಮಾ ಮಹೇಶ್ವರಿ ನಿಮ್ಮೊಳಗೆ ಹನ್ಯಾರಮ್ಮ ರಾಶಿ ವಿದ್ಯೆಯ ಬಲ್ಲ ರಮಣಿ ಹಂಬಲನೊಲ್ಲ ಭಾಷಿಗ ನಿವನ್ಯಾರಮ್ಮ ರಾಶಿ ವಿದ್ಯೆಯ ಬಲ್ಲ ರಮಣಿ ಹಂಬಲನೊಲ್ಲ ಭಾಷಿಗ ನಿವನ್ಯಾರಮ್ಮ ಲೇಸಾಗಿ ಜನರ ಸಲಹುವಕ್ಕಾಗಿ ನೆಲೆಯಾದೆ ಭಾಷಿಗ ದಾಸ ಕಣೆ ಅಮ್ಮಯ್ಯ ನಮ್ಮಮ್ಮ ಶಾರದೆ ಉಮಾ ಮಹೇಶ್ವರಿ ನಿಮ್ಮೊಳಗೆ ಹನ್ಯಾರಮ್ಮ ನಿಮ್ಮೊಳಗೆ ಹನ್ಯಾರಮ್ಮ ಥ್ಯಾಂಕ್ ಯು.
For the melodious invocation. With that divine beginning, let us move ahead with the IMA prayer. Hence, may I request Dr. Suriraju V, the Honorable Secretary of IMA Chitradurga, to kindly lead us in the IMA prayer and flag salutation. Let us all rise for the IMA prayer, and may this prayer remind us of our duty to serve humanity with compassion, dedication, and integrity.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ, ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಿರಲಿ. ಧ್ವಜವಂದನೆ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜಕ್ಕೆ ವಂದನೆ ಸಲ್ಲಿಸಲು ಇಲ್ಲಿ ನಿಂತಿದ್ದೇವೆ. ಅದರ ಗೌರವ ಮತ್ತು ವೈಭವವೇ ನಮ್ಮ ಬೆಳಕು ಮತ್ತು ಶಕ್ತಿ, ಮತ್ತು ಅದರ ಪಥವೇ ನಮ್ಮ ಪಥವು. ಈ ರಾಷ್ಟ್ರೀಯ ಸಂಸ್ಥೆಯ ಮಾನ್ಯತೆ ಪಡೆದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ಜವಾಬ್ದಾರಿಗಳನ್ನು ಅರಿಯುವ ಮೂಲಕ ಅದಕ್ಕೆ ನಮ್ಮ ನಿಷ್ಠೆಯನ್ನು ತೋರಿಸುವ ಪ್ರತಿಜ್ಞೆ ಮಾಡುತ್ತಿದ್ದೇವೆ. ದೇಶ ಸಮೂಹಗಳ ನಡುವೆ ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜವು ಉನ್ನತ ಮಟ್ಟದಲ್ಲಿ ಹಾರಾಡುವ ಸಲುವಾಗಿ ನಮ್ಮ ಅಧಿಕಾರದಲ್ಲಿರುವ ಎಲ್ಲವನ್ನೂ ಅದಕ್ಕೆ ಸಮರ್ಪಿಸುವ ಪ್ರಮಾಣ ಮಾಡುತ್ತಿದ್ದೇವೆ. ಜೈ ಹಿಂದ್. IMA ಚಿರಾಯುವಾಗಿರಲಿ. ವಂದನೆಗಳು.
Thank you, sir, for graciously leading us in the IMA prayer and invoking an auspicious beginning for today's proceedings.
Every grand journey begins with a warm welcome. To set the tone for today's program, I invite Dr. S.Y. Mulki Patil, Chairman, IMA Academy of Medical Specialties, Karnataka State Branch, to deliver the welcome address.
Good afternoon, respected dignitaries on the dais, of the dais. With immense pride and pleasure, I am standing before you to welcome this today's event. Under one Chitradurga branch, multiple events are taking place today. To name, one is IMA AMS Academy of Medical Specialty State Conference, along with South India Zonal Conference, followed by evening state level Teachers Day. So for this, so many branches, what we heard and what we are witnessing combined together along with the Chitradurga branch, they joined their hands to conduct this program. As we know all, IMA works in 3-tier system, like a national headquarters, state branch, as well as local branch. So IMA AMS, many people may not be heard about IMA AMS. It's a one wing of IMA branch, starts from the headquarters. We have IMA AMS headquarters, headed by Dr. Ramnik Bedi, chairman. Like that, we have a state IMA AMS branch, as well as we have a district level branches too. IMA AMS is having various specialty fellowship programs. Particularly from the Karnataka, we have currently 2 programs. One is Garbhagudi Hospital Infertility Center, which is located at the Bangalore. And this year, we also started one more andrology fellowship program by the Ankur Hospital. I think we witnessed the one stall by Mr. Josephine here. So like that, various activities are conducted by under IMA AMS. So we are here gathered to celebrate our annual conference. The conference stands testament to not only the clinical or the advancement in the medical, but also joining hands, as the name suggests, compost. I think Dr. Narayan Murthy sir, organizing chairman, will tell. Many people are eager to know what exactly the compost means. So it is a unity coming all together, various branches, starting from the headquarters, state, as well as Chitradurga branch and all. So many people, they have put their the countless hours of time in planning, as well as execution, collaboration, and also coordination. And also we witness a dedicated teamwork since, the weeks to or months together. So as a result, we are witnessing an excellent conference as well as the academic feast here. So I'm deeply honored to see the culminated effect of this countless hours of the people, which they have started from the minds, from the hands, from the hearts. So now it's time to welcome all these people for this conference. So I welcome on the behalf of IMA AMS State, IMA AMS South Zone, and also organizing team, that is IMA Chitradurga branch. Today's chief guest, who is going to inaugurate, Dr. Bidinar sir, for attending this from the headquarters side. He is also headquarters Vice President. I welcome you on the behalf of host branch, Chitradurga. You name anything, Dr. Bidnal sir, any day for that matter. Every day he's posting the importance of that. That's how, and also his commitment, social work towards many times. We witnessed even in COVID, even in floods also, we come across his. So thank you, sir, for coming all the way and attending this program. We also extend one more dynamic personality from the headquarters, President, Chairman-elect IMA AMS Headquarter, Dr. Venkatachalapati. On the behalf of all, I welcome you, sir, for this. He was a very vibrant IMA KSB president who almost covered more than 140 branches visit during his tenure. On the behalf of all, I welcome you, sir. Yes. We welcome our leader. Any organization, we have a face. So that face leader is none other than Dr. Chinivalar, sir. Our KSB president, we welcome you, sir. Murthy Chikkadadaru Kirti Doddannoge. So, sir, again, almost he is on the way to break the record of Dr. Venkatachalapati, visiting various branches as well as taking all the activities of IMA KSB. Again, I welcome you, sir. We also, on the behalf of host, we welcome our president-elect, Dr. Veerbhadraya, sir. On the behalf of Chitradurga branch and organizing team, I welcome you, sir. And also extend heartfelt welcome to our dynamic secretary, KSB, IMA KSB, Dr. Suryaraju, sir. Dr. Shankar Narayan, sir, who is a treasurer of IMA KSB. I also welcome you, sir, for this function. As I said, this is the teamwork Chitradurga witnessed, we all are witnessing. Team starts from the Basaveshwara Medical College, headed by our beloved Dean, Dr. Prashant, sir. We welcome you, sir. Again, to witness, it's not only the one institute, he is a part of this. One more director, Dr. Yuvraj, sir, director of the Chitradurga Medical Institute. On the behalf of all, I welcome you, sir. I also extend a warm welcome to Basaveshwara Medical College Medical Student, Dr. Rajesh, sir. Welcome you, sir, for this function. Yes, for any program to happen like this, we have to have a very dynamic, a dedicated team member, which we are seeing since almost months together. The entire pain is taken by Chitradurga branch. That is, I once again formally welcome Chitradurga IMA President, Dr. Palakshaya, sir, for this. And Dr. Prahlad, sir, Secretary IMA Chitradurga. I welcome you, sir. As I said earlier, the one more silent worker, most of the times planning, the countless hours dedication towards the IMA as well as towards the IMA AMS conference. That is none other than organizing chairmans. I welcome Dr. Narayan Murthy, sir, as well as Dr. S.P. Ravindra, sir, organizing chairmans of this conference. I also extend a warm welcome to the District Health Authority, DHO, sir, Dr. Renu Prasad, sir, for this. On the behalf of organizing team, I welcome you, sir, for this function. I also welcome our IMA AMS KSB Secretary, Dr. Manjunath, sir, who is always, the backbone, always with me for any activity. I'll welcome you, sir. And behind the screen, there are so many people working. I also welcome Dr. Yogendra as well as Dr. Megha Madam. Both are organizing secretary for this function. This conference witnesses, it is a synergy between the teamwork, scientific, academic, as well as even the part of the compost, that is the sum of the administrative events. So hope the entire conference will spark some scientific new ideas and also tie the good old concept of the scientific evidence. So with this, once again, I welcome all the scientific committee members and all the organizing team, all the previous past president, speakers, and particularly to name Dr. Masudin Karignur, past president of IMA KSB, who was behind the screen all the time. He'll be working, and also all the speakers, sponsors, and also the delegates, postgraduates, undergraduates, and most important, our MOC interns and students who were working, the almost midnight till midnight, what we used to see since almost few days. So also, there are some sponsors who installed the stalls, to name few, like Joshvin, that is a Master Health, is a part of the IMA, AMS, the fellowship, as well as one of the international NGO people also here, MSF, that is French organization basically, Medicine Sans Frontier. The Indian version is Doctors Without Borders. I think they are here. So who are doing excellent work, committed, dedicated work towards that. They are here for awareness as well as fundraise. I welcome once again, all the sponsors and everybody. Yes, we are in the medical college campus. Yes, if the activities conducted here, those who attend here, yes, definitely they are going to know what is happening in the IMA AMS or in the IMA AMS conference. But along with this, in the four walls, there are some people who can take the scientific as well as public health related to the public, that is the media people. I also welcome the media friends here, those who are attending. And also, I think the YouTube live channel is going on. All the watchers on the online platform also. Once again, I welcome all. Individually, we can do little. Together, we can do a wonderful work like this. Thank you once again. Thank you all.
Thank you, sir, for your gracious words of welcome. We now welcome Dr. S.Y. Mulki Patil, sir, Chairman, IMA AMS, Karnataka State Branch. We welcome you, sir.
We now come to the most awaited moment, the formal inauguration of Academy of Medical Specialties South Zone Conference 2025.
We begin this special occasion by invoking the spirit of growth, sustainability, and new beginnings. May I now request our chief guest, Dr. G.B. Bidinal, sir, and other dignitaries on the dais to kindly join in this inaugural ceremony. To mark the inauguration of this conference, we perform the symbolic act of watering a plant. Just as a plant grows when nurtured with care, knowledge, and ideas, flourish when we come together to share, learn, and collaborate.
I request Madhusudan sir to please join the inaugural ceremony.
This simple yet meaningful gesture reminds us of our responsibility to foster not just innovation and progress, but also harmony with nature. With this, we officially set the tone for our conference, hoping it will be as fruitful and enriching as the life we nurture in this plant today.
Thank you, esteemed dignitaries.
I now invite Dr. Narayan Murthy C. Sir, Chairman, IMA AMS Karnataka State Branch, to present an overview of Academy of Medical Specialties South Zone Conference 2025.
Good afternoon, one and all. Dignitaries on the dais, off the dais, my senior colleagues, students, volunteers, press media, and everyone. As Mulki Patil sir said, 3 events are going on today. State IMA AMS Conference, South Zone IMA AMS Conference, followed by Teachers' Day celebration by IMA KSB. So now we are witnessing inaugural ceremony of the IMA AMS Conference. Friends, it's a privilege to present the overview of the conference, assuming the post of one of the organizing chairman. Another organizing chairman is S.P. Ravindra sir. So at the outset, I thank office bearers of IMA AMS National, IMA AMS State Branch, and IMA KSB office bearers for giving the wonderful opportunity to host this program. Thank you, sir. I am thankful to Palakshappa sir and Prahlad sir and entire team of Chitradurga IMA members. If I start telling the names, I may miss many. So thanks to all who directly involved and indirectly involved for the success of this program. I'll take a different platform to mention each and everyone and acknowledge the support given to us. Friends, let me not forget the support given by 2 medical colleges, BMCH and Chitradurga Institute of Medical Sciences, dean, staff, and everyone. So thanks to all the staff. But let me tell you one thing, Dr. Prashant sir, who is a dean of Basaveshwara Medical College, who was with us as a volunteer from almost last 10-15 days in spite of his busy schedule. So what you are sitting is in first program of the auditorium. So he was there for each and everything, right from the audiovisual system, projection, everything. Heartfelt thanks to you, sir. And also they are hosting nice breakfast and lunch further. Thanks to management and all the administrative staff of Basaveshwara Medical College, represented by Prashant sir and Rajesh sir. Friends, it all started with the almost 6-7 months back, started with the phone call from Mulki Patil sir, who is an IMA AMS president, then followed by phone calls from Chiniwala sir, pressure from Madhusudan Karignur sir, so that we must conduct IMA AMS conference. Actually, we wanted to host IMA state conference for that matter, but because of the valid reasons Gangavati friends are conducting, we wish good luck from this platform. And we got an opportunity to host this program. Then adding to this additional responsibility of conducting South Zone also came into line. I feel it is very lucky to host South Zone conference, which involves 5 states. So then we started including the unique idea of giving an opportunity to present papers for the faculty, teaching staff, PGs and UGs. Friends, we are today, as of date, there are 600 plus registrations for this conference and 100 plus paper presentation, and pathology 39 paper presentations. So to do this, we wanted a good team. Thanks to each and everyone. So to this also meticulously each and everyone worked, not only for the scientific session, but also for the food, also for the banquet, unique banquet, which you will be witnessing tonight. So everything was taken care. wonderful young team is with us. Friends, YouTube live telecast of this program, as Mulki Patil sir said, it is live telecast is going on. I am excited and eagerly waiting how many will log in. I am just curious to know the number also. The friends who are not able to come to witness on spot, so they can utilize that opportunity too. And have you seen the delegate kits? There is one plant seeds that is given in that, and we have boldly written as not edible, not to think that it is chocolate and take. So please take those seeds and plant it near your house. We are just sending the message from Fort City, Chitradurga to go green, give prints wherever it is required, minimal use of plastic, save the environment. Thank you one and all. If I missed any names in presenting this thing, please excuse me. Thanks to one and all.
Thank you, sir, for outlining the vision of this conference. Now, I request our esteemed president to kindly unveil the souvenir as a token of memories and milestones marking this special occasion. It is an e-souvenir, so everybody can access it online. I kindly request Dr. Timmareddy sir to please join the souvenir reveal.
I kindly request Dr. Amruta ma'am and Dr. Vijayalakshmi ma'am to please on stage. Thank you, everyone. Now I request Dr. G.B. Bidinal sir, National Vice President, IMA, Academy of Medical Specialties, to enlighten us with his inaugural speech.
Good afternoon to all delegates and dignitaries on the dais. Karnataka State President Dr. V.V. Chinivalar and President-elect Dr. Veerbhadraya, Secretary Dr. Suri Raju and Dr. IMA-AMS Chairman Dr. Venkatachalapati and Director of the Basveshwar Medical College, Urology, and Dr. Prashant and Dr. Palakshaya and Rajesh, Medical Student, Manjunath Nekar, and past Vice President and Organizing Chairman of the conference, Dr. Narayana Murthy, Renu Prasad, and Dr. Shankar Narayan, and Dr. past President of the Karnataka State Bank, Dr. Madhusudan Karinur, Dr. Saranappa, and all my friends. I got immense pleasure to become the chief guest of this function because I came from the holy land of Kumaravasa Gadag and holy place of Putras Panchakshari Gavaigalu, who created the paradise for the blind and handicapped people. And Komu communal harmony, Swami Tonta Siddhalinga Swamiji, I hail from that area, Veeranayan temple, and Kumaravasa, who wrote Mahabharata as a Gadugina Bharata, Karnataka Katha Manjari, to the place, historic place of Madakari Nayaka and Vanake Obava as a chief guest. Really, I am very much overwhelming happiness to become the chief guest of this function. Dr. Mulki Patil during his welcome address, he told many things about the IMA-AMS. Really, it is one of the wing, Academy of Medical Specialties. This is one of the wing of the Indian Medical Association. Academy of Medical Specialties was formed in the year 1979 by the visionaries of Indian Medical Association with an intention of providing forum for the specialists of all branches of medicine to discuss the academic matters of multidisciplinary interest. The main objective of IMAMS is to update the recent advances in all specialties for the better clinical judgment in their practice and to improve their practice skill. It will also motivate the specialists to actively participate in all the activities of the Indian Medical Association. And Chitradurga branch is one of the vibrant branch in the Karnataka state. Now we saw the amount of academic feast in this conference. The headquarters of Office of IMA, Academy of Medical Specialties functioning in the IMA House, New Delhi, has been shifted permanently to Hyderabad with effect from 1st April 2008. It is located in IMA building, Hyderabad. The membership of Academy of Medical Specialties is open to all life members of IMA who have specialty qualifications in any discipline of the medicine. The fellows of College of General Practitioners who have passed FCGC examination are also eligible to become the members of Academy of Medical Specialties as they have specialized in the field of family medicine. The Academy of Medical Specialties also awards fellowships to the senior members of the profession, and Academy also proposes to organize training program in different fields of medicine and also conduct AMS certification courses. Just now Dr. Mulkipal elaborated about that. The main objectives of the IMA-AMS are to provide forum for the specialists to discuss academic matters. Just now we discussed about hematology. He has given a very nice elaboration about the clinical presentation of each cases. Different cases he has elaborated. Discuss the academic matters, update them on recent advances in medical specialties for the better clinical judgment, to motivate members of the Academy of Medical Specialties to participate in IMA activities and IMA Academy of Medical Specialty activities. The broader objective of the parent Indian Medical Association, which IMA supports, include advancing medical sciences, improving public health and education, upholding the medical profession's honor and dignity, and promoting the cooperation among our members. To serve as a platform of specialists from all branches of medicine to exchange the ideas and discuss multidisciplinary academic topics, continuing medical education, to keep the specialists updated on the latest advancement in their respective fields, thereby improving their clinical judgment and practice. Motivation for IMA participation, to encourage specialists to actively engage in the various activities organized by Indian Medical Association, to attend the conference, state level annual conference and AMS conference, and even annual medical legal conference, to update their knowledge. The broader objective of the Indian Medical Association, supported by IMAMS, the advancements of medical science, to promote and advance medical and allied sciences and improvement of public health and medical education, professional integrity, to maintain honor, dignity, and uphold the interests of medical profession and professional cooperation, to foster cooperation and collaboration among its members, abolition of professional compartmentalism, to work towards the elimination of barriers in the medical education, services, and registration to achieve the equality within our Indian Medical Association members. And also, IMA Academy of Specialties is very interested in professional training. A specialized training and fellowship courses in various medical specialties conducted by experts in the respective fields. Just now, Dr. Mulki Patil told about the infertility training. Skill development. The wing of focus is on updating the doctor's knowledge and skills in new developments and techniques with medicine. And conferences. IMA AMS organizes national, zonal. Now I am representing for South Zone IMA AMS conference. Actually, our national president, Dr. Dilip Bhanusali, visited Gadag branch, organized this state level medico-legal conference. On that day, June 14th, he has told me, Dr. Bidnal, you have to accompany me on 6th of September to attend the Chitradurga AMS conference. But because of unavoidable circumstances, he has entrusted his work to me. That's why I came in his place, I came as a chief guest. Really, I am delighted to become the chief guest of this Chitradurga holy and historical place of Madhukari Nayaka and Vanakeva Bhava. The conferences, AMS conference, recognition, Academy of Specialties recognizes training centers that run its fellowship courses, certificate courses are awarded to the doctors who complete training programs. Who has become members? Any IMA member can become the IMA AMS member. Branch, state branch. Any state branch which has got more than 100 members, any state in India can start their AMS. And even any branch who register the membership of more than 20, they can recognize as IMS local branch. Even in this Vadalkere branch or even this any Chitradurga, Hiriyur branch, any branch which crosses the 20 number mark AMS members, they can start the IMA AMS branch. Therefore, this is one of the wing of the National Indian Medical Association. Therefore, I am very happy to attend. This is both Karnataka State AMS, IMA AMS conference and South Zone. Almost all South Zone is almost 6 states. I am in charge of 6 states. Telangana, Andhra Pradesh, Kerala, Tamil Nadu, Pondicherry, Karnataka. All 6 states will come under South Zone, and this conference is IMA AMS South Zone as well as IMA AMS Karnataka State Branch conference. Really, it is a very good arrangement has been done. Really, morning when I came, I attended the hematology topic. Really, I am influenced by that topic. Every case he has a case-wise presentation was very nice, and investigation-wise and even treatment-wise was very nice by him. Really, all topics must be like this only. Dr. Mulki Patil was telling, sir, they have organized very well. You come early because today morning I left Gadag at 8 o'clock. I reached at 11 o'clock, 11 a.m. Then after then I came to here. Really, I must thank to all the organizers of the Chitradurga branch. I attended Chitradurga conference just in the year 13. In the year 2013, I attended. It was very nice conference. It was very nice conference. I attended that conference also. And this year also, they wanted to conduct state level IMA conference because already they have conducted once. We all together, they only voluntarily give to the IMA Gangavati branch. They are also doing very well, and they are almost very daily, weekly wise they will conduct meetings. Really, we must be very. Yes, Chitradurga Gangavati is very nearby. See, AMA AMS conference in Chitradurga, IMA conference in Gangavati, and all. I'll request all the members. We are one among one under one umbrella. We are all one. Unity is a strength. When we united together, we are very strengthful. Therefore, for any matters, we must united and fight together, even during for violence and bringing the clinical establishment. And our Karnataka state government has already brought a very good violence act against prohibition of violence. It's one of the best in India. Karnataka state prohibition against violence act is one of the best among India. Therefore, we are, because of our members, Dr. Chinwalar, Dr. Yoganand Reddy, Dr. Madhusudan Karinur, Dr. Pawan Patel, many people, Dr. Veerbhadre, all, Dr. Venkatachalapati, all leaders of IMA has went to Law Minister of Karnataka State Branch, and they have brought the law act very nicely. Really, I am very thankful to IMA Karnataka State Branch, and also all the members of IMA Chitradurga Branch. Yes, really I am very happy. I will close my talk by thanking all the members, and all the members, office bearers of Karnataka State Branch, all the office bearers of this organizing committee of IMA AMS conference, all district, they will include all district branches also, Chitradurga district branches. I am thanking all. I close my topic and my lecture. Thank you one and all. Bolo Bharat Mata ki, Bolo Bharat Mata ki. IMA Chirai Wagli. Jai Hind.
Thank you, sir, for those inspiring words. Now, with great respect, I invite Dr. Prashant G, the Dean of Basaveshwara Medical College and Hospital, Chitradurga, to kindly address the gathering with a few words.
Dignitaries, good afternoon, everybody. Dignitaries on the dais, the IMA, the President, the Honorary Vice President who has come over here, and all the other dignitaries and the office bearers and the dear colleagues and the students and other people who have participated in this conference. It is indeed a great pleasure to welcome you all to Chitradurga, that is especially the Basaveshwara Medical College and Hospital. When we got the opportunity to be a part of this program, definitely it is our pleasure and it's a pride for us to host this sort of conference, which has got of a significance in terms of conducting an academic feast as well as other two activities as at South Zone Conference as well as the Teachers' Day celebration. All together it's a feast which we definitely take it as a pride. On behalf of Basaveshwara Medical College and Hospital and from the management and the colleagues, I definitely think it's a great privilege and honor. It has been endured on us to conduct this sort of conference. Without taking much time, I definitely welcome you all for this conference. Let the conference have great message and the academic feast ahead. And once again, I thank you from all for it.
Thank you, sir. Next on, I request Dr. Yuvraj B.Y. sir, the Director of Chitradurga Medical College and Research Institute, to share his thoughts with us.
Respected dignitaries, distinguished members, and organizing committee of Indian Medical Association, esteemed colleagues, my dear students, media personals, ladies and gentlemen. It is really an honor for me to address this august gathering today the Academy of Medical Specialties, which is organized by Indian Medical Association in coordination with Basaveshwara Medical College and Hospital. Often I feel proud with the vision of His Highness or Holiness, Dr. B.C. Roy, where IMA has made a remarkable changes for the betterment of medical professionals in India. The time has come for us to collectively strengthen the patient-centered care, medical education, and research through meaningful inter-institutional collaboration. In a district like Chitradurga, where health and economic indicators still remains below the state average, our combined effort must focus on disease prevention, health promotion, and accessible and affordable curative services. This can be achieved only by empowering our dedicated medical and paramedical workforce. Such an approach will also help to reduce the catastrophic burden of out-of-pocket expenditure on patients. I appeal to the esteemed IMA to take proactive steps in extending comprehensive health insurance schemes for doctors and their families and paramedical professionals. At the same time, certification programs in basic life support, emergency care, and public health preparedness for student communities and healthcare workers must be prioritized to build a robust and resilient healthcare ecosystem. Together, let us move forward with commitment, compassion, and collaboration to shape a better healthcare in the future. I heartily thank all of you, the organizers, for inviting me today here. Om Sarve Bhavantu Sukhinaha, Sarve Santu Niramaya. Jai Hind.
Thank you, sir. I now request Dr. Palakshaya L. to felicitate our pathology judges, Dr. Vijay Shankar sir, KCIAPM President, Dr. Rashmi, Professor and HOD, Department of Pathology, Siddhganga Institute of Medical Sciences, Dr. Vardendra Kulkarni, Professor and HOD of Department of Pathology, JJM Medical College and Hospital, Davangere, Dr. Sonam Nandyal, and Dr. Ramu R., Professor, Department of Pathology, Basaveshwara Medical College and Hospital, Chitradurga. everyone. Now I invite Dr. Rajesh MS, Medical Superintendent of Basveshwara Medical College and Hospital, Chitradurga, to kindly speak a few words on this occasion.
Good afternoon, everybody. Respected dignitaries on the dais, off the dais, dear colleagues, friends. It is a great honor to conduct this conference in our premises. Our president has been very generous in accepting to host this conference at the request of IMA. Indeed, it is a great honor to also conduct all these academic activities. I hope all the doctors who are here take a good message back home and improve their knowledge and implement the same in their practice. Thank you one and all for giving me this opportunity to talk a few words. Thank you.
Thank you, sir. It is now my privilege to invite the President, IMA Karnataka State Branch, to address this gathering.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ವೇದಿಕೆಯ ಮೇಲಿರುವ ಎಲ್ಲ ಗಣ್ಯಮಾನ್ಯರಿಗೆ, ವೇದಿಕೆಯ ಮುಂಭಾಗದಲ್ಲಿರುವ ಎಲ್ಲ ಗಣ್ಯರಿಗೆ, ಶಿಕ್ಷಕ ವೃಂದಕ್ಕೆ, ವಿದ್ಯಾರ್ಥಿನಿಯರಿಗೆ ಎಲ್ಲರಿಗೂ ಸ್ವಾಗತ, ಸುಸ್ವಾಗತ. ಚಿತ್ರದುರ್ಗ ಕನ್ನಡದ ಒಂದು ಗಂಡು ಮಟ್ಟಿನ ನೆಲ ಎಂದರೆ ತಪ್ಪಾಗಲಿಕ್ಕಿಲ್ಲ. ಯಾಕೆಂದರೆ ಇದು ಮದಕರಿ ನಾಯಕರು ಆಳಿದಂಥ ಮತ್ತು ಒನಕೆ ಓಬವ್ವನ ಒಂದು ಶೌರ್ಯದ ಪ್ರತೀಕದ ಒಂದು ಸ್ಥಳ ಅಂತ ಇದು. ಸೊ ಇಂಥ ಒಂದು ಸ್ಥಳದಲ್ಲಿ ಕನ್ನಡದ ಗಂಡುಮೆಟ್ಟಿನ ನಾಡಿನಾದಂಥ ಚಿತ್ರದುರ್ಗದಲ್ಲಿ ನಾನು ಕನ್ನಡದಲ್ಲಿಯೇ ನನ್ನ ಒಂದು ಭಾಷಾ ನುಡಿಗಳನ್ನು ನಾನು ನುಡಿಬೇಕಂತ ಅನಿಸ್ತಾ ಇದೆ. ಅದಕ್ಕೆ ಕನ್ನಡದಲ್ಲಿಯೇ ನಾನು ಪ್ರಾರಂಭ ಮಾಡ್ತಿದ್ದೀನಿ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಚಿತ್ರದುರ್ಗ ಶಾಖೆಯ ಮತ್ತು AMS ರಾಜ್ಯ ಶಾಖೆಯ ಮತ್ತು ಸೌತ್ ಝೋನ್ದ ಪದಾಧಿಕಾರಿಗಳೇ, ಸದಸ್ಯರೇ, ಇಂದು ಇಲ್ಲಿ ಸಮ್ಮೇಳನಕ್ಕಾಗಿ ಹಾಜರಾಗಿರುವ ಎಲ್ಲ ಪ್ರತಿಷ್ಠಿತ ವೈದ್ಯ ಬಳಗಕ್ಕೆ ನನ್ನ ಹೃತ್ಪೂರ್ವಕ ವಂದನೆಗಳು. ವೈದ್ಯ ವೃತ್ತಿ ಎಂದರೆ ಕೇವಲ ಉದ್ಯೋಗವಲ್ಲ, ಅದು ಒಂದು ವೃತ್ತಿ ಧರ್ಮ, ಜನಸೇವೆಯ ದಾರಿ. ಪ್ರತಿದಿನ ನಾವೆಲ್ಲರೂ ನಮ್ಮ ಜ್ಞಾನ, ಕೌಶಲ್ಯ ಮತ್ತು ತ್ಯಾಗಗಳ ಮೂಲಕ ಮಾನವ ಜೀವವನ್ನು ರಕ್ಷಿಸುವ ಗಂಭೀರ ಹೊಣೆ ಹೊತ್ತಿರುತ್ತೇವೆ. IMA AMS ಎಂಬ ವೇದಿಕೆ ನಮಗೆ ವಿಶೇಷತೆಯ ವೈದ್ಯರನ್ನು ಒಂದೇ ವೇದಿಕೆಯ ಅಡಿಯಲ್ಲಿ ಕೂಡಿಸಿ ಪರಸ್ಪರ ಜ್ಞಾನ ಹಂಚಲು, ಸಂಶೋಧನೆಗೆ ಉತ್ತೇಜನ ನೀಡಲು ಹಾಗೂ ಹೊಸ ಆವಿಷ್ಕಾರಗಳಿಗೆ ದಾರಿ ತೋರಲು ಸಹಾಯಕವಾಗುತ್ತದೆ. ಈಗಿನ ವೈದ್ಯಕೀಯ ಕ್ಷೇತ್ರವು ಅತಿ ವೇಗವಾಗಿ ಬದಲಾಗುತ್ತಿದೆ. ಕೃತಕ ಬುದ್ಧಿಮತ್ತೆ, ನವೀನ ತಂತ್ರಜ್ಞಾನಗಳು, ನೂತನ ಔಷಧೋಪಚಾರ ಇವುಗಳಿಗೆಲ್ಲ ಹೊಸ ವಿಧಾನಗಳು ರೋಗಿಗೆ ಚಿಕಿತ್ಸೆ ನೀಡುವುದರಲ್ಲಿ ಪ್ರಮುಖ ಅಸ್ತ್ರಗಳಾಗುತ್ತಿವೆ. ಆದರೆ ಯಾವುದೇ ತಂತ್ರಜ್ಞಾನ ಬಂದರೂ ವೈದ್ಯ ರೋಗಿ ಸಂಬಂಧದ ಮಾನವೀಯ ಸ್ಪರ್ಶವೇ ವೈದ್ಯಕೀಯದ ಹೃದಯ. ಅದನ್ನು ನಾವುಗಳು ಎಂದಿಗೂ ಕಳೆದುಕೊಳ್ಳಬಾರದು. ಇಂದು ಈ ಸಮ್ಮೇಳನದಲ್ಲಿ ನಾವು ಚರ್ಚಿಸುವ ವಿಷಯಗಳು ಹೊಸ ಚಿಕಿತ್ಸಾ ವಿಧಾನಗಳು, ತಜ್ಞರ ಅನುಭವ ಹಂಚಿಕೆ, ಯುವ ವೈದ್ಯರಿಗೆ ಮಾರ್ಗದರ್ಶನ ಹಾಗೂ ಸಮಾಜದ ಆರೋಗ್ಯಕ್ಕೆ ಸಂಬಂಧಿಸಿದ ನೀತಿಗಳ ಮೇಲೆ ಚಿಂತನೆ. ಇವುಗಳು ನಮ್ಮನ್ನು ಇನ್ನಷ್ಟು ಸಮರ್ಥವಾಗಿ ಸಮಾಜದ ಸೇವೆಗೆ ಸಿದ್ಧಗೊಳಿಸುತ್ತವೆ. ವೈದ್ಯ ವೃತ್ತಿಗೆ ಎದುರಾಗಿರುವ ಸವಾಲುಗಳು ಕಡಿಮೆ ಏನಿಲ್ಲ. ವೈದ್ಯರ ಮೇಲೆ ಹಲ್ಲೆ, ಸರ್ಕಾರದ ಕಾನೂನು ಸಮಸ್ಯೆಗಳು, ಅನಾವಶ್ಯಕ ಒತ್ತಡಗಳು. ಆದರೆ ನಾವು ಒಗ್ಗಟ್ಟಿನಿಂದ ನಿಂತರೆ ಮಾತ್ರ ನಮ್ಮ ಧ್ವನಿಗೆ ತೂಕ ಬರುತ್ತದೆ. IMA ಮತ್ತು AMS ವೇದಿಕೆಗಳು ನಮಗೆ ಆ ಶಕ್ತಿ ನೀಡುತ್ತವೆ. ಈ ಸಮ್ಮೇಳನವನ್ನು ಯಶಸ್ವಿಯಾಗಿಸಲು ಶ್ರಮಿಸಿರುವ ಚಿತ್ರದುರ್ಗ IMA ಪದಾಧಿಕಾರಿಗಳಿಗೆ, ಸದಸ್ಯರಿಗೆ, AMS ಸಹೋದ್ಯೋಗಿಗಳಿಗೆ ಹಾಗೂ ಪಾಲ್ಗೊಂಡಿರುವ ಪ್ರತಿಯೊಬ್ಬರಿಗೂ ನಾನು ನನ್ನ ಹೃತ್ಪೂರ್ವಕ ಅಭಿನಂದನೆಗಳನ್ನು ತಿಳಿಸುತ್ತಾ ನನ್ನ ಎರಡು ಮಾತುಗಳನ್ನು ಮುಗಿಸ್ತೇನೆ.
Thank you, Dr. V.V. Chinivalar, sir. Now I request Dr. Palakshaya L. sir to felicitate our guest, Dr. G.B. Bidinar, National Vice President IMA, and Dr. Venkata Chalapati, Chairman-elect IMA Academy of Medical Specialties. Now I request Dr. Palakshaya sir to felicitate Dr. Venkata Chalapati sir, Chairman-elect, IMA Academy of Medical Specialities.
Thank you very much. Thank you very much, Dr. Palakshaya sir, for honoring our guests. Now I invite Dr. Palakshaya sir, IMA President Chitradurga, to kindly deliver the presidential address.
Dignitaries on the dais, as IMA President, I thank everybody, our organizing committee, Dr. Narayan Murthy, Dr. Megha, Dr. Yogendra, Dr. Ravindra, and also I thank our surgeons. We are helped everybody. We are IMA from Chitradurga. We are sincerely made an effort to success this conference. Thank you.
Thank you, sir. To express our gratitude, may I now invite Dr. Prahalad NB, Honorable Secretary, IMA Chitradurga, to deliver the vote of thanks.
Yeah. Good afternoon, everyone. I am standing between you and a wonderful lunch. It's a matter of proud privilege for me, specifically this program, because 3 of my classmates are on stage in different capacities. Dr. Renu Prasad, DHO of Chitradurga district. Then we have Dr. Veerbhadraya from Tumkur. He happens to be the incoming IMA president. Then we have our beloved president, Dr. Palakshaya here. If I want to start thanking, I should start thanking, I should go back ages, centuries back, because this organization was started by a visionary who changed the course of events in the state, Sri Bhakti Bandari Basavanna. Because he started that lineage, and this organization was set up about 600 back by one Swamiji, Shantavira Murugis Shantavira Swamiji, we call him. He decided to stay in this place so that this organization could start. And to him, the patronage was done by the king, the then king, the Bichugati Brahmana Nayaka. I think we should be thanking them so that this organization started. And there was a long lineage of Swamijis who saw to that, it became like, the Mysore Maharajas once acknowledged them as Navakoti Narayanas. So that tradition has been continuing that tradition. When we wanted to organize this event, our beloved Dean, he wholeheartedly agreed immediately. Yes, we shall have it. And because of him, this in, I'll tell you, record time, this auditorium was constructed. This examination hall was converted into a mini auditorium so that we could have this program. I wholeheartedly thank him to start with. Okay, and also initially our vision was to have an IMA state conference here, but we had to give it away to our beloved president is here. One smile we lost, his beautiful smile. When we were contesting for this event, to get this event, they were celebrating our 60th, installation or 60th program of IMA Gangavati. Then we said, as a brotherhood, I think we should give it away. So they are going to host that. I think we should be taking part in that. And thank you, sir. But instead, we got this event. That is mainly because of Dr. Mulki Patil, sir. He is here. And also, I am a president. Okay, I said, if not IMA conference, you go and organize this event, IMS Con. So because of them, we are organizing this event. and also to grace this event, we have the Bidinal sir and also Venkatapatacharya sir. You know, both of them, they have come all the way, you know, they left their work, they practice everything. This thing. Sometimes I wonder, how did these IMA officials function? You know, IMA, organizing IMA events, participating, even conducting various official activities, not easy. They have to give up their practice, a lot of their time, family time, everything, because IMA is a movement. They're all committed to, like for example, we have, where is Dr. Madhusudan Karingnur sir? You know, Dr. Madhusudan Karingnur sir, Malki Padil sir, and IMA president himself personally called me early morning. Engri Pladre, Nan IMA president re, Engri the arrangements illa. That really touched my heart. This is IMA brotherhood, you know. We are all doctors doing this. Then we also have our secretary, IMA secretary, who has come all the way from Bangalore. You know, he has left his activity and he's here with us. And also all my Chitradurga team is here sitting on the stage. And above all, our volunteers, they have worked day and night. I think we should all give a big, you know, applause for them, for all of them. And we also have a secretary, Dr. Manjunath Neka. He is here since yesterday to see that, you know, everything, you know, they went through the program, whole program, so that they streamlined everything so that there are no hiccups here in this program. I wholeheartedly thank all of them. Yes, sir.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಮುಂದಿನ ತಿಂಗಳು ಅಕ್ಟೋಬರ್ 24, 25, 26 ನಮ್ಮ ಕರ್ನಾಟಕ ರಾಜ್ಯದ ಸ್ಟೇಟ್ ಎನ್ಯುವಲ್ ಕಾನ್ಫರೆನ್ಸು ಗಂಗಾವತಿಯಲ್ಲಿ ನಡೀತಾ ಇದೆ. ದಯವಿಟ್ಟು ಏನಂತಲ್ಲ ಎಲ್ಲ ಆ ಒಂದು ಸಮ್ಮೇಳನಕ್ಕೆ, ಕಾನ್ಫರೆನ್ಸಿಗೆ ದಯವಿಟ್ಟು ಚಿತ್ರದುರ್ಗದಿಂದ ಸಾಕಷ್ಟು ಸಂಖ್ಯೆಯಲ್ಲಿ ಬಂದು ಭಾಗವಹಿಸಿ ನಮ್ಮ ಒಂದು ಆ ಸಮ್ಮೇಳನವನ್ನು ಯಶಸ್ವಿಗೊಳಿಸಬೇಕು ಅಂಥೇಳಿ ನಾನು ಕೇಳಿಕೊಳ್ತಾ ಇದ್ದೀನಿ. ಇನ್ನೂ ಒಂದು HPV ವ್ಯಾಕ್ಸಿನ್ ಬಗ್ಗೆ ಇತ್ತೀಚೆಗೆ ನ್ಯಾಷನಲ್ ಲೆವೆಲಲ್ಲಿ ಸತಿಗೆ ಅದ್ರ ಬಗ್ಗೆ ಬಹಳ ಇದು ನಡೆದಿದೆ. ಆಲ್ಮೋಸ್ಟ್ ಏನಂತಲ್ಲ ಗೈನಕಾಲಜಿಸ್ಟು ಮತ್ತು ಉಳಿದವರು ಎಲ್ಲರೂ ಕೂಡಿಕೊಂಡು IME ಚಿತ್ರದುರ್ಗದವರು HPV ವ್ಯಾಕ್ಸಿನ್ ಬಗ್ಗೆ ಆದಷ್ಟು ಅದರ ಟ್ರೈನಿಂಗು ಮತ್ತು ಇದ್ರ ಬಗ್ಗೆ ಕೊಡಿಸ್ಬೇಕಂತ ಹೇಳಿ ನಾನು ನಮ್ಮ KSB ಪರವಾಗಿ ಕೇಳಿಕೊಳ್ತಾ ಇದ್ದೀನಿ.
Last but not least, our staff of Basaveshwara Medical College and Hospital, okay, support staff, and also Savniru would have been not possible, you know, with the help of Dr. Timareddy, Dr. Amrita, Dr. Vijayalakshmi, and media and press people, more importantly, okay, audiovisual people, all a lot of them, you know, directly, indirectly, and you know, this was organized in a very short, you know, in a very, very, very short time, the whole thing was put up into a place. I wholeheartedly thank you, everyone. If I have forgotten somebody, please forgive me. It was only an oversight. Thank you very much. A wonderful lunch is waiting. Students also, you are all, you know, you are all sitting here with patiently since morning. You know, so you are also invited for lunch. Come down, have lunch. After lunch, come back here. With that condition, I'm sending you there. Okay, and come back and continue, you know, stay back for the scientific proceedings in the afternoon also. Thank you very much. Yeah.
Thank you for those warm
Dr.
words.
Yuvraj
of
sir, Dr. Yuvraj sir, I forgot the director of Chitradurga Institute of Medical Sciences. You know, whenever anything we call him, just one phone call, he is always available to us. Thank you so much. Yeah, okay.
Thank you for those warm words of gratitude, sir. With
Yeah,
this,
we are gathering back at 2:30 here after lunch.
thank you for those warm words of gratitude, sir. With this, we formally conclude the inaugural function of Academy of Medical Specialties South Zone Conference 2025.
Once again, we extend our heartfelt thanks to all the dignitaries, delegates, and participants for gracing this occasion and making this event truly special. Wishing you all a wonderful conference ahead. Enjoy your lunch and we'll see you back at 2:15 sharp. Thank you.
ಎಲ್ಲರೂ ಚಿತ್ರದುರ್ಗ ಅಂತ ಬರಲಿಲ್ಲ ಯಾಕಂತೆ ಬೇಕು ತಗೊಳ್ಳಿ ಬರ್ಬೇಕಾಯ್ತು ಸರ್ ನೀವು ಹೆಂಗೆ ಬರ ಇವತ್ತು ಬೆಳಿಗ್ಗೆ ಬಂದ ಗದಗ ಚಿತ್ರದ ಎರಡು ಕೂಡ ಹೈಲೈಟ್ ಮಾಡೀನಿ ಎಲ್ಲರೂ ಗದಿನಾಗ ಹಾಕ್ಬೇಕಂತ ನಾವು ಗದಗಿಂದ ಚಿತ್ರದ ಎರಡು ಕೂಡ ಹೈಲೈಟ್ ಮಾಡಿದ್ನ ಇಲ್ಲಿ ಸ್ಪೀಚ್ನಾಗ ಏನು ಹೋಗೋದು ಅಂತೇಳಿ ಕನ್ನಡ ಬಿಟ್ಟು ಬಂದಿರಲ್ಲ ಅಂತ ಮೊನ್ನೆ ಹೇಳಿದ್ದು ನಿಮ್ಗೆ ಬಾ ಅಂತೇಳಿ ಮೊನ್ನೆ ಕರೆದ ಹೆಂಗೆ ಹೇಳ್ತಾರೆ ಬಾ ಅಂತೇಳಿ
ಆ್ಯಡ್ ಮಾಡ್ಕೊಳ್ಳೋದು ಸರ್?
ಯೂರೋಲಜಿಸ್ಟ್ ಯಾರು
ಅವ್ರಿಗೂ ಹಾಕ್ಕೊಳ್ಳೋದು
ಎಷ್ಟು ಜನ ಇದ್ದಾರೆ
ಸರ್? ಕರೆಂಟ್ಲಿ 3 ಮೆಂಬರ್ಸ್ ಪ್ಲಸ್ ರಾಘವೇಂದ್ರ ಸರ್ 4 ಆದರು. ಯಾರ್ದು ಹೇಳಿ ಕೊಡ್ತೀವಿ. ಎಲ್ಲ ಕೊಡು ಹೋಗಿ ನೋಡಿ ಕಾಪಿ ಇದೆ ನಾನು ಕೊಡ್ತೀನಿ.
ಸರ್ ಬರ್ತಿದ್ದಾರೆ ಸರ್.
ವಿನಯ ನಮ್ಮ ಕಾಲ್ ಕಾಲ್ ಮಾಡ್ತಿದ್ದೀನಿ.
ಮಾಡಿದ್ರಾ?
ಇಂಟ್ರೊಡ್ಯೂಸ್ ಮಾಡ್ತಾರೆ ಮಾಡಬೇಕಾ ಸರ್?
Hello, check. Hello.
Good afternoon once again, ladies and gentlemen. It was indeed a great session until now. We hope you all had a delightful lunch and are feeling refreshed.
As we begin the afternoon proceedings of COMPOST-2025, we are about to witness one of the most awaited highlights of the day.
It is time for the prestigious Dr. B.M. Alur Oration, a session that has always inspired generations of medical professionals.
The topic for today is cardiopulmonary resuscitation. What is new in 2025? By Dr. S.T. Yavagal sir, former professor and head of cardiology, Sri Jayadeva Institute of Cardiovascular Sciences, Bengaluru.
This oration will be chaired by Dr. Chinivalar sir, IMA Karnataka State Branch President, Dr. Suri Raju sir, IMA Karnataka State Branch Secretary, Dr. Mulki Patil sir, Chairman, IMA Academy of Medical Specialties, Karnataka State Branch, Dr. Manjunath Nekar sir, Secretary, IMA Academy of Medical Specialties, Karnataka State Branch, and Dr. Venkata Jalapati sir, Chairman-elect, IMA Academy of Medical Specialties, Headquarter. We welcome them all. I request the chairpersons to kindly introduce the speaker.
Good afternoon, everyone. I would like to give a small introduction of Dr. S.T. Yavagal, sir. Dr. S.T. Yavagal, aged 77 years, completed his MBBS, MD, and DM in cardiology from Bangalore Medical College. He joined Sri Jayadeva Institute of Cardiology, Bangalore, in 1975 as a lecturer and served in multiple roles including HOD, medical superintendent, and retired as in-charge director in 2005. Presently, he is a member of the governing council of the institution. Post-retirement, he worked as professor and HOD at Jawaharlal Nehru Medical College, Belgaum, where he started the DM cardiology course and later as a professor, HOD, and director at Kempegowda Institute of Medical Sciences, Bangalore. Currently, he is consultant cardiologist at Trinity Heart Foundation, Bangalore. Dr. Yavagal is a past president of Indian Academy of Echocardiography and the Indian College of Cardiology. He has published over 50 papers in state, national, and international journals, written chapters in 7 textbooks, and delivered more than 200 guest lectures. He has presented 110 papers at various conferences, conducted 8 drug trials, and delivered 11 orations. He is a fellow of IAE, ACC, CSI, ICC, and IMA AMS, and has held leadership roles including President of CSA Karnataka, Honorary Secretary of IMA Karnataka, and Founder President of IAE Karnataka. He has conducted 82 cardiology health camps across Karnataka, directed awareness films on heart attack, and authored booklets on hypertension, CPR, and PTCA in Kannada and English. He has been the recipient of several honors, including the prestigious Kempegowda Award by Bangalore Mahanagara Palike. Presently, he serves as Vice President of the Medical Education and Research Trust, Karnataka. Big round of applause to Dr. S.T. Yavagal, sir. Thank you, sir.
Dear friends, before I start my oration, I have been asked to introduce Dr. B.M. Alur to this audience. Dr. B.M. Alur, born on 20th August 1938 in Gajanur village, Gadag district. He did his MBBS from Kasturba Medical College, Manipal in 1964. He worked as lecturer in anatomy at KMC Hubli 1965 to 66, then went to Britain, did his FRCS in 1970 from England as well as Glasgow. He was the Chief Medical Officer at Ghataprabha Center for nearly 7 years. Probably at that time, that was the only center which was known to the people. He has got FICS in 1977. He is a Fellow of the Royal Society of Health, London, FIAMS 1991. He is a visiting fellow surgeon to University of Newcastle, UK, 1977 to 78. He is a visiting surgeon to UK 2003 to 2008. He is the chairman ASI, Association of Surgeons of India, Karnataka chapter, 1988-89. He was president of Rotary Club Gadag Betageri, president of IMA KSB 1990 and 91, and contributed a lot to the Indian Medical Association. He has received several awards, including Kannada Rajyotsava Award in 1991, Dr. Menda Community Service Award 1991 from IMA headquarters. He got Association Oration Award in 1995 by IMA KSB. Dr. A.K. Sinha Oration in 2000, H.S. Bet Oration from Association of Surgeons in 2011. He has been given Lifetime Achievement Award by IMA headquarters at Medicon 2013. All his children are doctors. Son, Dr. Sharan, is a urologist at Gadag. More than this, he is a good friend of all of us, good human being, has contributed a lot both to the profession as well as to the society. This is the introduction of Dr. B.M. Alur, whose photograph is displayed here. Thank you. Respected chairpersons and dear friends, first of all, I'd like to thank I hope you're all hearing. Respected chairpersons and dear friends, first of all, I'd like to thank IMA KSP members who selected me for this oration. I'm also thankful to Dr. Alur, who is instrumental in starting this oration. For this oration, I have selected the topic of, which is related to all the specialties, cardiopulmonary resuscitation, what is new in 2025. I know all of you know CPR, it is nothing new. You are all involved at one stage or the other in doing CPR. But still, after listening to my lecture, you will realize what is the ground reality of this particular topic. Heart and stroke
found today, immediately it will get updated in the guideline so that the whole world can use those things. Thus, it facilitates more rapid translation of new scientific discoveries into daily patient care. The goal is to double the bystander CPR rates and double the cardiac arrest survival. Earlier, we had so many restoration recommendations, COMPOST, etc. All those things have been incorporated in the American Heart Association guidelines. Not only that, they are categorized, all the recommendations have got a class of recommendation and level of evidence. The class of recommendation, class 1 is strong. Only 20% of the recommendations are very strong. 2A moderately strong, 23%. 2B is weak, it is mild recommendation, 48%. 3A, there is no benefit, and 3B is harmful. Similarly, level of evidence quality. A means high quality, all randomized controlled trials, all meta-analysis, all full quality meta-analysis, all have suggested this, that hardly represents 1%. B, all randomized moderate quality. B2NR. BNR means non-randomized moderate quality recommendations. Limited data. C is the limited data, that is 46%. Most of the recommendations come under that group. EO means expert opinion, that is 23%. And you see here, they have made 315 recommendations. Whatever you want, if you go through that, answer is there about the CPR. They have discussed this in 15 parts. Part 3 deals with ethical issues. Ethical issues surrounding the resuscitation are complex and vary according across the settings, in and out of hospital providers, basic or advanced, patient population, whether it is neonatal, pediatric or adult, or whether it's start or when to start permanent CPR. All ethical issues related things are there in the part 3. Dear friends, cardiac arrest, there are 2 types. One is primary cardiac arrest, other is secondary cardiac arrest. Primary cardiac arrest, it is an unexpected witness, seen or heard, collapse in a person who is not responsive. Here, heart suddenly stops. The arterial oxygen saturation is normal at the time of the cardiac arrest, so compression only CPR is sufficient for out-of-hospital cardiac arrest. 70 to 80% of patients who will have cardiac arrest outside the hospital, they are all primary cardiac arrest. We'll see 10 years data. Recently they have published 1,128 patients. 24-hour survival and 30-day survival was 29% and 16%. It is a good neurological outcome which was observed in 13% of all patients. The main cause of suspected cardiac arrest was cardiac in 54%, hypoxia in 11%. In others, they don't know the reason. Secondary cardiac arrest. Secondary cardiac arrest is secondary to severe hypoxia, often from drowning, respiratory failure, drug overdose, hypotension, shock, hemorrhage, etc. Here, we require the classic CPR, which is reserved for this group, secondary cardiac arrest. 2025 guidelines, they are all evidence-based recommendations. Out-of-hospital cardiac arrest and in-hospital cardiac arrest must function differently. Target the education of both the lay rescuers as well as healthcare providers. Part 4 deals with system care and quality improvement. Out-of-hospital cardiac arrest. Very beautiful recommendation is being given. If implemented, it's going to help a lot. But still, medical profession is yet to realize that. What they are telling is, for out-of-hospital cardiac arrest, you have a cardiac resuscitation center. For example, I'll tell you, suppose Chitradurga Medical
Also has been given for the in-hospital cardiac arrest. What they tell is if your hospital is a 500-bedded hospital, arrest can occur any nook and corner of the hospital. Once the arrest occurs, the people who are in that area can start treating, but you have a team in the hospital consisting of a physician, intensivist, anesthetist, pediatrician, gynecologist, who have got expert, who have trained in CPR. This corner from somebody from the corner will message to that team will arrive and take over the management of the CPR. By doing that, they can improve the survival rate. Part 5 deals with adult basic life support. The earlier recommended initial sequence steps was ABC, where A was airway, B was breathing, C was chest compression. Today it is CAB, except in the newborn. When there is a cardiac arrest, what are the things we should do? First, we should confirm staff. Then we will start chest compression as early as possible. One should kneel next to the individual. Knee should be shoulder around the shoulder, with the part, hand should be on the shoulder. To keep the hand straight, start compressing the chest. This is how head tilt, chin lift is. That is to clear the airway, to see that the tongue doesn't fall back. So it is a head tilt and chin lift maneuver, and this is how one should stand while doing the compression CPR for the public. This elbow should be straight. It should be straight below the shoulder so that the weight of the body is falling on the hand and chest is being compressed. Today, there is an increased focus on methods to ensure high-quality CPR. 2025 guidelines tell high-quality CPR only can save the patient, not poor quality of CPR. Start chest compression as early as possible. More early, better chance of survival. Chest compression should be adequate rate 100 to 120 per minute. Long back, 3 decades back, when we were young, then at that time, people used to do compression 72 per minute because heart average is 72 per minute. Then when a youngster starts doing it at a higher rate, they used to tell, no, this is not the way, do it 72 slowly. But days have changed. Medical science is a very wonderful thing. Today, what we tell after some years, we tell it is reverse. For example, coronary angiogram was contraindicated in acute MI when it came to the existence. But today, it becomes the first indication. Similarly, beta blockers, when they came to the market, cardiac failure was the contraindication for beta blocker. Today, beta blocker is the first drug to be given for cardiac failure. Like that, things are changing. So here they told 72 will not help. 100 minimum, they told. Next guideline, they increased it to 120. Then they felt it's difficult to count like that and do it. So do it at a rate between 100 to 120 per minute. Chest compression of adequate depth. It should be at least 2 inches. In children, about 2 inches. Infants, 1/3 of the AP diameter of the chest. And allow chest to recoil after each compression. minimize the interruptions in compression. Depth of at least 2 inches or 5 centimeters for an average adult, while avoiding excessive chest compression is also not good because it may again harm the patient. Again, the compression should be in the central part of the sternum or lower half of the sternum, not on the precordium. If you do on the precordium, there will be fractured ribs. It is challenging without a feedback device. That is the reason what the American Heart Association tells, please practice on a mannequin, which has got, when you practice, it will be showing how many times you are doing it and how much depth it is going. If you learn in that, you will know how to do it on a human being. Thus, it is challenging without a feedback device. The key things to keep in mind during CPR is push hard and push fast. It is not a cardiac massage, but it is a compression and decompression maneuver. Each compression is the patient's heartbeat. If the chest compression are interrupted for any reason, blood flow to the heart and brain essentially stops, decreasing the chance of neurologically intact survival. Emergency cardiac treatment, like earlier days they were doing routine atropine, cricoid pressure, airway suctioning, they are all no longer recommended. If multiple rescuers are available, they should rotate the task of compression every 2 minutes, otherwise the person will become fatigued and compressions will not be up to the mark. If there is a team, then the recommendations are made for a simultaneous choreographed approach to perform chest compression, airway management, rescue breathing, rhythm detection, shock delivery by an integrated team of highly trained rescuers in applicable setting. If there are many people, one will look after the compression, one will look after the airway, one will look after the drugs, one will arrange for the shock, like that. Teamwork. Compression only CPR, the provider delivers only chest compression 100 to 120 per minute with a depth of 2 inches without a pause until arrival of the medical team. The initiation of the bystander resuscitation, especially if begins within 1 minute of cardiac arrest, markedly improves the survival. So the compression will have to start within 1 minute of the arrest. Then chances of survival become more. Becker et al. Study, survival more than 4 times greater in patient who received early bystander resuscitation than trained people coming and doing it. Hufil et al. 2010 only they told, meta-analysis of several observation studies showed higher survival rate in compression-only CPR compared to standard CPR. Compression-only CPR is clearly better than no CPR, and this should be the primary message to be conveyed to all healthcare professionals and general public. Part 6 deals with alternative techniques and ancillary devices for CPR. A high-quality CPR generates, even in spite of high quality, it generates only 25 to 35% of normal cardiac output and oxygen delivery. So, variety of alternatives are being developed. They tried impedance threshold device and they found there was no benefit. Automated CPR, 3 types of automated compressions are available: pneumatically driven piston compression, active compression decompression device, load distributing band compression. None of the studies have demonstrated superiority of mechanical chest compressions over conventional CPR. Thus, manual chest compression remains the standard care. This is automated CPR. The machine, you can adjust the rate and depth. Jayadeva has got one, but this routine use of these mechanical devices is not recommended at present. They can be used only in hospital setting where standard CPR is difficult. For example, you are moving a patient from general ward to the ICU, or when you are doing a coronary angiogram or PCI, at that time you will not be able to do it. So if it is on the automated CPR, it can continue to do it. Prolonged CPR during preparation for extracorporeal CPR, again, time should not be wasted for any of these things. If these devices are used, it's very important to provide training to minimize the interruptions. If you are giving DC shock, don't waste time arranging the, putting the jelly, etc. If you take 2 to 5 minutes for that, whole thing is lost. So they should take as minimum time as possible to arrange and to give a DC shock, because time is important. Compression cannot be stopped in between. Part 7 deals with adult advanced cardiovascular life support. Oxygen. Use of maximal feasible inspired oxygen air is recommended when CPR is being given, but not once the patient has retained his consciousness. This recommendation applies only when the CPR is going on, does not apply to care after return of spontaneous circulation. Physiological monitoring of CPR. It may be useful, but clinical trial demonstrates goal-directed CPR based on physiological parameters. They improve the outcome, but still we don't know. The results are awaited. Ventilation. The present guidelines have repositioned airway and breathing below circulation in sudden cardiac arrest from cardiac cause. But if the sudden cardiac arrest is occurring because of the other causes, the pulmonary cause like drowning, choking, respiratory failure, here oxygen reserve is likely to be depleted. The airway and breathing should restart as quickly as possible. I told you in the beginning only, primary cardiac arrest, when the arrest occurs, the arterial oxygen saturation is normal, only compression CPR is sufficient. But secondary cardiac arrest due to pulmonary cause, etc., where the arterial oxygen saturation is reduced, ventilation is also equally important. If the patient is not breathing, 2 ventilations are given via the provider's mouth or bag valve mask. This can be challenging to perform correctly and is best done by 2 trained rescuers. It is recommended that the tidal volume of 500 ml should be delivered in 1 second when you are doing the breathing. Effective mouth-to-mouth ventilation. Chest should rise with each ventilation. If not, it indicates inadequate mouth seal or the airway occlusion. 2 ventilations should be given in sequence after 30 compressions, 30:2, if there is a single healthcare provider. When breaths are completed, compression should be started immediately. If available, you can use a barrier device. Usually the trained people are given a pocket mask so that they can put it and breathe, give respiration through that. If advanced airway is in place, ventilation should be provided every 6 to 8 seconds without interrupting the chest compression if there are 2 healthcare providers. Ambu bag is also sufficient. Higher the ventilation rate is also not good because it increases the intrathoracic pressure, resulting in the diminished venous return and reduced cardiac output. It can also cause gastric inflation, which increases the risk of aspiration and can impede the ventilation further by elevating the diaphragm and restricting the lung expansion. Endotracheal tube placement should be done whenever there is a possibility, because the breathing will become easy and better. If possible, confirm it by continuous wave capnography and connect to the ventilator. Ultrasound is an additional method to confirm that endotracheal tube is in right position. What is this continuous wave capnography? It's a real-time, non-invasive method for monitoring the patient ventilation by measuring the displaying of the carbon dioxide in the exhaled air. It measures the exhaled air carbon dioxide and shows on the monitor whether the endotracheal tube position is correct or not. It is used to confirm the correct endotracheal tube placement by seeing the appearance of the normal capnography waveform. And when you are doing CPR, if there is a sudden increase in the exhaled carbon dioxide, that means patient is regaining, returning of sudden spontaneous circulation. That means you are succeeding in saving him. This is all for public general above back. This is the endotracheal tube. This is the laryngoscope. This is the ventilator. Ventilate in position. Cardioscope. Defibrillation. Early defibrillation is critical to survival after sudden cardiac arrest. The most frequent initial rhythm in out-of-hospital cardiac arrest is ventricular fibrillation. The chance of successful defibrillation diminishes if you delay doing defibrillation. So if defibrillation is available, give first shock. 2 high-quality population-based cohort studies have shown that the use of these devices by bystanders doubles the survival rate after out-of-hospital cardiac arrest. It's an effective treatment for BF or pulseless VT associated with cardiac arrest. No specific training is required. The rescuer simply follows the audio-visual instruction when the device is switched on. This is the defibrillator with pads. It is very important to reduce the pre-shock and post-shock pauses in chest compression during defibrillation. One cycle of chest compression should be resumed immediately after shock. After giving DC shock, don't go on wasting time in looking at the cardioscope whether the patient has started his own contractions or looking for the pulse, whether his heart is contracting like that. You must start immediately chest compression because heart will take some time to start its function after the defibrillation. Even an interruption in the compression while preparing the defibrillation results in the drop in the coronary perfusion pressure. So every effort should be made to minimize the interruptions in compression. Echocardiography. What is the role? It should not interfere with the provision of high-quality CPR or conventional ACLS therapy. Whether ultrasound can guide the CPR, more knowledge is required. Today, the key role of echo in CPR is only to identify the reversible causes like pericardial tamponade, which may be difficult to make out clinically. Our echo people can show us patient has got pericardial tamponade, the treatment point will be different. Pulmonary embolism, hypovolemia, myocardial dysfunction. It helps in assessing the cardiac activity, evaluation of effect of chest compression, whether your compression is helping the patient. It guides the intervention. It also tells about the prognostic information. Role of drugs in CPR. Adrenaline, epinephrine. Current guidelines recommend that adrenaline should be given IV every 3 to 5 minutes during cardiac arrest. Adult is 1 milligram, children is 10 micrograms per kg. Timing of administration, if it is a shockable rhythm, defibrillation will be the first. If it is non-shockable rhythm, epinephrine will be the first. It increases the rate of return of spontaneous circulation and survival to hospital admission. Earlier days we were using vasopressin. Today it is removed from the ACLS cardiac arrest algorithm. It simplifies the approach. Steroids. The role of steroids is controversial. Did not improve the survival in hospital cardiac arrest. But one study showed vasopressin steroid epinephrine combo. The treatment with this VSC during CPR is found to be beneficial. Spiros et al. Way back in 2013, a randomized trial in patients with in-hospital cardiac arrest, treatment with VSC followed by treatment of survivors with daily steroid increased the frequency of being discharged with a neurologically favorable outcome compared to the patient receiving standard care and epinephrine alone. So if you are suspecting neurological problem, this drug is going to help. VSC patient also had improved hemodynamics and central oxygen saturation as well as less organ dysfunction. Prognostication during CPR. A low partial pressure of end-tidal carbon dioxide in an intubated patient at the end of 20 minutes of CPR is associated with a failure of CPR. When we are doing CPR, the carbon dioxide concentration in the exhaled air should go on increasing. If it fails to increase, that means probably there is a failure of CPR. It should not be used in isolation or in a non-intubated patient. Any anti-arrhythmic drugs as a second line of refractory VF or VT, there are no trials. Initiation and continuation of the anti-arrhythmic drugs in post-cardiac arrest period, again there are no trials. IV atropine, fibrinolysis, routine fluid loading, and artificial pacing have no effect on the outcome. Sodium bicarbonate is it is useful when there is a prolonged resuscitation. Delivery of drugs via tracheal tube is no longer recommended. Precordial thumb. Olden days we used to tell when there is a cardiac arrest, you give a precordial thumb and then start compressions. But today's recommendation, either it favors nor it is against. It is, however, not recommended for out-of-hospital cardiac arrest. Many of you must have experienced when, if you allow the attenders to enter the ward and see what you are doing, they will tell you have hit his chest and he collapsed because of that. If you don't allow them, they will tell you when the cardiac arrest, nothing was done. Both are problems. However, precordial thumb, it should not be done in an out-of-hospital cardiac arrest. What are the other options if there is a ROIC is not rapidly achieved? Mechanical CPR device, endovascular ventricular assist device, intra-aortic balloon counterpulsation, extracorporeal CPR, roll alone or in combination, still not well understood. What is this extracorporeal CPR? It's an advanced medical procedure that combines the CPR with extracorporeal membrane oxygenator for the patient. What they do is the blood will go through the membrane oxygenator and get oxygenated and go back to the body so that brain and heart will get better oxygen in the blood. Which population would be benefited most? Studies are required. This cannot be done in every circumstance. If somebody is already on the operation table and if the arrest has occurred, they can try, or if an intervention is going on in the cath lab, when everything is already there on the line, it's easy to get it connected. What are the contraindications for CPR? The only absolute contraindication to CPR is if the treating doctor has displayed a bold, do not resuscitate. When some person is, after doing all the treatment, the treating physician, nothing else we can do, has such a patient, almost dying level, you know nothing can be done. There is no point in going on doing all this exercise. A relative contraindication is if a clinician justifiably feels that the intervention would be medically futile, it won't help, then you can. When to stop CPR? At least we should try for 20 minutes. If the 20 minutes level, if you cannot survive, probably you may not be able to survive. Or if there is only one person who is doing chest compression, if he is tired, there is no point in continuing because compression will not be sufficient. If there is a return of spontaneous circulation, you can stop CPR like that. Part 8 deals with post-resuscitation care. Another important area which has been neglected for many days. Apart from timely and effective CPR, the optimal post-resuscitation care is also very crucial for a good outcome. The two important pillars of the post-resuscitation care are routine coronary angiogram and therapeutic hypothermia. Even identifying and treating the underlying cause for cardiac arrest is also very important. Coronary angiogram. 2015 guidelines told all the patients who have survived, they should undergo coronary angiogram. But today what they tell, if a cardiac arrest occurs, if you save the patient, straight away shift him to the cath lab and do the coronary angiogram and see if there is a block, open the block, then only you can save the patients. So today it is not planned angiogram, it is an emergency coronary angiogram should be done for all people who have been survived in the out of hospital cardiac arrest. CAG and coronary intervention should be performed as an emergency rather than late in the hospital or not for all OHCA. Even in comatose patients, they are telling patients who underwent CAG or PCI were more likely to survive than those who did not. Therapeutic hypothermia. Still, many hospitals, many physicians are not yet considering this. All comatose patients, comatose means lack of meaningful response to verbal commands. Adult patient with return of spontaneous circulation after cardiac arrest should have targeted temperature management to select and maintain a constant temperature between 32 to 36 degrees for at least 24 hours. We should prevent fever. Routine pre-hospital cooling of patient of return of spontaneous circulation is not recommended. It's only if they are comatose, it is recommended. How to do therapeutic hypothermia? IV infusion of cold saline, external cooling methods like cooling blanket, wet towels, fanning, cooling helmet, ice pack to the groin, axilla, neck, intravascular heat exchange device, all this can be used. It improves the neurological outcome after return of spontaneous circulation. It reduces the cerebral metabolic rate. It suppresses many chemical reactions associated with reperfusion injury, reduces the mitochondrial damage, apoptosis, programmed cell death. But the adverse effects are also there, arrhythmias, infection, coagulopathies, we should remember. Hypothermia is contraindicated if there is a severe cardiogenic shock, life-threatening arrhythmias, pregnancy, patients with primary coagulopathy. Post-CPR, avoid and correct hypotension and hypothermia, give oxygen, manage glucose management, prognosis. Survival and good neurological outcome is observed in the younger age. If you try in a younger age, witnessed out of hospital cardiac arrest, early CPR, shockable initial rhythm, OHCA outside the home. Because when it occurs outside the house, there are somebody will be helping rather than inside the home. Organ donation. All the cardiac arrest persons who are progressing to death or brain death should be evaluated as the potential organ donators in the setting where the program exists. So, like this, all special circumstances, the American Heart Association gives the guidelines. I will just tell one word about each one. Acute coronary syndrome. What they are telling is if somebody has want to train in CPR, they should know also in acute coronary syndrome. The team which goes to the spot from the hospital, they should address the pre-hospital emergency department phase. They should do an ECG if it's infarction, computer generated, this one, straight away they should inform the cath lab and get ready. If not, at least take this, pass the ECG to the physician and take his opinion. The pre-arrival notification can be given to the hospital and the cath lab so that they will be ready. If there is no STEMI or ECG changes, then we should do the troponin I, troponin T by that team only there. They can even give heparin, aspirin according to the advice of the physician, supplementary oxygen. Primary PCI, if delay is anticipated, then even the recommendation is to give thrombolysis and shift to PCI center. Similarly, in special circumstances like opioid poisoning, lipid emulsion, later half of pregnancy, if there is a cardiac arrest, you have to move the uterus to the side and then do, otherwise there will be aortic cable compression. And if in a pregnant lady, peripartum cesarean delivery should be considered if after 4 minutes of cardiac arrest, if we cannot survive the patient, the gynecologist can take a decision about doing delivery so that at least the baby can be saved, cesarean delivery. Part 11 deals with pediatric basic life support. Algorithm is again 1%, 2%, it differs. No compression CPR alone. Usually it is CAB should be considered. Rate of compression is same. Depth is 1/3. It is not like this. For baby you are doing with a thumb, with 2 thumbs. Rescue breathing because of asphyxial nature. If unwilling or unable to deliver the breath, at least compression CPR should be there. If there is one rescuer, 30 compression, 2 breaths, 2 rescuers, 15 compression, 2 breaths. Use automated electrical defibrillator if it is available. Part 2 deals with advanced life support, where you are going to aggressive volume is not recommended, titrated fluid therapy should be given, limited survival benefit to the use of atropine, and what they should do for the pediatric is discussed. Neonatal survival, part 13 deals with neonatal survival. Again, it gives the guidelines, what should be done, what should not be done. Part 14 deals with education. Still there is a low survival rate, both out of hospital and in hospital cardiac arrest. High quality training is needed both to the lay public as well as the healthcare professionals. American Heart Association recommends that even the trained people should be trained again and again once in 2 years, because a lot of changes might have taken place in the management of cardiac arrest. Use of high fidelity mannequin for advanced life support for training should be used. It is reasonable to use audio-visual feedback devices during CPR training. More frequent is useful. Reduce the time to defibrillate. Another important addition, it is not necessary that doctors should train the lame public. Lame public who have got training for CPR, they in turn can train the public. That is what they are telling. Communities may consider training of bystanders in compression only CPR. Bystander CPR remains low in many regions, emphasizing the need for increased awareness and training. The use of patient automated electrical defibrillator is crucial for improving the survival. At present, very sorry to note that only 2% of out-of-hospital cardiac arrest are receiving defibrillation. Part 15 deals with first aid. First aid means helping behaviors and initial care provided for acute illness or injury, but these first aid training should also include early recognition of stroke, hypoglycemia, what they should do when there is an open wound, when there is a 10th tooth is come out. They should carry the tooth to the dentist so that they will refix it. Symptoms of anaphylaxis, they should be able to recognize. The first aid training should cover all these things. Dear friends, cardio-cerebral resuscitation is a new approach of patients with primary cardiac arrest that has shown significantly increased survival. After introducing cardiac cerebral resuscitation program, which stressed upon the compression-only CPR, the layer rescue CPR. Olden days, they used to hesitate to give mouth-to-mouth breathing, etc., because he must have taken drinks, he might have just vomited, or a man doing mouth-to-mouth for a female. They had hesitations, but today, when you tell only do compression CPR, people are ready to do it, and it has shown that it has increased to 40%, thus resulted in 300% improvement, that is 3.7% to 17.6% in survival to hospital discharge. 2025 guidelines, they tell immediate bystander CPR, high quality chest compression with minimal interruption, early defibrillation continues to be the crucial priorities. Dispatch, the next research is going on, whether dispatcher guidance and drones, they are trying to use, whether drone can take the defibrillator to the spot and give it to the person who is sitting by the side of the cardiac arrested patient so that he can use it. DSCPR and use of drones to deliver AED are emerging strategies to improve the early intervention and improve the outcome. Probably in the next guideline, it will get about. Probably looking at it, probably a day may come when the drone may take the whole team of trained people to the spot from the hospital and may help the cardiac arrest patient. What are the problems in India? There is a low bystander CPR rate. Although there are about 6 articles are there, the survival rate 1.3 to 9.8%. Only one study has shown 9.8. All the rest have shown 1.3 to 5 or 6% survival rate. Need for public awareness is very important. Importance of emergency medical system should come into practice. Community CPR training is important. Telephone instruction CPR can be done. Address all the barrier social things. Establishing a national registry of cardiac arrest so that we'll know what is happening in the country. Use of technology like drones, etc. may come in the future days. So I conclude telling that no longer ABC, now it is CAB. A high quality CPR with minimum interruption should be our goal. Role of routine use of drug is unclear, but epinephrine has got some benefit. After successful resuscitation, the focus should shift to post-resuscitation care, maintenance of cardiocerebral perfusion pressure, achieving therapeutic hypothermia, early coronary angiogram. The 4 C's, compression, cardioversion, cooling, cardiac catheterization. These are the only interventions which improve the survival rate in both out of hospital and in hospital cardiac arrest. Guidelines now change from periodic review to continuous update. Recommendations have got American Heart Association class and level of evidence, tremendous potential for increasing the survival in cardiac arrest. Success in CPR depends upon the prompt rescue action, high quality CPR, optimized ACLS, post-cardiac care. High quality training is needed for everybody. Most of our ambulance carry the words, this hospital, this ambulance belongs to this hospital, this is donated by so and so. But if the ambulance carries the word, save a life with compression only CPR, if it goes, probably many public will learn CPR. After once patient is survived, he should be moved immediately to a center where there is a facility for coronary angiogram and angioplasty so that we can save the patient. With these few words, I conclude. Thank you very much.
Thank you, Dr. Esteban, sir, for your elaborative CPR, the new updates in this medical. So now we shall felicitate our Dr. S.T. Avgal from IMA, KSB and AMS.
Thank you everyone. I now request Dr. G.B. Bidinal sir, National Vice President IMA, to kindly felicitate our chairperson.
Thank you, everyone. Now I request Dr. Venkata Chalapati sir, Chairman-elect IMA AMS Headquarters, to give an overview regarding Academy of Medical Specialties.
Dr. Venkata Chalapati M completed his MBBS from Government Medical College Ballari and pursued his MD Pediatrics at Sri Shet KM School of Postgraduate Medicine and Research, Gujarat University. He has held several significant organizational roles, including Founder Vice President of IAP Karnataka State Branch in 2015, President of IAP BPS in 2016, Organizing Chairman of Bengaluru Pedicon 2016, and Organizing Co-Chairman of the IAP National Conference Pedicon 2017. He is also the founder and current President of IAP Chikballapur District. At the Indian Medical Association, he served as President of the Chikballapur branch for 2 years, during which the branch won the State Best Branch Award, and later as State President of IMA Karnataka in 2021, a tenure recognized as the national level. He has also served as National Joint Secretary of IMA Headquarters, New Delhi. Additionally, Dr. Venkata Chalapati has contributed as a former syndicate member of Rajiv Gandhi University of Health Sciences, as a former member of the Karnataka Medical Council and executive board member from Karnataka at the Central IAP. Thank you.
A very good afternoon to you all. At the outset, I would like to thank the organizers for giving me this opportunity. At the same time, I would like to congratulate the organizers for pulling out a wonderful conference with not less than 600 delegates and about 40 papers in the presentation section. And that leads a good round of applause, I suppose. Secondly, I would like to thank the chairman of IMA AMS, Dr. Ramnik Bedi, who was supposed to be here, but unfortunately because of some family emergency, so I had to fill in his gap. Last night he called up and asked me to make this presentation. In fact, my job is made easy if you had attended the morning inaugural session, because Dr. Bidinal had covered almost every aspect of IMA AMS. Thank you very much for that, sir. So since I have been given the opportunity, I'll just touch upon things which have been left over. So I bring greetings from IMA headquarters. So what is the history of IMA AMS? This was a sub-chapter of IMA which was started in 1979. Let me tell you, friends, IMA can be seen into three aspects. It is an academic body, it is a trade union, and also recreational club rather. But IMA AMS will be mostly of an academic body. That is the main job and responsibility of IMA Academy of Medical Specialties. So it was started in 1979 as one of the academic wings of Indian Medical Association and was administered from Delhi, and later on it was shifted to Hyderabad in 2008. Then it was shifted into Hyderabad, as it is a tradition of just decentralizing many of the sub-chapters of the headquarters. So coming to the main objectives, yes, morning yes said already, I'll just brush up. To acknowledge the talent, expertise and experience in all specialties, medical, surgical, including basic medical sciences. Say many of us would have a postgraduate degree, but will not be able to pursue further in our super specialties due to various reasons. And AMS is a wonderful opportunity for you to pursue your goal in a super specialty course after you finish off your post-graduation. To formulate policies, make suggestions, recommendations in the matter of medical education training, in particular encouraging continued educational activities. To promote teaching, training and CME of its members on an ongoing basis, to devise ways and means to encourage group studies, cooperative activities, research projects in both the methodology of educational techniques and field research into disease complexes. To compile educational materials including publication of literature, periodicals, bulletins and books. So the same thing, whatever I told you, is the main aim of IMA AMS. Coming to the body as a structure, we have around 20 state chapters, around 225 local branches of IMA AMS, and the life membership stands as on today is on 18,644. I think this is a very, very dismal number, I would say, since we have in headquarters about nearly around 4 lakh doctors enrolled as IMA, and also we have almost 11 lakh doctors enrolled in MCI. But this is the figure in the IMA AMS. I think we are very poor in academics, rather I would say. And fellows, we have around 2,680. So life member of Academy of Medical Specialties shall be chosen as faculty member for, these are all the advantages, what are the advantages of joining IMA AMS. And we do honor the members of AMS with our fellowships, and even professorship of IMA AMS is awarded for very academic person who works for more than 10 years in that specialty. So how you enroll, like you should be a life member of IMA, and IMA AMS fellowship application forms and fee details can be downloaded from our website. So eligibility for IMA AMS fellowship. Nomination for fellowship of academy shall be of life members who comply with the following minimum requirements. You should be a life member of IMA, life member of the Academy of Medical Specialty, and practice the specialty for at least 10 years. And academic achievement, professional distinction, publication of scientific papers, research, teaching experience. Uninterrupted continuance of membership, life membership of IMA after selection as fellow, failing which the fellowship shall be liable to be withdrawn. All other requirements which may be prescribed by the governing council from time to time for the guidance of the credential committee. So after you fill up the form, you have to mail it or send it to this address, which is at Hyderabad. The Hyderabad is the headquarters of IMA AMS. And now we have also gone digital. So most of your membership certificate can be downloaded from the website once you finish off the formalities of enrolling as a life member. So you can download it from the website. So why I should join AMS? I said what are all the advantages of becoming a AMS member. Very, very important is that IMA AMS is running nearly around 44 specialty, super specialty, fellowship and certification courses. And unfortunately, they are not recognized by NMC or MCI. But let me tell you, last year when I was the Joint Secretary at the headquarters, we had a MOU with Baba Farid Medical University. And lot of work is being done at the headquarters to try to see that whatever the fellowships or certificate courses that we provide are recognized by the NMC. So that through the medical university, all our members would get a recognized degree or certificate or a fellowship. So these are all the important courses. Almost we are running around 44 super specialty courses in different parts of India. And these are all in the pipeline. So how to conduct the fellowship course in respective states? So if any institute is interested in running a course, so they have to provide the details. So in fact, we have a long-term course and short-term course. Long-term fellowships are for 1 year. In fact, Bangalore, we are running around 2 courses. One is IVF and another one is Andrology. Both are running for 1 year and they're all full house. There's a lot of demand for these courses currently. So this is the requirement. Modules of training should be provided, and time of training period, name of the hospital, center or hospital history, faculty details, all you have to provide it to the IMA headquarters. The IMA headquarters will send a team to inspect the institution, and once it is satisfied, you can start a course, and definitely it is of great advantage because you get a manpower, and also financially also the institution is at a greater advantage. And this is very important thing. I think every year IMA AMS brings out annals. It's a beautiful monogram of a given chapter or a particular subject. This year, in fact, now we have started this adult immunization annals. Now it is in the pipeline, and that will be released every year, for that matter, every year during the IMA AMS National Conference. And this year, I think we are releasing a immunization monogram. It's written by most of the experts of national and international stand. So I just take this opportunity to appeal to each one of you who are specialized in some subject to enroll yourself as member, take the advantage of AMS and try to get into some kind of a fellowship and certification course, because this is a very, very purely academic subchapter of Indian Medical Association. So this is the activity that is these are the upcoming activities. The Central Zone Conference is happening on, it had happened at Chhattisgarh. South Zone is today we are doing, and East Zone is this month and 21st we are doing. North Zone is clubbed with the National Conference during the month of November 29th and 30th. So I invite you all and take this opportunity for you to participate in this national conference of IMA AMS at Chandigarh. So thank you very much for this hearing. Thank you so much. So if there are any questions, I'll be more than happy to take.
Thank you, sir. I now request Dr. S.Y. Mulki Patil, sir.
Hello, one second. If there are any questions, I would be more than happy to answer. Yeah, membership fee is now 1,000, that's all. It's very, very, very minimal. Only thing is that you should be a life member of IMA. That is very important, main member. And particularly what Dr. Bidhanal wants to say is that how the fellowship fee is distributed between the institute. So if 40% will go to the institute, 30% to the headquarters and 30% to the state chapter. For example, if the fee for IVF is around 3 lakhs, so 40% will go to the institution which is running this course. Say for example, there are 10 members enrolled, 40% of the fee of all the 10 members will be taken by the institution. And moreover, they will have a hands to work in their institute. That is the biggest advantage apart from finances also. And 30% will go to the state and 30% to the chapter. No, this fellowship and certification courses, let me tell you, in fact, I was the executive board member of Indian Academy of Pediatrics also. There we run Indian College of Pediatrics. There also we are facing the same problem. Most of these fellowship courses or certification courses are only for you to acquire a skill or to pursue your passion where you have failed to get into MCH or DM. So that is one thing. So this is one thing, but it will not have a legal sanctity as such. You can't write it on your letterhead or in your visiting card. Anyhow, IMA is perceiving, moving heaven and earth. We are fighting tooth and nail. And in fact, I know how much of hard work is put in. So we got a MOU with very great difficulty from Baba Farid Medical University of Haryana. In fact, Delhi University also, we had this technology course, medical records technology course. We have a MOU with the Delhi University. 1 or 2 are recognized, but these certain courses we are planning to work with the Baba Farid Medical University so that once you get a recognition from the university, we can pursue it with the NMC. Since that our own man Abhijit Seth, who is there now sitting in NMC, and is also Gujarati, you can understand, next upcoming president of IMA National is also a Gujarati man. Hope that something good will come out of this combination. I definitely agree. They are not legally not recognized. Only to acquire skills.
Thank you, sir.
Okay, thank you so much. Thank you.
Thank you, sir. I now request Dr. S.Y. Mulki Patil, sir, Chairman, IMA Academy of Medical Specialties, Karnataka State Branch, and Dr. Narayan Murthy C., Organizing Chairman of Academy of Medical Specialties Conference, to felicitate Venkata Chalapati, sir.
Thank you, sir. Next on, we move to a subject that touches many lives, fertility.
Our speaker is Dr. Anita A. Manoj, Senior Fertility Specialist, Garbhagudi IVF Center, Bengaluru. She will be enlightening us on declining fertility. It's time to be diligent. The session is chaired by Dr. Mallikarjuna Kirti, sir, Senior Obstetrician and Gynecologist, Kirti Hospital. Dr. Geeta H.H., Senior Obstetrician and Gynecologist, Basveshwara Medical College Hospital and Chitradurga. Dr. Tyojakshi Bai, Senior Obstetrician and Gynecologist, Surge Hospital. Dr. Raghavendra K. Sir, Professor, Department of Pediatrics, Basveshwara Medical College and Hospital, Chitradurga. I request the chairpersons to kindly introduce the speaker.
Good afternoon. It's an honor to introduce Dr. Anita A. Manoj. She is a senior fertility specialist with over 18 years of experience in obstetrics and gynecology and reproductive medicine. She has completed her MBBS from Devraj Aras Medical College and her MS OBG from Mahatma Gandhi Medical College and Research Institute. And she has pursued fellowships in minimal access surgery and reproductive medicine. Her expertise spans infertility evaluation, IVF, IUI, fertility preservation, and holistic women's healthcare. She is also an accomplished researcher with several publications in reputed journals and an active member of FOGSI and the Indian Medical Association. She has also featured in many television programs creating awareness about infertility and conducted numerous medical camps in both urban and rural settings. I welcome Madam to deliver her lecture. Thank you.
Happy evening all. I am Dr. Anita Manoj. Am I audible? Yes. Okay. So today I took a serious topic because present generation, like we know about the common disorders like PCOD or something else or some other male factor abnormalities, but the present generation who are postponing the marriages or who are postponing the family or who are postponing the thought or plan of conceiving the babies. Either they want to postpone or they want to delay or they don't want to conceive the kids. But later dates, when they are in 20s, 30s, they are thinking, not now. I want to finish my education. I want to finish my professional course. I want to finish my PhD. I want to settle in a good job. First, I want to get married. Let me see whether my spouse is compatible to me or not. If not compatible, we'll just adjust or see for 5 years, then plan for pregnancy. Or they'll have, like, I have this project, very good project, let me plan for the pregnancy later. Like this, the precious years, the precious reproductive years between 20 to 30 years, most of the younger generation, they are wasting. My true words are wasting. So when they decide or when they realize, by then they're already 35 plus or 40 plus, and they when come to meet us, already their fertility levels would have been dropped drastically. The drastic fall in the fertility levels, it can be because of the age, or it can be because of the decisions made by the couple, whatever I mentioned, or it can be because of the generation itself. There is early decline in fertility in the present generations. I'll just rush through. I know there is post-lunch session and very boring topic, fertility, for you all, but still interesting topic. Most of us, or most of the younger generations, should know. So declining fertility, the different causes, what to do, what not to do. First, let me go through the women causes. I'll just give a brief example of a case. So Mrs. A, around 30 years, and the husband around 36 years, with a primary infertility of 7 years, regular cycles, no other comorbidities, and no significant family history also, that came to us. And then the treatment history, if you look into that, they would have tried multiple smaller treatments like OITI or IUI cycles, all scans done by the radiologists only, and the dominant follicle seen was 9 mm. And they had no significant health hazardous habits other than husband having a tobacco chewing, and that's it. So the investigations also all were normal limits. The semen analysis shows 16 million concentration with progressive motility of 28%. On general physical examination, the BMI is normal. The scan picture, see the scan picture which has been highlighted. The right ovary is showing only 3 small follicles or antral follicles, and the left ovary showing only 4 antral follicles. On biochemical evaluation, the AMH value is around 0.71 and FSH is around 9.8. So evaluation of the husband also done, blood investigations for him also done. The scan showed bilateral grade 4 varicocele with teratozoospermia and DFI around 37%. So for these couple, in view of low ovarian reserve and the DFI and previous multiple cycles, smaller treatments failed, we did IVF with a TESA in view of DFI. So frozen embryo transfer done, and 3 grade 3 embryo, day 3 grade 1 embryos were transferred, and beta HCG was 1024, that means positive. So what is this diminished ovarian reserve? It's a condition that is characterized by decrease in the quantity, quality of eggs produced by the ovaries, resulting in reduced response to ovarian stimulation or reduced fecundity compared with the women's comparable age. So it can be AFC, that is antral follicle count less than 5, or a biochemical marker, that is AMH less than 1.2. So around 10% of the women in general population, they are affected by poor or diminished ovarian reserve. The prevalence of the diminished ovarian reserve, it may vary among different populations depending upon several factors like age, ethnicity, lifestyle, environmental factors, all these. So the pathophysiology can be, as I already mentioned, it can be, that is, she might have a normal pool during the reproductive age group, but there is rapid atresia from a normal pool, or normal atresia from an abnormally small initial pool, because congenital causes, she is born with small initial pool, or extreme end of a normal bell-shaped population distribution of the number of oocytes at a given age. So certain ethnic groups, they have higher prevalence of diminished ovarian reserve than others, and this may be related to genetic factors, or it can be environmental factors also. So there is growing concern in the present generation or in the present age for this declining fertility trends, both among women as well as men also. So prevalence increased from 19% to 26% in 2011. Now in 2024 or 25 it is much more. AMH and AFC values of Spanish and Indian women undergoing IVF were compared. They found that mean age among Spanish and Indian respectively, they were like 2.3 times higher among Spanish women than the Indian. So these are the fertility distribution among different states of India. The dark shade, that's the highest fertility index, that is 3.7 to 4, which includes Bihar and another state. The South India, see, you can see the fertility trend in South India, it is on the lower side. So in 2024, India, the fertility has dropped from like previously 3 to almost 2. In the projections are much lesser. It becomes irreplaceable in future. So oocyte atresia, this is the graphical picture. So at 16 to 20 weeks of intrauterine life, a girl baby or a girl child will have 6 to 7 millions. So the oocyte number will be in millions in the intrauterine life. It becomes in a single digit millions at the time of birth. It becomes in lakhs at puberty, and it becomes 25,000 after 35 years. So this is the decline. So that is why the 20 to 30 years of age is the age for high reproductive potential. The causes can be varied. It can be idiopathic, it can be drugs related, it can be toxins exposure, it can be habits, it can be a severe infections during childhood or during the reproductive age groups, it can be autoimmune diseases, or it can be iatrogenic causes which would have led to all these. So it can be the toxins like BPA or diaphthalate metabolites or lead also. So why we have to measure the ovarian reserve? It's a prognostic information. That is what we are, whenever we get a platform, we are trying to tell. At least a woman or a lady can test if she is planning to postpone the pregnancy. She can just test AMH, if not ultrasound also. A man can test one simple semen analysis, basic level also, to diagnose their fertility potential. So when to evaluate? The fecundity of women decreases gradually but significantly after 32 years as age increases, increased incidence of disorders that impair the fertility, higher risk of pregnancy losses also. Even though they conceive with using technology also, they might land up in anembryonic gestations, abortions, or they might go for anomalous babies and termination, preterm labors and other things also. So pregnancy complications or obstetric complications are also high in these women. So when to evaluate? If after 1 year of unprotected intercourse, they are not able to conceive, like around in case of more than 85% of the couples, usually they conceive within 1 year if they are not using any protection. If not, then, or after 6 months when the women's age is more than 35 years, or if the women's age is more than 40 immediately, or any time, as soon as if the pregnancy is desired also, if there is a known problem to women such as irregular menstrual cycles, or there is suspected tubal disease, or there is past history of infertility for the patient, I mean it can be either partners in the family, then also they should approach immediately. So these are the ovarian reserve tests. The biological, it is age. The biochemical, it can be hormones like FSH, LH, inhibin, estrogen and AMH levels. The dynamic test like clomiphene citrate challenge test, GAST effort, but we usually see the hormones. We check the age and we usually go with the AFC, that is the ultrasound. We usually do AMH and AFC and correlate with the age and then decide the plan of action. These things we don't do nowadays. The significance of FSH. FSH, we all know, we have read in the basic books also, FSH should be less than 10. Anything more than 10, it will be abnormal. The quality of the oocytes will be affected on top of the decreased number also. So AMH, nomogram this is. And optimal fertility, we see if the AMH is between 4 to 6.8 and very low if the AMH is less than 0.4. So clinically, more than 6.8, we say it is PCO. Normally we take it as 1.2 to 3.5. Anything less than 1.2, we consider as low AMH or poor ovarian reserve. Anything more than 3.5, we say it's a polycystic ovaries. There also, in both extremes, the quality will be affected and the pregnancy potential of the oocytes will be affected. So AFC, that is the antral follicular count, it should be, we usually take the 2 to 10 millimeters, usually less than 6 millimeter follicular count in the transvaginal sonogram. So whatever marked in the picture, so these follicles only will count. So it should be between 8 to 15 per ovary. And this is age related, that is 20 to 30 years. After 30 years, this number will come down. So anything beyond 15, we consider as polycystic. So normal reserve and multifollicular and polycystic. Clinically, we consider more than 15 only as abnormal. For those patients, the quality will be affected. Even if we treat them also, they are hyper responders. They are more prone for OHSS and other complications. Though we retrieve 30, 40 oocytes in such patients, finally if you see the number of good embryos they form, it will be around in single numbers only, single digits. See, these are the ovarian tests and their significance or the values. So poor ovarian responders, as per the Bologna consensus, they say at least 2 criteria should be satisfied. That is advanced maternal age more than or equal to 40 or any other risk factors like previous documented poor ovarian reserve less than 3 oocytes retrieval or an abnormal ovarian reserve test, AFC and AMH. And these are the Posidon classification. A poor ovarian responders they are. That means they can have a normal ovarian pool but response is less. They can have a low ovarian pool and so the response is less. And it can be like older age more than 35 years. It can be younger age also with a poor ovarian response. Why should you know or why should we know the poor ovarian response? Why should we identify? To individualize the protocol as per the Posidon criteria based on their age, AFC, AMH and the response, we individualize the protocol. Thinking poor ovarian reserve, we cannot choose or we cannot brand them with one specific drug for all. It may not suit. So depending upon their things, we have to choose the drugs and treatment protocols. Early initiation of treatment. Better be late than never and better be early also. Prognosis, cancellation, donor egg cycles and all these counselings we have to do. So interventions to enhance the IVF outcome, we have to go for high dose gonadotrophins for these patients. We have to go for modified protocols, dual stimulations. That we can try ANTAC protocol also. Triggers we will plan, and assisted hatching during the embryonic development, and sequential transfers during the embryonic transfers, because we'll have limited number, so we'll go for sequential transfers also for these couple. So we can use the adjuvants like growth hormone, luteinizing hormone, androgens, ecospirin or aspirin, and estradiol pre-treatment in the previous cycle, arginine, all these will definitely help them, at least marginally. So evaluation of ovarian reserve prior to treatment helps in predicting the response as well as the outcome. Preconceptional counseling should be done irrespective of the age. Postpone the pregnancy. That means if anyone planning to postpone, think of social egg freezing instead of going for donor cycles in future. If AMH is less than 1.5, definitely try to consider IVF. A new ray of hope is ovarian regenerative therapies. So ovarian regenerative therapies, that is, we can infiltrate the ovaries with the PRP or the stem cells or the other factors also to increase, but the documentation is still, we need more articles regarding all those things. And freeze-thaw activation, that is, we can freeze, social freezing or any other purpose, we can freeze and then go for FET, embryo transfers later. Coming to the men. So women, we know eggs are, follicles are coming down because of the age. So then they're getting, as the age is advancing, yes, they are losing the eggs. But in the present trend, previously it was 10%, 20%, 30% the men, the male factor. Now it is almost equal, or male factor is increasing day by day. So it's an alarming trend in the present generation men. $42,935 men provided semen samples in 73 to 2011. There was a significant decline in between 1973 to 2011 among unselected Western and among fertile Western. So the mean semen analysis or the semen count declined on an average 1.4% per year, with an overall decline of 52% between 73 to 2011. So there are many articles publishing like this, the declining trend in the male fertility. The canary in the coal mine, that is, it is not completely answered. Should this be a cause for concern? Is it a true warning? Should we wait for more data to be published? There are many factors why it's happening like this. And there are many unanswered questions also why it's happening like this. So it can be because of the drugs, it can be because of the inflammation, it can be because of their habits or environmental factors also. And the COVID also has drastically caused decline in the male fertility. So this was a journal published in 2022 August 5. It shows there is mild or asymptomatic COVID-19 infection. It had a significant effect on semen quality in the short term. And the results suggested that the SARS-CoV-2 infection in patients may negatively influence their fertility potential in a short-term period, but more studies are needed to decide about the long-term effects. So Indian scenario in 1987, you can see the female factor was around 38% with male factor around 20%. In the causes of infertility now, the male factor and the female factor are almost equal, but now it is the male factor is increasing, because in our OPD, if we see 5 couples, in that almost 3 couples are like male factor only, either oats like oligoasthenoteratozoospermia or severe oats or azoospermia. So like this we are seeing frequently nowadays. The causes can be, as I told, it can be, like again we all know pre-testicular, testicular, post-testicular, it can be obstructive, non-obstructive. So it can be varicocele, it can be obstructive causes, it can be immunological and neurological causes, it can be genetic, unexplained or functional causes like ejaculatory dysfunction, or it can be some severe infections leading to like this male factor abnormalities. The lifestyle factors play a major role in fertility, let it be a man or let it be a woman. So weight, that is obesity, habits, and we all are addicted to screens, let it be laptop, let it be iPad, let it be phone, whatever, always sitting, sleeping. So it's like our screen is much more than the spouse nowadays. So those have a very bad effect on the fertility also. So hot tubs or saunas, tight innerwear, exposure to toxins and heavy metals, cell phone usage, drugs and steroid misuse, all these will affect the fertility very badly. So heat, stress will affect the spermatogenesis. So 1% increase in testicular temperature, it leads to 14% decrease in spermatogenesis. So reducing, it will reduce the sperm quality and increases the infertility, risk of infertility because of the mitochondrial damage. So these are the professions which cause decrease, like increase in the scrotal temperature, decrease in the spermatogenesis, like prolonged sitting with the laptops, long drivers who sit and drive for hours together, pujaris who sit with the homas and do long hours of pujas, and the chefs also who will be with the fire most of the time. So there are multiple drugs causing the fertility decline in men. So according to WHO, 2020, the normal parameters are volume should be around 1.4 ml, count should be a minimum, these are the minimum parameters, around 16 millions. Total motility should be around 42% with a progressive motility around 30%. The viable sperm should be around 54%, and normal morphology should be a minimum of 4%. These are the recent things which we follow. So a thorough history, a detailed semen analysis, and a detailed evaluation of the man will help us identifying where the problem is and will help us identify and guide their treatment also. So high DFI and the chromosomal abnormalities and other things like Y chromosome microdeletions also play a major role in evaluating the male partner. A basic scan, like as I mentioned, and the hormones like FSH, LH and inhibin B for the man to identify the causes, and then hormonal profile and then evaluate him will help us. If we found him like all these parameters and the hormones and other things are normal, we can go for surgical retrieval of the sperms, either with PESA, TESA, TESE or micro-TESE. If they don't get any sperms on this, we can try as per new, we can try with the hormones, we can try after 6 months also. If fails then also, then we can suggest donor sperms. So this is a case, but as the time has lapsed, I'm just skipping this. This was a case where a man found to be azoospermia in couple, and we did TESA, we retrieved sperms, we did IVF with that, and they conceived. So conclusion, thorough history, a proper medical evaluation, proper evaluation about their occupation, and advanced analysis whenever necessary will help us identify them and guide them in proper treatment. So there is lot of fallacies about these things also, like intratesticular PRP, whether it will improve or not, like as in case of ovaries, but they are still fallacies only. Nothing been proven so far. Thank you. Any doubts?
Thank you, Anita. Thanks for coming all the way from Bangalore.
Thank you, sir.
It was a very fundamental, basic information for all the doctors. So you addressed the audience very well. Just one question. There is some misconception about the social egg freezing among the general population and even among the junior doctors or general doctors. So can you just enlighten them with what is social egg freezing and what is the success rate?
Yeah.
Because many think that they can just freeze the eggs and have the baby later. Okay.
Yes.
Thank you.
Very good questions are very much needed for the present generation also, because as during introduction I told, many of us are, because in view or in perception of our education, career or whatever, or higher post or medals, certificates, we are postponing the pregnancy, we are planning. So social, like egg freezing can be done for the people or for the girls or for the women who are affected with the diseases like cancers or anything, if they are affected, if they are going for treatment like radiation, chemotherapy, surgery on the reproductive organs, before they go to the treatment, we freeze the oocytes or we freeze the semen. So that is freezing for a cause. That is, we are freezing because they are going for a treatment, because after the treatment they lose their fertility potential. But in social freezing, since they are more career oriented or anything, if they want to freeze the oocytes or the semen now and they want to go for pregnancy later with their own oocytes, like maybe glamour industry, they might have a good career in the glamour industry, they want to have children after 40 years. By then their fertility potential would have declined. So they can freeze their eggs at the age of 30 or so, and they can have their own baby after 40. So very good success rates, but the success rates are better with the embryo freezing than the egg freezing. If we freeze 10 eggs, when we thaw and inject with the sperms, maybe 4 embryos we might get, good embryos. But when we are planning to freeze, if they come as a couple, and if we freeze the embryos, when we freeze 6 embryos, all 6 embryos might survive and they might have a good potential. That is the only risk associated, because the frozen oocytes, when we thaw and do ICSI, we may not get the expected number. Otherwise, there are no risk factors. And good also, if anyone planning, let it be your friends, your next generation, so you can advise them. Go for social freezing instead of going for donor cycles in the later age.
Thank you, ma'am, for this enriching session. Now, I request the chairpersons to kindly do the honors of felicitating the speaker.
Thank you everyone. I now request Dr. Megha GH, Organizing Secretary, Academy of Medical Specialties Conference, to kindly felicitate our chairpersons. Thank you everyone. Our next session showcases the breadth of surgical possibilities, plastic and reconstructive surgery.
Now we welcome Dr. Jashwant C.T. Sir, plastic and reconstructive surgeon, to speak on spectrum of plastic and reconstructive surgery in a Tier 3 city. Chaired by Dr. Sridhar Murthy Sir, Professor General Medicine, BMCH, Chitradurga. And Dr. Arun Kuna from Chalkere, IMA Secretary, and Dr. Jai Kumar Sir, Family Physician, Chitradurga. I request the chairpersons to kindly introduce the speaker by reading their CVs.
Good evening, everybody. It is my pleasure to introduce Dr. Jaswant C.T. Dr. Jaswant C.T. is a consultant plastic, hand and aesthetic surgeon from Chitradurga, currently practicing at Renew Plus Clinic and Kottresh Hospital, Chitradurga. He completed his MBBS from Al Amin Medical College, Bijapur, followed by MS in General Surgery from Vijayanagara Institute of Medical Sciences, Ballari. He further pursued his doctorate in National Board at Dinanath Mangeshkar Hospital, Pune. In addition to his core qualification, he has undergone specialized training in diabetic foot management, AV fistula surgery, and non-surgical aesthetic procedures. With special interest in reconstructive surgery, hand surgery, facial-maxillary surgery, Dr. Jaswant has actively contributed to academic forums by delivering lectures and moderating workshops at various conferences. He is an esteemed member of several professional bodies, including Association of Plastic Surgeons of India, Indian Association of Aesthetic Plastic Surgeons, Indian Society for Surgery of the Hand, Karnataka Association of Plastic and Reconstructive Aesthetic Surgeons, and the Indian Medical Association, Karnataka. Thank you very much, sir. Please take over the mic, sir.
Yes, sir. Thank you very much for the kind introduction, sir. Good evening, all. I know I am the last batsman for this session, and you expect good strike rate from me. So my slide changing rate will be 10 slides per minute, okay? So you can be entertained, don't worry. Yeah, disclaimer, all the surgeries shown here performed by me in Chitradurga after coming here for the past 4 years. All due consents of the patients has been taken to show these pictures for academic benefit. So as plastic surgery involves whole of the body, I have divided into head and neck, chest and abdomen, upper limb and lower limb. So this will be an rush through the photos, pre-op, post-op and few intra-op pics. So I hope I'll keep you all entertained. So head and neck, I will get in Chitradurga, I get as simple cases as this, which gives a good cosmetic result, and a complicated an auto rickshaw accident where a school child has this type of injury. So there is a skin defect here, and I have put a skin graft just below the eyelid, and here is the result after 3 months. And we sometimes get very horrible cases according to patients, but this is what we are trained to. So after procedure, this is after 6 months, we get an acceptable face. So then such wounds sometimes are scary, where there is no eyelid, only the tarsal plate is there. But upon exploration and proper wound debridement, it's only a zigzag puzzle where it needs to be rearranged. And here you can see, and this is the POD2 after 48 hours. There is a good eyelid movement, and I have a video also where the eye movements are also there. So one more case, a young lady who is worried by the defect here just below the lid. A rotational flap was done. So at 3 months, she is happy with the result and ready for marriage. Yeah, this is a patient for assault. She had an scalp injury with bone exposed. So thorough debridement was done. The bone was exposed. It was covered with an muscle flap. Then a rotational flap was done, by rotational flap, and the result is no scar because of hairs, obviously. So this is an temporal artery aneurysm. So operated once, recurrence, then it was excised, and patient is symptom free right now. This is a simple ear keloid done in contour surgery. She had bilateral ear piercing later in life after 40 years, and this was the keloid. So after 6 months and after 1 year, the follow-up there was no recurrence, which is normally difficult. So this was a simple case, and sometimes we get a complicated case like this. This patient used to come from Hospate. So I had to downsize this by giving intralesional steroid for up to 9 months, monthly injections. Once it was then, the size was reduced. Then I did a contour surgery, and then from here, this is the result after 6 months. So basal cell carcinoma, wide local excision, defect of more than 4 to 5 centimeters, a local rotational flaps, and this is the result. So this is a bilateral torticollis, bipolar sternocleidomastoid release was done, and from here, the patient was here, that too before stitch removal. Then I lost follow-up of this patient to see the long-term results. This was a penetrating injury, a lorry door cutting through the neck, injury of trapezius muscle, middle scalene muscle, and levator scapular muscle repaired. Patient is fine. This is an dashboard injury after 1 year. This is a follow-up of my known patient. So I could get follow-up of even 1 year. So and this is an acceptable scar with such type of a wound. So this is a bat ear corrected. So this was how it is, and now the matching to the opposite side. This was an hairy nevus on the face. Ideally, it needs a tissue expansion and there, but patient was not ready for it. So then I planned for a serial excision, and over a period of 1.5 years, every 3 months. So I have achieved this, and still minor correction is needed. So maybe next year presentation, I will be having a complete picture of this patient. So an eyelid papilloma, excised without any difficulty. A basal cell carcinoma of the nose, reconstructed with an paramedian forehead flap. So from here, this is the result. Basal cell carcinoma, apocrine tumor of the nasal tip. A lot of geometrical calculation. Even though we are in medicine, we shouldn't, I can't forget geometry. So revision, and here it is. This is basal cell carcinoma reconstructed with an nasolabial flap from here till here. So also difficult cases, see floor of tongue and floor of the mouth cancer reconstructed with PMMC flap. This was the defect. This was the defect here. So this is the flap inset, and then medial mandibulotomy is fixed. And this is at 14 days. So maxillofacial fractures is a main part of our day-to-day activity. So we get such pan-facial fractures where we have to bring the teeth in occlusion, then put an arch bar, then fix the bones, mandibular bones, the zygomatico buttresses, then infraorbital rims on both sides. So these are the plates I have put, and after 3 months, this is the result. So perfect occlusion and perfect mouth opening. So we also sometimes reconstruct the floor of the orbit with an orbital floor mesh. So this is head and neck. Now coming to chest and abdomen. These are keloids which are difficult to manage, but with proper motivation and follow-up, I could achieve this after 12 months of intralesional steroids. And even this chest keloids, same intralesional steroids and pressure massages, pressure therapy, silicone gel applications, I could achieve this from here till here after 9 months. So this is a pilonidal sinus, simple excision and a Limburg flap, healed in 15 days as compared to a primary excision which will heal in 3 months. So this is an spina bifida or teratoma, wide local excision with a defect of 9 centimeters. Bilateral VY advancement flap was done and closure, healed in 3 weeks. This is a fibroadenoma. Few young girls who come with a fibroadenoma and they don't want a scar. We try to palpate and try to bring that fibroadenoma towards the nipple areola complex, and if you can reach it, then we can take an periareolar incision, take the specimen out, and this is at 14 days at suture removal. There is no scar visible because it is hidden in the periareolar area. So this is an axillary breast or an accessory breast. So you can see the fold at the axilla, excision done, and you can see immediately post-surgery seen. even at suture removal, you can see the axillary breast has gone. So these are few complicated LSCS cases who come to us with persistent sinuses. That time we do an wide local excision, we track the sinuses, go up to rectus and even rectus muscle, empty the abscess cavities, and then we get a good result. 90% success rate is seen after doing this. The sinuses won't recur. And most commonly, the tuberculosis is the pathogen there. So this is an nevus comedicans. Patient had an herpes zoster in the childhood, and it turned out to be an nevus comedicans. Wide local excision in a serial settings after 6 months. From here, I could achieve this. Even though the scar is there, the disease is gone. So this is an infected spine fixation for disc prolapse. So I had to debride, put a vac, then get the wound contracted and then closure and healed properly within 2 weeks. So burns, we get acute burns as simple as superficial burns. Give a thorough wash under general anesthesia, put collagen dressing, and it will heal in 7 to 10 days. Sometimes we get the deep dermal burns where we need to do an fasciotomy and then an hysterotomy with tangential excision of the burns scar, and then healing in 3 to 4 weeks. So facial burns, girl child, parents are under tension, doctor is under tension, but somehow we could manage, put a collagen dressing. So at 14th day, the baby was able to go to school back, to the school back. So electrical burns, deep burns, I had counseled them for an amputation at above elbow level before taking up for debridement. Luckily, we could manage. This is the thigh wounds, electrical burns, multiple entry and exit points. So did a thorough debridement. I had to dress him for up to 2 months and then put a skin graft. And luckily, I could save the hand. So physiotherapy is needed to make it functional. So the radiator patient had fallen from a tractor. His limb was stuck. The radiator water from the tractor kept on burning him for more than 5 minutes. So I had counseled him for a below knee amputation to the patient. So luckily, I did an debridement. And at the end of 3 months, I could give him his own limb, but without fingers, because the fingers were already gone when he presented to us here. So this is an iatrogenic burns happened in Davangere. A warmer put in good faith to the patient during surgery caused her these burns. So I had again counseled for amputation, but gave a try. Debrided, all the bones were exposed. Then I did a stepladder abdominal flap, put the hand to the abdomen for 21 days, 3 weeks. Then after division, the hands were saved. Fingers were saved. So this is an electrical burn, post-burn contracture, 5-year-old in a 6-year-old child. So I did, this is the fixed contracture of both the fingers. I did the contracture release, put a full thickness skin grafting with K-wire fixation to keep the finger straight. So I could get a straight finger and also movement finger, which video I am not able to put now. So this is a patient, again, 8 years of contracture. Patient was unable to lift his hand. He is 7 years old, and from 1 year he has never lifted his left hand above the shoulder. So then counseled, taken him up for surgery. So put a flap to the axilla and skin grafted other area. And here you can see from here to here in 3 months. So coming to upper limb, AV fistulas are part and parcel of our day-to-day surgeries. So for dialysis, this is a radiocephalic AV fistula. This is radial artery, cephalic vein, anastomosed here. Then after clamp release, dilatation of the cephalic vein. And you can see closure. And this is the dilated vein and POD3. Ideally, we wait for 42 days before initiating dialysis. This is brachial artery, cephalic vein, brachiocephalic fistula. And sometimes we have complications also. This was a patient with Marfan's syndrome, traits of Marfan's syndrome, where there was a brachial artery aneurysm post AV fistula. So this is the aneurysm. So I couldn't separate the aneurysm from the brachial artery, so I decided to excise it. So I excised from top to bottom, the entire aneurysm, including the brachial artery part, was excised. Then the limb was in risk, so I took an grade 7S vein from the leg and reconstructed this is the defect. From clamp here till here is the brachial artery defect of about 5 to 8 centimeters. So this is the loop, this is the great saphenous vein bridging brachial arteries on both the ends. And this is the excised aneurysm specimen. And here you can see this is the brachial artery sitting perfectly here. So this is a drone, this patient is a DRDO employee. While testing the drone, he had that cut. So I thought the finger is gone, like the same as the patient, but on thorough debridement and K-wire fixation, I could save the thumb and saved it 3 weeks. Near total, this is door injuries with distal phalanx exposed, proper debridement and repair, finger survived, fingertip survived. So this is an amputation of the fingertip. A cross finger flap was planned from the ring finger. So this is the donor area covered with skin grafting. And this is the flap inserted onto the defect. So after 3 weeks, after division, this is it. The donor area is also well healed. And the recipient is also well healed here. Similar case, nail bed injury. Normally when nail injury is there, we only concentrate on the pulp and we forget about the nail bed. But on doing nail bed repair, we can get an excellent, from here, we can get an excellent result where it looks like a near normal finger. Near total amputation, fixed, survived. So again, near total amputation, you can see almost only it is attached with only one side of neurovascular bundle. I had to do an digital artery anastomosis and nerve anastomosis also, and it survived after 6 weeks. This is the pic. Even though it is deformed, he has a nail bed and nail complex. So sometimes complicated cases like this comes where it's a mutilated hand. There is no thumb at all here, you can see. It's gone. So I had told them, I don't know, I was very clueless. What can I give to this patient? So then after debridement, I could do this. Then I thought, why not reconstruct a thumb from the amputated index and middle finger. So this is called osteoplastic thumb reconstruction. I took the bone of the index finger and put it on the thumb, fixed with the K-wire, and gave an groin flap coverage. So from this mutilated hand, I could give this where he can hold and support his left hand with, at least I could give him pinch and grasping hand. So this is a nursing student of this institute who had an abscess, and he went to a local Ayurveda because his grandmother insisted to put some leaves. So he presented to us like this. So I did a debridement. Because he was a nursing student and right hand, I thought you can never give injection in right hand, but luckily he was very regular in follow-up. Then I put a skin graft also after a few days, and then I could give him a near normal hand. So crush injury with graded abrasion, again stepladder abdominal flap, finger survived from here to here. So this is a trigger finger. I don't have any video right now. This is the A1 pulley release with a small incision, and patient is able to do a finger flap, trigger finger. This is a Dupuytren's contracture. So this is all fascia unable to extend the finger. So a fasciectomy was done. Here is the specimen excised and kept sideways. So where I could achieve the full extension intraoperatively only, closure and healing after 6 weeks. This is an interesting case. There was a sharp injury resulting in nail plate and nail bed amputation. He is an hotelier in Lakshmi Bazaar. So he wanted a good nail because people will feel bad when he parcels or gives it. So then I told him, so you have to sacrifice something, not the money. The nail bed from his great toe. I took it, put it on this is the white part is the nail grafting, which I have taken from the great toe to his index finger. Then he sent a pic 3 days back when I was preparing this presentation. He had lost to follow-up. So this is his finger, full grown nail. A patient with fracture, neglected more than 2 months. He had osteomyelitis of the middle finger. He was unable to use his left hand. He was a hamali in APMC, this thing. He told, sir, 2 mahine se kaam nahi kiya hu, paisa to hai nahi. Then I told, okay, I'll send you to your work. So then I amputated, did a re-amputation. And from here, he had this. And after 2 months with physiotherapy, he went and he told, abhi main 50 kg ka weight to uta raha hu. So I'm happy, and he gave me my money back also after he started earning. Yeah. So this is one amputation. So ideally, without skin cover, we need to do an re-amputation at just cross it so that, but patient won't be functioning the hand. So I tried to salvage that whatever bone is left. Again, did a groin flap, and from here I could give him some length so that he can hold things, bottle or anything. Yeah. So this is the anterior transposition of ulnar nerve in an cubital tunnel syndrome. So here you can see there is a constriction here where the proximal nerve is swollen and the distal one is very thinned out. So then this is the subfacial. There are multiple types: subfacial, submuscular, or subcutaneous anterior transposition. My preferred choice is subfacial. Then I did an fascia elevation here and then fixed it. So this is an glass cut injury. All the tendons, flexor tendons of the hand were cut of all the 4 fingers. This took me 5 hours to identify, and I couldn't get good pictures also. So somehow I could, from here, the above picture, I could get the cascade, the typical flexion cascade. And then I have this video also, but I couldn't play now. So he was able to flex and extend after 3 months. This is a recent case, maybe POD7 or POD6, a gross injury, orthopedics patient. He debrided, he did orthodesis. This was a huge defect. If we couldn't cover this within 3 days of injury, then he would have definitely landed in amputation. So we did an groin and hypogastric combined flap with this is the femoral artery here. This is the superficial circumflex iliac artery, and this is superficial inferior epigastric artery cycle. This is the flap which was taken. The donor area was skin grafted, and then the hand was kept to the abdomen, and it was flap insetting was done. So it's doing good. I checked the dressing on 5th day. The flap has survived. So this is proximal interphalangeal fracture dislocation. This can't be treated with K-wire. It needs a Suzuki frame. So this is it, where there is distraction of the PIP joint, thereby with active physiotherapy from the day of surgery. So this is how it is done, and the patient recovered fully after 6 weeks. So this is routine tendon injuries on the extensor aspect. Opened, identified, sutured, good, healed well. This is on the dorsum of the hand, wrist, involving extensor tendons of the hands. All the tendons identified with various colored needles, and all repair done here, including vessels. Yes. This is if they present us immediately. When they come after 2 months, so all tendons had sloughed out, and there was a defect of more than 5-6 centimeters. I took a palmaris longus tendon from the volar aspect, then reconstructed the tendons, and then closure was done. This is a case of schwannoma of median nerve, excised nerve. This is the specimen, and nerve was preserved with only few fiber damages, and then patient had a good outcome. This was a very trivial glass injury resulting in ulnar nerve and ulnar artery injury, with ulnar nerve injury causing a claw hand. So ulnar artery and nerve was repaired, nerve, the artery, and then the clawing was gone after 3 months once nerve regeneration was complete. So this is an ganglion, recurrent ganglion excised by some other doctor under local anesthesia. I prefer excising ganglion under brachial block or general anesthesia with tourniquet, where I don't want to see a single drop of blood while excising a ganglion. So by doing so, I can go till the base up to the joint capsule and excise the complete. And this is already 3 years old, and the patient has not yet come back without recurrence. Yes. So this is carpal tunnel syndrome. Transverse carpal ligament release. This is median nerve, neurolysis done, closure. So coming to last part, lower limb. Trauma with heel pad avulsion. Difficult case was what I thought. Debrided, then tagged it, dressed for 3 weeks, got a good bed, skin grafted, and patient is an auto driver from Hirur and is able to walk and do his routine stuff. So this is an wound with the medial malleus exposure and nail plate. This implant was put. Then I did an reverse solar artery flap to this, then divided after 3 weeks. At the end result, after 3 weeks, the donor area is only minimally scarred, and we have got a good coverage onto his medial malleolus. So this is bone exposure, lower tibial. The implant is inside on the anterior surface. So did a rotational flap, covered. So limb saved without being implant to be removed. So this is near total amputation of the second toe, fixed micro anastomosis done, and survived. So diabetic foot necrotizing fasciitis is a common happening in this part of the Karnataka. So this under anesthesia, thorough debridement is done without going 1 to 2 centimeter. This is like wide local excision, what we do in cancer. I follow that in diabetic foot also. So from here to here, half an hour. From that, from the previous wound to this wound, it takes 3 weeks. Put a skin graft. From this is half an hour from here to here, and from here 3 weeks. This is the donor area is healed, and this is healed. So total 42 days or 6 weeks. 3 weeks for debridement and grafting. From grafting till this 3 weeks. So total in 45 days, patient was able to walk on his own foot. So this diabetic deep space abscess or plantar abscess looks so small, but it can go. So you can see the extension along the flexor hallucis longus tendon up to. So from here, the debridement goes on like this. So an extensor tendon injury of the foot, where the tendons have been retracted, identified, sutured, and closure done. So this is an intramuscular lipoma. This was attached to the peroneal vessels, separated slowly, and closure done. This is an tibial, posterior tibial nerve tumor, which was malignant, which we didn't know initially. So I tried to salvage the nerve, so I couldn't reach here. This is the entire connection here. It was up to 5 to 6 centimeters. So on a meticulous dissection, I could reach up to here, but from here onwards, I couldn't dissect. So then I decided to sacrifice the tibial nerve. So, and this is the defect, what you can see, and I could primarily repair it. And patient didn't have any neurological deficits. Then patient underwent radiotherapy at Shankara Cancer Hospital, Bangalore. So this is one more intramuscular lipoma bulging out from the fascia. It was an intramuscular thing, but also subcutaneously it had bulged out from the fascia. Excised completely. It was very close to the tibial, anterior tibial nerves, but didn't involve it. So this is simple skin grafting, what we plastic surgeons are known for, because whenever plastic surgeon is done, it is only for skin grafting is what others feel. So this is a simple skin grafting. This is at 15 days, that is at 1.5 months. And sometimes we get such a huge thing where I had to take all the skin from his both thighs. So from here, grafted multiple, and there was not even an inch of skin loss, and I could get the contour of the dorsum of the foot clearly. And a huge wound from ankle till knee, grafting taken, applied within 15 days. This was the wound. Yeah, diabetic ulcer over heel. So non-healing ulcer for more than 6 months. I did a thorough debridement. This was the defect 4 into 3 centimeters. Took an rotational flap from the heel pad. Suturing done, and this healed at 3 weeks. Complete healing of the wound. So this is non-healing ulcer of the IP joint. We do a thing called Keller's gap arthroplasty, where base of the proximal phalanx is excised. So thereby the momentum is shifted and the ulcer heals on its own. So this is an old case of tendo-Achilles injury. So we can see the defect in the tendo-Achilles is then repaired, sutured, and patient is walking at 3 months. So this is an calcaneal region injury with exposed calcaneum and infected calcaneum. Somehow we could salvage the calcaneum, did an reverse oral artery flap. So from here, the wound is healed and patient is back on his heel. So this is one deglowing injury, debridement, and done, and this is healed without any grafting needed. So this is an cross finger flap done by our other plastic surgeon, and salvaged the limb 2 years back. Now that plastic surgeon is not in town, so they came to me. So I took up and I did flap thinning. The bulky flap, we couldn't wear shoes or slippers. So I gave him a flatter foot. Now he's happy. Yeah, because till now I have only shown aesthetic surgery, not that Chitradurga is not forward or improved. I even get aesthetic surgery patients also. So I have only even index cases. This is an patient, 28-year-old with non-developed breast, silicone augmentation done. This is the result at 3 months. This is a patient with under eye bags, blepharoplasty done. She looks younger by 5 years, I think so, if you agree. Yeah, and this is a patient with a depressed scar. I did an autologous fat transfer. This fat is being taken from his abdomen and then decantation done, and the fat is injected. And you can see immediate bulking. Normally we put 25% more than what is required, because up to 30 to 40% of fat gets absorbed within 3 months. Yes. Thank you very much.
Thank you very much, sir, for your wonderful illustrations, and you have done a wonderful work also.
Thank you,
we congratulate you and thank you very much, sir. Wish you all the best.
Thank you, sir. Keloid. Yes, sir.
How frequently you inject the steroid?
Sir, my consultants used to prefer 21 days.
21 days?
Every 21 days, one injection, sir. Intralesional steroid.
How many?
Sir, it depends on the lesion. I normally tell them 3 to 6, and depending on, they have to be ready. But I practice here is every month, sir, because 30ನೇ ತಿಂಗಳು 2ನೇ ತಾರೀಕು ಪ್ರತಿ ತಿಂಗಳು is easy rather than 21 days, because they get a lot of festivals in between and they just lose, sir. So monthly cycle tara, they come to me exactly on that day and they get injected.
What else you will do along with the
sir, along with that, massage for 15 minutes, sir, morning and evening 15 minutes.
They have to do
I tell them the day you miss brushing, you have to miss massage. Madve irli, abba irli, they do brushing, so they have to massage. So every day they have to do, sir. And then I give silicone-based gel to apply and a silicone-based gel sheet to apply, sir. Those things I do.
Sir, in nowadays in infected cases,
yes, sir.
So there is a ozone is in this thing now. You have any
experience? Sir, that is all for if you want to prolong patients, you can do all those type of dressings, sir.
Like vac instead of vac now, yes, ozone sir. Ballooning is also coming up.
No idea, sir.
No idea.
I have come to Chitradurga 4 years and I think I have stopped studying from past 4 years. Okay. New ozone, maybe I'll go and update, sir. Next week I'm going for conference, maybe I'll.
And you said for the dorsal injuries of the fingers.
Yes, sir.
You did skin grafting, right?
Yes, sir.
You did grafting?
No, not grafting, sir. This is abdominal flap.
Yeah, and along with that, you have put the pin all across the IP joint.
Yeah, sir, because there was fractures also.
How long you want to keep that?
6 weeks, sir.
Because once if you keep more than 3 weeks,
yes, sir,
it may give the stiffness.
Yeah, sir, but with fractured bone, we risk malunion or non-union also, sir. So, because these are all young patients who have trauma, even after 6 weeks, they are able to do it, sir. I have videos
actually,
also.
The skin graft will take in 25 days.
Not skin graft, sir. This is that needs 21 days, sir, minimum.
21 days.
Because the blood supply has to come from the injured finger to the flap before I divide.
And if you take it out earlier, I think the mobility can be.
Yes, sir, that is there. But in an elder individual, I decrease the 21 days waiting period to 15 days and K-wires to 1 month, sir, 28 days. Okay. But young people, I keep it for 6 weeks because they have to lift weight, do vigorously. So I want good healing. So I wait for 6 weeks minimum, sir.
And in your this thing like foot,
yes,
so chronic rupture of the tendon Achilles.
Tendon Achilles, yes, sir.
Have you done the VY-plasty?
No, sir. Even because I put the foot in dorsiflexion for a long term, sir, and the injury was 1.5 years old. I just brought the 2 edges and it was closing without tension. Tension hardly, I can say there was no tissue loss, sir, or tendon loss.
No, if it
so I could get it.
1.5 years means there will be a prolonged.
So, but in this patient somehow I could get it, sir. And the patient is, you saw him standing on flat slippers, both the limb. He is able to walk also, sir.
But usually there will be retraction.
Yes, you are right, sir. I have done VY-plasties also many times, sir. Okay. And I have also flipped the tendon Achilles, split into half, rotated it, and I have fixed it to the bone also by anchoring sutures. That also I have done, sir. Okay. This is an index case. I thought I should keep it simple. And
so then what's your advice for recurrent ingrowing toenail?
So recurrent ingrowing toenail, one episode when there is an acute abscess, I just remove the nail plate and leave it for healing.
Okay.
And if it recurs again, then they are more convinced. Matte agodila, sir. Then I go and excise the nail plate and do an repair the skin fold. I'll bring it below the nail
It's
bed,
on
sir.
the both side of the same nail.
Yes,
So,
sir.
Only excision.
No, sir. Both sides I hardly have seen, sir. I've only seen on one side of the this thing finger.
You will do partial excision or the total excision?
Total excision, sir. Up to the bone. Complete nail bed excision, and that skin flap I'll bring it below the nail bed level, sir. So that no recurrence is seen. Yes, sir.
Thank you, sir.
Thank you very much, sir.
Thank you, sir, for sharing your expertise with us. I request the chairpersons to kindly do the honors of felicitating the speaker.
Thank you, everyone. I now request Dr. Yogendra Sir, Organizing Secretary, IMA, Academy of Medical Specialties, Chitradurga, to kindly felicitate our chairpersons. Thank you, everyone. And now, the time has come to bring this wonderful day to a close.
We welcome you all for the valedictory function and closing ceremony. I now request the dignitaries to please take their seats on the dais. Dr. GB Bidinal sir, National Vice President IMA, and to chief guest for today's function.
Dr. Suriraju V. Sir, Honorable Secretary, IMA, Karnataka State Branch.
Dr. Palakshaya L. Sir, President IMA Chitradurga.
Dr. Prahlada N.B. Sir, the Honorable Secretary, IMA, Chitradurga.
Dr. Narayan Murthy C. Sir, Organizing Chairman, Academy of Medical Specialties Conference.
Dr. Shilpa Ma'am, Treasurer, IMA, Chitradurga.
Dr. Yogendra Sir and Dr. Megha Ma'am, Organizing Secretaries of AMS Conference.
Dr. S.Y. Mulki Patil Sir, Chairman, IMA, AMS, Karnataka State Branch.
Dr. Manjunath Nekar Sir, Honorable Secretary, IMA Academy of Medical Specialties, Karnataka State Branch. I now request
welcome. Yeah, respected dignitaries on the dais and friends. Now that wonderful AMS Con, Academy of Medical Specialties, Karnataka State and Southern Conference comes to an end. So on this occasion, so we are going to have a small informal valedictory program. Okay, on this occasion, I hereby request Dr. Bidinal sir to say a few words, concluding words for the event. Yeah.
Dignitaries on the dais and off the dais. Really, it is a very good conference. IMA AMS South Zone and IMA AMS Karnataka State Branch Conference. And meticulously, they have conducted, and selection of the topics are very good. And all the attendants, I request the younger generation to attend in large numbers to update their knowledge, attending such functions, such conference, AMS conference and IMA conference, and gain your knowledge, update your skills, and also update your knowledge. Knowledge is very vast, like an ocean, and the ratio of what you know and what you doesn't is zero. But what you does not know is infinite. Therefore, you must always update your knowledge. Then I must congratulate all the organizing team and Karnataka State Branch team. Thank you very much. Thank you one and all. Jai Hind, IMA Chirayavagli.
Hereby I request Dr. Srinivasa and Dr. Prabhakar sir, the past presidents of IMA KSB, to come onto the dais. Just an honor. Yeah. Yeah, on this occasion, hereby I request the Chairman of AMS Con, Dr. Mulki Patil sir, to say a few concluding words about the event. Meanwhile, friends, after this event, immediately we're going to start the most awaited event, that is Teachers' Day program. So please stay on. Thank you.
Good evening, respected dignitaries on the dais and off the dais. I think we are seeing some new faces in the audience because the next program, almost the last program, is going to start. Since morning, this was the academic feast we had today, almost from the 9 o'clock, followed by afternoon oration. And I must thank and appreciate the host branch, Chitradurga branch, headed by Dr. Palakshaya sir, as well as organizing chairman, Dr. Murthy sir. Please give them a big hand for successful conducting of this IMA AMS state conference as well as South Zonal conference. Without their efforts, probably it would have not possible. Take it academic, take it a food, transportation, every aspect they have covered excellently. Brilliant, sir, everything. Thank you once again. Thank you.
Thank you very much for those kind words, sir. So with this, I say the final vote of thanks. I thank all the dignitaries on the stage and also all friends for having come from different parts here, and also mainly the participants of paper presentation, research paper presentation who have come from various medical college. Thank you very much for your participation. It's because of you this program is successful. I'll give a full credit to all of you and also our volunteers. Thank you very much. Thank you all. Okay, in another 15 minutes, we'll start the next program. We'll make the stage arrangements for the same thing. Okay, you can stretch your body a little bit, you know, until then. Yeah, there's a tea break, tea. Go down, have tea, and come back to the hall immediately. Agidayilla? Okay, okay.
Thank you, sir. On behalf of IMA Chitradurga district branches, we thank each one of you for your valuable presence and active participation. Let's continue to learn, collaborate, and serve society better.
Now we will have a short tea break. Please refresh yourselves and rejoin us for the Teachers' Day celebration. Thank you.
ಹಲೋ ಚೆಕ್ 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 ಹಲೋ ಚೆಕ್ 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 ಹಲೋ
Hello. Hello, hello. I request all the Teachers' Day awardees to sit on the right side to the dais in the second and the third row.
Hello, hello, hello.
Anything, I'll be here. Hello, hello, hello. Hello, hello, check.
Hello. Hello. Hello, hello. Hello. Hello, hello. ಅಲ್ಲ ರೀ ನಾವು ಇಬ್ರು ನಿಲ್ಬೇಕಿಲ್ಲ
ಇಷ್ಟಿಲ್ಲ ಇಷ್ಟಿಲ್ಲ ನೋಡ್ರಿ
ಹಲೋ ಹಲೋ ಹಲೋ
ಬೇಕಾ
ಮೈಕ್ ಇದೆ ಅಲ್ಲಿ ಗೊತ್ತಾಗಲಿಲ್ಲ ಅಂದರೆ ಅದು ಕೊಡ್ತೀನಿ. Hello, hello. Hello. Hello, hello. Hello. Association and Stage branch. We extend a warm welcome to everyone present here.
Sukumar HP sir ಬರ್ತಾರಲ್ಲ he is a dean and professor dean and Kim sir Bengal
A very good evening to everyone present here. That's mine. On behalf of the Indian Medical Association Hematology State Branch, we warmly welcome you to this beautiful event being held at the fourth city of Chitradurga on occasion of the Teachers' Day.
ನಾನು ಕುಮಾರ ಶ್ರೀನಿವಾಸ್ ಬಸವೇಶ್ವರ ವೈದ್ಯಕೀಯ ಕಾಲೇಜಿನ ವಿದ್ಯಾರ್ಥಿಗಳು ನಿಮ್ಮೊಂದಿಗೆ ಗುರುವಿಂದ ದಯಗಳು ಗುರುವಿಂದಲೇ ಸಕಲ ಪುಣ್ಯಗಳು ಗುರುವಿಂದ ದೈವಾದ ಸಾಮಾಜಿಕ ಕಳಕಳಿ ಒಳ್ಳೆಯ ಉತ್ತಮ ಶಿಕ್ಷಕರು ಸಭ್ಯ ಸಮಾಜದ ಕನಿಷ್ಠ ಬಾಣಕ್ಕೆ ಶಿಕ್ಷಕರು ಅತಿ ಮುಖ್ಯವಾದ ಉತ್ತಮ ರಾಷ್ಟ್ರ ನಿರ್ಮಾಣದಲ್ಲಿ ಒಬ್ಬ ವಿದ್ಯಾರ್ಥಿಯ ವ್ಯಕ್ತಿತ್ವ ವಿಕಸನದಲ್ಲಿ ಪ್ರಬಲ ಪಾತ್ರ ವಹಿಸುವ ಶಿಕ್ಷಕರು ನಮ್ಮ ಕಷ್ಟ ಸುಮ್ಮನೆ ಕೂತಾರೆ.
A very good evening to everyone present here. On behalf of the Indian Medical Association, Karnataka State Branch, we extend a warm welcome to everybody to this beautiful event held in the fourth city of Chitradurga on occasion of the Teachers' Day. This is me, Dr. Janavi Kulkarni.
ನಾನು ಕುಮಾರ ಶ್ರೀ ಬಸವೇಶ್ವರ ವೈದ್ಯಕೀಯ ಕಾಲೇಜಿನ ವಿದ್ಯಾರ್ಥಿಗಳು ನಿಮ್ಮ ಮುಂದೆ. ಗುರುವಿಂದ ದೈವಗಳು, ಗುರುವಿಂದ ಬಂಧುಗಳು, ಗುರುವಿಂದಲೇ ಸಕಲ ಪುಣ್ಯಗಳು ಲೋಕಕ್ಕೆ, ಗುರುವೀಗ ದೈವ ಸರ್ವಜ್ಞ. ಸಾಮಾಜಿಕ ಚಿಂತನೆ, ಕಳಕಳಿ ಹೊಂದಿರುವವರೇ ಉತ್ತಮ ಶಿಕ್ಷಕರು. ಸದೃಢ ಸಮಾಜ ಮತ್ತು ಬಲಿಷ್ಠ ರಾಷ್ಟ್ರ ನಿರ್ಮಾಣಕ್ಕೆ ಶಿಕ್ಷಕರ ಕೊಡುಗೆ ಅತಿ ಮುಖ್ಯವಾದದ್ದು. ಉತ್ತಮ ರಾಷ್ಟ್ರ ನಿರ್ಮಾಣದಲ್ಲಿ ಪ್ರತಿಯೊಬ್ಬ ವಿದ್ಯಾರ್ಥಿಯ ವ್ಯಕ್ತಿತ್ವ ವಿಕಸನದಲ್ಲಿ ಪ್ರಬಲ ಪಾತ್ರ ವಹಿಸುವುದು ಶಿಕ್ಷಕರು ಎಂಬುದನ್ನು ನಾವು ಮರೆಯುವಾಗಿಲ್ಲ.
The role of medical teachers, especially in preparing doctors who protect the health of the society, is even more crucial. The Indian Medical Association Karnataka State Branch has been performing the noble task of identifying and honoring such excellent teachers on Teachers' Day, a day to remember the ideal teacher of India, Dr. Sarvapalli Radhakrishnan. It is a matter of pride for us that this year's ceremony is being held at our Basaveshwara Medical College.
ಈ ಕಾರ್ಯಕ್ರಮದ ಅಧ್ಯಕ್ಷತೆ ವಹಿಸಿರುವ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ಅಧ್ಯಕ್ಷರಾದ ಡಾಕ್ಟರ್ ವಿ ಚಿನಿವಾಲರ್ ಸರ್ ಇವರನ್ನು ವೇದಿಕೆಗೆ ಗೌರವಪೂರ್ವಕವಾಗಿ ಆಹ್ವಾನಿಸುತ್ತೇವೆ. ನಮ್ಮ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಮೆಡಲಿಯನ್ ಅನ್ನು ಡಾಕ್ಟರ್ ಸುರಿರಾಜ್ ಸರ್ ಅವರು ಡಾಕ್ಟರ್ ವಿ ಚಿನಿವಾಲರ್ ಸರ್ ಅವರಿಗೆ ಹಾಕಬೇಕೆಂದು ವಿನಂತಿಸಿಕೊಳ್ಳುತ್ತೇವೆ. IMA ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ನಿಯೋಜಿತ ಅಧ್ಯಕ್ಷರಾದ ಡಾಕ್ಟರ್ ವೀರಭದ್ರಯ್ಯ TA ಇವರನ್ನು ವೇದಿಕೆಗೆ ಗೌರವಪೂರ್ವಕವಾಗಿ ಆಹ್ವಾನಿಸುತ್ತೇವೆ. IMA ರಾಜ್ಯ ಖಜಾಂಚಿಗಳಾದ ಡಾಕ್ಟರ್ ಶಂಕರ್ ನಾರಾಯಣ್ ಸರ್ ಇವರನ್ನು ವೇದಿಕೆಗೆ ಆಹ್ವಾನಿಸುತ್ತೇವೆ. ಈ ಕಾರ್ಯಕ್ರಮದ ಉದ್ಘಾಟಕರಾಗಿ ಆಗಮಿಸಿರುವ ಡಾಕ್ಟರ್ ಬಸವಕುಮಾರ ಸ್ವಾಮೀಜಿಗಳನ್ನು ಆತ್ಮೀಯವಾಗಿ ವೇದಿಕೆಗೆ ಆಹ್ವಾನಿಸುತ್ತೇವೆ. ಇವರನ್ನು ವೇದಿಕೆಯ ಮೇಲಿರುವ ಗಣ್ಯರು ಬರಮಾಡಿಕೊಳ್ಳಬೇಕಾಗಿ ವಿನಂತಿ.
As the chief guest of this Teachers' Day celebration, we extend a heartfelt welcome to the eminent ophthalmologist and honorable MLA of Kudalgi constituency, Dr. N.T. Srinivas sir. A big round of applause. We are delighted to welcome to the stage a distinguished teacher, a senior doctor, and one of Davangere's most respected medical professional, Dr. Mahesh sir. It is our privilege to invite the Dean of Sri Basaveshwara Medical College, Dr. Prashant G. sir, as our esteemed guest. A big round of applause for our Dean.
ಈ ಕಾರ್ಯಕ್ರಮದ ಉದ್ಘಾಟಕರಾಗಿ ಆಗಮಿಸಿರುವ ಡಾಕ್ಟರ್ ಬಸವ ಪ್ರಭು ಸ್ವಾಮೀಜಿಗಳನ್ನು ಆತ್ಮೀಯವಾಗಿ ವೇದಿಕೆಗೆ ಆಹ್ವಾನಿಸುತ್ತೇವೆ. ಇವರನ್ನು ವೇದಿಕೆಯ ಮೇಲಿರುವ ಗಣ್ಯರು ಬರಮಾಡಿಕೊಳ್ಳಬೇಕಾಗಿ ವಿನಂತಿ. IMA ರಾಷ್ಟ್ರೀಯ ಉಪಾಧ್ಯಕ್ಷರಾದ ಡಾಕ್ಟರ್ ಬಿದಿನಾಳ್ ಸರ್, IMA ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ಉಪಾಧ್ಯಕ್ಷರುಗಳಾದ ಡಾಕ್ಟರ್ ಮರಿಗೌಡ, ಡಾಕ್ಟರ್ ಮಲವೇಗೌಡ, ಡಾಕ್ಟರ್ ಸುಜಾತ ರಾವ್ ಮತ್ತು ಡಾಕ್ಟರ್ ಸುರೇಶ್ ಸಗಲತ್ ಇವರನ್ನು ಆತ್ಮೀಯವಾಗಿ ವೇದಿಕೆಗೆ ಸ್ವಾಗತಿಸುತ್ತೇವೆ. ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ಸಹಾಯಕ ಕಾರ್ಯದರ್ಶಿಗಳಾದ ಡಾಕ್ಟರ್ ಮಧುಸೂದನ್ KN, ಜಂಟಿ ಕಾರ್ಯದರ್ಶಿಗಳಾದ ಡಾಕ್ಟರ್ ಮಧುಶಂಕರ್ ಹಾಗೂ PROಗಳಾದ ಡಾಕ್ಟರ್ ವಾಣಿ ಕೋರಿ ಇವರನ್ನು ಆತ್ಮೀಯವಾಗಿ ವೇದಿಕೆಗೆ ಸ್ವಾಗತಿಸುತ್ತೇವೆ.
We are also pleased to welcome the National AMS President-elect, Dr. Venkatachalapati M., the State AMS President, Dr. Mulki Patil sir, and the State AMS Secretary, Dr. Manjunath Nekar sir. Big round of applause. As hosts of the state-level AMS conference at Chitradurga, we warmly welcome our organizing presidents, Dr. Narayan Murthy sir and Dr. Ravindra SP sir, along with the organizing secretaries, Dr. Yogendra sir and Dr. Megha GH Mam.
IMA ಚಿತ್ರದುರ್ಗ ಶಾಖೆಯ ಅಧ್ಯಕ್ಷರಾದ ಡಾಕ್ಟರ್ ಬಾಲಕ್ಷಯ ಎಲ್ ಸರ್ ಹಾಗೂ ಕಾರ್ಯದರ್ಶಿಗಳಾದ ಡಾಕ್ಟರ್ ಪ್ರಹ್ಲಾದ್ NB ಸರ್ ಇವರನ್ನು ಆತ್ಮೀಯವಾಗಿ ವೇದಿಕೆಗೆ ಸ್ವಾಗತಿಸುತ್ತೇವೆ. ಕಾರ್ಯಕ್ರಮದ ಮೊದಲಿಗೆ ಪ್ರಾರ್ಥನಾ ಗೀತೆ ಕುಮಾರಿ ಕೃತಿಕಾ ಎಸ್ ರವರಿಂದ.
ಗೆಲುವಾಗಿ ಬಾ, ಗಜಮುಖನೇ ನೀ ನಮ್ಮ ಗೆಲುವಾಗಿ ಬಾ. ಗುರುಕುಲಕ್ಕೆ ವರವಾಗಿ ಗುರು ತೋರೋ ಗುರುವಾಗಿ ಪೊರೆ ನೀನು ಎಂದೆಂದು ಕರುಣಾಳು ಬಾ ಬಂದು ನೀ ನಮ್ಮ ಗೆಲುವಾಗಿ ಬಾ, ಗಜಮುಖನೇ ನೀ ನಮ್ಮ ಗೆಲುವಾಗಿ ಬಾ. ಬಾಳಲ್ಲಿ ಒಂದಾಗಿ ಬಾ ನಮ್ಮ ಜೊತೆಯಾಗಿ, ಕ್ಷಣ ಕ್ಷಣವೂ ನಮಗಾಗಿ ನೆರವಾಗು ಬೆಳಕಾಗಿ, ದಯ ಇರಲಿ ನಮ್ಮಲ್ಲಿ ಗತಿ ನೀನೇ ಆದಿಯಲ್ಲಿ, ನೀ ನಮ್ಮ ಗೆಲುವಾಗಿ ಬಾ, ಗಜಮುಖನೇ ನೀ ನಮ್ಮ ಗೆಲುವಾಗಿ ಬಾ. ನಿಧಿಯಾಗಿ ವಿಧಿಯಾಗಿ ಸುದೆ ತುಂಬ ಒಲವಾಗಿ, ಹಿರಿಯಾದ ಸಿರಿ ನೀನು ಈ ಬಾಲ ಸವಿಜೇನು, ದಯ ಇರಲಿ ನಮ್ಮಲ್ಲಿ ಗತಿ ನೀನೇ ಆದಿಯಲ್ಲಿ, ನೀ ನಮ್ಮ ಗೆಲುವಾಗಿ ಬಾ, ಗಜಮುಖನೇ ನೀ ನಮ್ಮ ಗೆಲುವಾಗಿ ಬಾ.
ತಮ್ಮ ಸುಶ್ರಾವ್ಯ ಗಾಯನಕ್ಕೆ ಧನ್ಯವಾದಗಳು.
The IMA prayer and flag salutation will now be led by Dr. Prahalad NB.
ವೇದಿಕೆಯಲ್ಲಿರುವ ಮೇಲಿರುವ ಮಾನ್ಯರೇ ಮತ್ತು ಸಭಿಕರೇ, ಎಲ್ಲರೂ ಎದ್ದು ನಿಲ್ಲಬೇಕೆಂದು ತಮ್ಮಲ್ಲಿ ಪ್ರಾರ್ಥಿಸುತ್ತೇನೆ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ ನನ್ನೊಂದಿಗೆ ಎಲ್ಲರೂ ಪುನರಾವರ್ತಿತ ಮಾಡಿ. ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಮಿಷಗಳನ್ನು ಮೀರಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಿರಲಿ. ಈಗ ನಾನು ಧ್ವಜವಂದನೆಯನ್ನು ಮಾಡ್ತೇನೆ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜಕ್ಕೆ ವಂದನೆ ಸಲ್ಲಿಸಲು ಇಲ್ಲಿ ನಿಂತಿದ್ದೇವೆ. ಅದರ ಗೌರವ ಮತ್ತು ವೈಭವವೇ ನಮ್ಮ ಬೆಳಕು ಮತ್ತು ಶಕ್ತಿ, ಮತ್ತು ಅದರ ಪಥವೇ ನಮ್ಮ ಪಥವು. ಈ ರಾಷ್ಟ್ರೀಯ ಸಂಸ್ಥೆಯ ಮಾನ್ಯತೆ ಪಡೆದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ಜವಾಬ್ದಾರಿಗಳನ್ನು ಅರಿಯುವ ಮೂಲಕ ನಮ್ಮ ನಿಷ್ಠೆಯನ್ನು ತೋರಿಸುವ ಪ್ರತಿಜ್ಞೆಯನ್ನು ಮಾಡುತ್ತಿದ್ದೇವೆ. ದೇಶ ಸಮೂಹಗಳ ನಡುವೆ ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜವು ಉನ್ನತ ಮಟ್ಟದಲ್ಲಿ ಹಾರಾಡುವ ಸಲುವಾಗಿ ನಮ್ಮ ಅಧಿಕಾರದಲ್ಲಿರುವ ಎಲ್ಲವನ್ನೂ ಅದಕ್ಕೆ ಸಮರ್ಪಿಸುವ ಪ್ರಮಾಣವನ್ನು ಮಾಡುತ್ತಿದ್ದೇವೆ. ಜೈ ಹಿಂದ್. ಚಿರಾಯುವಾಗಲಿ IMA.
Thank you, sir. To formally welcome our distinguished dignitaries, we request the President of IMA Chitradurga branch, Dr. Palakshya L. sir.
ಡಾಕ್ಟರ್ ಪಾಲಕ್ಷಯ್ಯ ಸರ್ ಅವರಿಗೆ ಶ್ರೀ ಬಸವಪ್ರಭು ಸ್ವಾಮೀಜಿಗಳನ್ನು ಬರಮಾಡಿಕೊಳ್ಳಬೇಕಾಗಿ ವಿನಂತಿಸಿಕೊಳ್ತೇವೆ. ಡಾಕ್ಟರ್ NT ಶ್ರೀನಿವಾಸ್ ಸರ್ ಅವರನ್ನು ಬರಮಾಡಿಕೊಳ್ಳಬೇಕಾಗಿ ವಿನಂತಿಸಿಕೊಳ್ತೇವೆ. ಡಾಕ್ಟರ್ ವಿ ವಿ ಚಿನಿವಾಲ ಸರ್ ಅವರನ್ನು ಬರಮಾಡಿಕೊಳ್ಳಬೇಕಾಗಿ ವಿನಂತಿಸಿಕೊಳ್ತೇವೆ. ಡಾಕ್ಟರ್ ಜಿ ಬಿ ಬಿದಿನಾಳ್ ಸರ್ ಅವರನ್ನು ಬರಮಾಡಿಕೊಳ್ಳಬೇಕಾಗಿ ವಿನಂತಿಸಿಕೊಳ್ತೇವೆ. ಡಾಕ್ಟರ್ ಮುಲ್ಕಿ ಪಾಟೀಲ್ ಸರ್ ಅವರನ್ನು ಬರಮಾಡಿಕೊಳ್ಳಬೇಕಾಗಿ ವಿನಂತಿಸಿಕೊಳ್ತೇವೆ. ಡಾಕ್ಟರ್ ಶ್ರೀನಿವಾಸ್ ಸರ್ ಅವರನ್ನು ಬರಮಾಡಿಕೊಳ್ಳಬೇಕಾಗಿ ವಿನಂತಿಸಿಕೊಳ್ತೇವೆ. ಡಾಕ್ಟರ್ ಸೂರಿರಾಜು ಸರ್ ಅವರನ್ನು ಬರಮಾಡಿಕೊಳ್ಳಬೇಕಾಗಿ ವಿನಂತಿಸಿಕೊಳ್ತೇವೆ. ಡಾಕ್ಟರ್ ಶಂಕರ್ ನಾರಾಯಣ್ ಸರ್ ಅವರನ್ನು ಬರಮಾಡಿಕೊಳ್ಳಬೇಕಾಗಿ ವಿನಂತಿಸಿಕೊಳ್ತೇವೆ. ಡಾಕ್ಟರ್ ಮಹೇಶ್ ಸರ್ ಅವರನ್ನು ಬರಮಾಡಿಕೊಳ್ಳಬೇಕಾಗಿ ವಿನಂತಿಸಿಕೊಳ್ತೇವೆ. ಡಾಕ್ಟರ್ ವೀರಭದ್ರಯ್ಯ ಸರ್ ಅವರನ್ನು ಬರಮಾಡಿಕೊಳ್ಳಬೇಕಾಗಿ ವಿನಂತಿಸಿಕೊಳ್ತೇವೆ. ಡಾಕ್ಟರ್ ಮಂಜುನಾಥ್ ಸರ್, ಡಾಕ್ಟರ್ ಮರಿಗೌಡ ಸರ್, ಡಾಕ್ಟರ್ ಮಲವೇಗೌಡ ಸರ್, ಡಾಕ್ಟರ್ ಮೇಘಾ ಜಿ ಎಚ್ ಮ್ಯಾಮ್, ಇವರನ್ನು ಬರಮಾಡಿಕೊಳ್ಳಬೇಕಾಗಿ ವಿನಂತಿಸಿಕೊಳ್ತೇವೆ. ಡಾಕ್ಟರ್ ಪ್ರಹ್ಲಾದ್ ಸರ್ ಅವರನ್ನು ಬರಮಾಡಿಕೊಳ್ಳಬೇಕಾಗಿ ವಿನಂತಿಸಿಕೊಳ್ತೇವೆ. ಎಲ್ಲರನ್ನೂ ಆತ್ಮೀಯವಾಗಿ ಬರಮಾಡಿಕೊಂಡ ಡಾಕ್ಟರ್ ಪಾಲಾಕ್ಷಯ್ಯ ಸರ್ ಅವರನ್ನು ಡಾಕ್ಟರ್ ನಾರಾಯಣ ಮೂರ್ತಿ ಸರ್ ಬರಮಾಡಿಕೊಳ್ಳಬೇಕಾಗಿ ವಿನಂತಿಸಿಕೊಳ್ತೇವೆ. ನಮ್ಮೆಲ್ಲರ ನೆಚ್ಚಿನ IMA ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ಕಾರ್ಯದರ್ಶಿಗಳಾದ ಡಾಕ್ಟರ್ ಸೂರಿರಾಜುರವರನ್ನು ಈ ಸಮಾರಂಭದ ಕುರಿತು ಪ್ರಾಸ್ತಾವಿಕ ನುಡಿಗಳನ್ನು ಆಡಬೇಕೆಂದು ಮನವಿ ಮಾಡಿಕೊಳ್ಳುತ್ತೇವೆ.
ಎಲ್ಲರಿಗೂ ಶುಭ ಸಂಜೆ. ಮೊದಲನೇದಾಗಿ ಈ ಅದ್ಭುತವಾದ ಕಾರ್ಯಕ್ರಮವನ್ನು ಮಾಡಿಕೊಟ್ಟಿರುವಂತಹ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಚಿತ್ರದುರ್ಗ ಅವರಿಗೆ ನಾನು ಕಂಗ್ರ್ಯಾಚುಲೇಷನ್ ಹೇಳೋದಕ್ಕೆ ಇಷ್ಟಪಡ್ತೇನೆ. ಯಾಕೆಂದರೆ ಇದು ಅದ್ಭುತ ಸಮ್ಮೇಳನ ಅಂತಲೇ ಹೇಳಬೇಕಾಗತ್ತೆ. ಟೀಚರ್ಸ್ ಡೇ, AMS ಕಾನ್ಫರೆನ್ಸು ಮಾಡೋದು ಒಂಥರ ವಿಶಿಷ್ಟತೆಯಿಂದ ಕೂಡಿರುವಂತಹ ಒಂದು ಸಂದರ್ಭ. ಆದರಣೀಯ ಮುಖ್ಯ ಅತಿಥಿಗಳು, ಅತಿಥಿ ಗೌರವಾನ್ವಿತವರು, ಪ್ರಾಧ್ಯಾಪಕರು, ವೈದ್ಯ ಸಹೋದ್ಯೋಗಿಗಳು ಮತ್ತು ಸ್ನೇಹಿತರೆ, ಎಲ್ಲರಿಗೂ ಹೃತ್ಪೂರ್ವಕ ಸ್ವಾಗತ. ಇಂದು ನಮ್ಮ IMA ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆ ಆಯೋಜಿಸಿರುವ ಶಿಕ್ಷಕರ ದಿನಾಚರಣೆ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಪಾಲ್ಗೊಂಡಿರುವ ನಿಮಗೆಲ್ಲರಿಗೂ ಆರ್ಥಿಕ ಸ್ವಾಗತ ಮತ್ತು ಶುಭಾಶಯಗಳು. ಇಂದು ನಾವಿಲ್ಲಿ ಸೇರಿರುವುದು ತಮಗೆಲ್ಲ ಗೊತ್ತಿದೆ. ಶಿಕ್ಷಕರ ದಿನಾಚರಣೆಯನ್ನು ಆಚರಿಸಲು ನಮ್ಮ ದೇಶದ ಮಹಾನ್ ದಾರ್ಶನಿಕರು, ಗುರುವರ್ಯರು ಆಗಿರುವಂತಹ ಡಾಕ್ಟರ್ ಸರ್ವೇಪಲ್ಲಿ ರಾಧಾಕೃಷ್ಣನ್ ಅವರ ಜನ್ಮದಿನವನ್ನು ಶಿಕ್ಷಕರ ದಿನವಾಗಿ ಆಚರಿಸಿರುವುದು ನಮಗೆಲ್ಲರಿಗೂ ಹೆಮ್ಮೆ. ಅವರೊಂದು ಮಾತು ಹೇಳ್ತಾರೆ, ಸಂತೋಷ ಮತ್ತು ಆನಂದದಿಂದ ಕೂಡಿದ ಜೀವನ ಜ್ಞಾನ ಮತ್ತು ವಿಜ್ಞಾನದ ಆಧಾರದ ಮೇಲಿದೆ ಅಂತ. ಈ ನುಡಿಮುತ್ತುಗಳು 100ಕ್ಕೆ 100 ಪಾಲು ಸತ್ಯ ಅಂತ ಈ ಸಂದರ್ಭದಲ್ಲಿ ಹೇಳೋದಕ್ಕೆ ಇಚ್ಛೆಪಡ್ತೇನೆ. ಶಿಕ್ಷಕರು ನಮ್ಮ ಜೀವನದ ದಾರಿ ತೋರಿಸುವ ದೀಪಸ್ತಂಭ. ವೈದ್ಯಕೀಯ ಕ್ಷೇತ್ರದಲ್ಲಿಯೂ ಶಿಕ್ಷಕರ ಪಾತ್ರ ಅತ್ಯಂತ ಮಹತ್ವದ್ದು. ಪ್ರತಿಯೊಬ್ಬ ವೈದ್ಯನು ವಿದ್ಯಾರ್ಥಿ ಆಗಿದ್ದಾಗಲಿಂದ ತಮ್ಮ ಗುರುಗಳಿಂದ ತಿಳಿದುಕೊಂಡು ಜ್ಞಾನದಿಂದ ಸಮಾಜಕ್ಕೆ ಸೇವೆ ಮಾಡುತ್ತೆ. ಇಂದಿನ ಸಮಾರಂಭದ ಅತಿಥಿಗಳು, ಈ ಕಾರ್ಯಕ್ರಮವನ್ನು ಉದ್ಘಾಟಿಸಲು ಆಗಮಿಸಿರುವ ಡಾಕ್ಟರ್ ಬಸವರಾಜ ಸ್ವಾಮೀಜಿಯವರಿಗೆ ಹಾರ್ದಿಕವಾದ ಸ್ವಾಗತ ಮತ್ತು ಧನ್ಯವಾದಗಳು. ಅದೇ ರೀತಿ ಇಂದಿನ ಮುಖ್ಯ ಅತಿಥಿ, ಸದಾ ನಮ್ಮ ವೈದ್ಯ ಸಮುದಾಯದ ಸಮಸ್ಯೆಗಳಿಗೆ ಧ್ವನಿ ನೀಡಿರುವಂತಹ ಡಾಕ್ಟರ್ NT ಶ್ರೀನಿವಾಸ್ ಅವ್ರು ಗೊತ್ತಿದೆ ಯಾವ ರೀತಿಯಲ್ಲಿ ಇತ್ತೀಚೆಗೆ ಫೈರ್ NOC ಬಗ್ಗೆ ಹೋರಾಟ ಮಾಡ್ತಿದ್ದಾರೆ ನಮ್ಮ ಪರವಾಗಿ ಅಂತ. ಅವ್ರಿಗೆ ಹೃತ್ಪೂರ್ವಕ ಸುಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೇನೆ. ಅದೇ ರೀತಿ ನಮ್ಮ ವಿಶೇಷ ಅತಿಥಿಯಾಗಿ ನಮ್ಮೊಂದಿಗೆ ಇರುವ ಬಸವೇಶ್ವರ ಮೆಡಿಕಲ್ ಕಾಲೇಜಿನ ಮಾಜಿ ಪ್ರಾಂಶುಪಾಲರು ಮತ್ತು ಡೀನ್ ಆಗಿರುವಂತಹ ಡಾಕ್ಟರ್ ಮಹೇಶ್ ಅವರು ಕೂಡ ನಾನು ಆರ್ಥಿಕ ಸುಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೇನೆ. ಅದೇ ರೀತಿ ಈ ಸಮಾರಂಭವನ್ನು ಅಧ್ಯಕ್ಷತೆ ವಹಿಸಿರುವ ನಮ್ಮ ರಾಜ್ಯದ IMA ನಮ್ಮೆಲ್ಲರ ನೆಚ್ಚಿನ ಅಧ್ಯಕ್ಷರಾಗಿರುವಂತಹ ಡಾಕ್ಟರ್ VV ಚಿನಿವಾಲರವರು ಕೂಡ ನಾನು ಮನದಾಳದ ಸುಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೇನೆ. ನಮ್ಮ ಪಾಸ್ಟ್ ಪ್ರೆಸಿಡೆಂಟ್ ಡಾಕ್ಟರ್ ಶ್ರೀನಿವಾಸ್ ಅವರು ಕೂಡ ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ನಾನು ಹೃತ್ಪೂರ್ವಕ ಸುಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೇನೆ. ಅದೇ ರೀತಿ ಪ್ರೆಸಿಡೆಂಟ್ ಎಲೆಕ್ಟ್ ಆಗಿರುವಂತಹ ಡಾಕ್ಟರ್ ವೀರಭದ್ರಯ್ಯ ಅವರಿಗೆ ಕೂಡ ನಾನು ಈ ಶುಭ ಸಂದರ್ಭದಲ್ಲಿ ಸುಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೇನೆ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ಸ್ಟೇಟ್ ಬ್ರಾಂಚ್ ಖಜಾಂಚಿಗಳಾಗಿರುವಂತಹ ಡಾಕ್ಟರ್ ಶಂಕರ್ ನಾರಾಯಣ್ ಅವರನ್ನು ಕೂಡ ಈ ಸಂದರ್ಭದಲ್ಲಿ ಸುಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೇನೆ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಚಿತ್ರದುರ್ಗ ಬ್ರಾಂಚಿನ ಅಧ್ಯಕ್ಷರಾಗಿರುವಂತಹ ಡಾಕ್ಟರ್ ಪಾಲಾಕ್ಷಿ ಅವರನ್ನು ಕೂಡ ಈ ಸಂದರ್ಭದಲ್ಲಿ ಶುಭ ಸಂದರ್ಭದಲ್ಲಿ ಸುಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೀನಿ. ಅದೇ ರೀತಿ ಡಾಕ್ಟರ್ ಪ್ರಹ್ಲಾದ್ ಅವ್ರನ್ನು ಕೂಡ ನಾನು ಸುಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೀನಿ. ನಿಮ್ಮೆಲ್ಲರ ನೆಚ್ಚಿನ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ನ್ಯಾಷನಲ್ ವೈಸ್ ಪ್ರೆಸಿಡೆಂಟ್ ಆಗಿರುವಂತಹ ಡಾಕ್ಟರ್ ಬಿಡಿನಾಲ್ ಸಾಹೇಬ್ರಿಗೆ ಅವರು ಕೂಡ ನಾನು ಈ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಸುಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೇನೆ. ನನ್ನ ಸ್ನೇಹಿತರು AMS ಚೇರ್ಮನ್ ಆಗಿರುವಂತಹ ಡಾಕ್ಟರ್ ನಾರಾಯಣ್ ಸ್ವಾಮಿ ಅವ್ರಿಗೆ ಅವರು ಕೂಡ ಸುಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೀನಿ. ಡಾಕ್ಟರ್ ಮುಲ್ಕಿ ಪಾಟೀಲ್ ಅವ್ರಿಗೆ ಕೂಡ ಸುಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೀನಿ. ಪಾಸ್ಟ್ ಪ್ರೆಸಿಡೆಂಟ್ IMA ಕರ್ನಾಟಕ ಸ್ಟೇಟ್ ಬ್ರಾಂಚ್ ಮತ್ತು AMS ಚೇರ್ಮನ್ ಆಗಿರುವಂಥ ನ್ಯಾಷನಲ್ ಚೇರ್ಮನ್ ಆಗಿರುವಂತಹ ಡಾಕ್ಟರ್ ಸಡನ್ ಮಾಡ್ತಾ ಇತ್ತು ಒಂದು ನಿಮಿಷ ಆಯ್ತು. ಡಾಕ್ಟರ್ ವೆಂಕಟಾಚಲಪತಿ ಅವರಿಗೆ ನಾನು ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಸುಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೀನಿ. ಅದೇ ರೀತಿ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ವೈಸ್ ಪ್ರೆಸಿಡೆಂಟ್ ಡಾಕ್ಟರ್ ಮಳವೇಗೌಡ ಅವರಿಗೆ, ಡಾಕ್ಟರ್ ಮರಿಗೌಡ ಅವರಿಗೆ ಕೂಡ ನಾನು ಸುಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೀನಿ. ಡಾಕ್ಟರ್ ನೇಕಾರ್ ಅವರು ಕೂಡ ನಾನು ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಸುಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೀನಿ. ಮತ್ತು ಡಾಕ್ಟರ್ ಮೇಘಾ ಅವರಿಗೆ ಕೂಡ. ಅದೇ ರೀತಿ ಈ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಗೌರವಿತ ಶಿಕ್ಷಕರಾದ ನಿಮ್ಮೆಲ್ಲರ ಈ ಶಿಕ್ಷಕರ ದಿನಾಚರಣೆಯ ಅವಾರ್ಡ್ ಗೆದ್ದಿರುವಂತಹ ಪ್ರತಿಯೊಬ್ಬರಿಗೂ ಕೂಡ ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಸುಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೀನಿ. ತಮಗೆ ಅಭಿನಂದನೆಗಳು ಕೂಡ. ವೈದ್ಯಕೀಯ ಕ್ಷೇತ್ರದಲ್ಲಿ ಶಿಕ್ಷಕರ ಸೇವೆ ಅಮೂಲ್ಯವಾದದ್ದು. ವಿದ್ಯಾರ್ಥಿಗಳಿಗೆ ಜ್ಞಾನ ಶಿಸ್ತಿನೊಂದಿಗೆ ಮೌಲ್ಯಗಳನ್ನು ಬಿತ್ತುವ ಗುರುಗಳ ತ್ಯಾಗವನ್ನು ನಾವೆಲ್ಲರೂ ಗೌರವದಿಂದ ನೆನಪಿಸಿಕೊಳ್ಳೋಣ. ನಿಮ್ಮ ಸಾಧನೆ ಸರ್ ನಮ್ಮೆಲ್ಲರಿಗೂ ಬಹಳ ಹೆಮ್ಮೆ ತರುವಂಥದ್ದು. ಇದಲ್ಲದೆ ಈ ಕಾರ್ಯಕ್ರಮವನ್ನು ಯಶಸ್ವಿಯಾಗಿ ಆಯೋಜಿಸಿರುವ ಚಿತ್ರದುರ್ಗ ಶಾಖೆಯ ಅಧ್ಯಕ್ಷರು, ಕಾರ್ಯದರ್ಶಿಗಳು ಮತ್ತು ಎಲ್ಲ ಸಹೋದ್ಯೋಗಿಗಳಿಗೂ ಅಭಿನಂದನೆಗಳನ್ನು ತಿಳಿಸುತ್ತಾ ನಾನು ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಸುಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ, ಶಿಕ್ಷಕರ ಮಹತ್ವ, ಗುರು ಅಂದರೆ ಕೇವಲ ಪಾಠ ಹೇಳುವವರಲ್ಲ, ಗುರು ಅಂದರೆ ಜೀವನ ಮೌಲ್ಯಗಳನ್ನು ಬೋಧಿಸುವವರು. ವೈದ್ಯಕೀಯದಲ್ಲಿ ಗುರುಗಳು ವಿದ್ಯಾರ್ಥಿಗಳಿಗೆ ಕೇವಲ ವೈದ್ಯಕೀಯ ಜ್ಞಾನವನ್ನಷ್ಟೇ ನೀಡುವುದಿಲ್ಲ, ಸಹಾನುಭೂತಿ, ಮಾನವೀಯತೆ ಮತ್ತು ಸೇವಾ ಭಾವನೆಯನ್ನು ಕೂಡ ಬೆಳೆಸುತ್ತಾರೆ. ಇಂದು ನಾವೆಲ್ಲರೂ ನಮ್ಮ ವೈದ್ಯಕೀಯ ಗುರುಗಳನ್ನು ನೆನೆಸಿ ಅವರಿಗೆ ಕೃತಜ್ಞತೆ ಸಲ್ಲಿಸುವ ದಿನ. ಈ ಉತ್ಸವದ ಮೂಲಕ ನಾವು ಗುರುಗಳಿಗೆ ಗೌರವ ಸಲ್ಲಿಸಿ ಅವರ ಆಶೀರ್ವಾದದೊಂದಿಗೆ ಮುಂದೆ ಇನ್ನಷ್ಟು ಉತ್ತಮ ಸೇವೆ ಮಾಡೋಣ ಅಂಥೇಳಿ ಪ್ರತಿಜ್ಞೆ ಮಾಡೋಣ. ಮತ್ತೊಮ್ಮೆ ಎಲ್ಲ ಅತಿಥಿಗಳಿಗೆ, ಸಹೋದ್ಯೋಗಿಗಳಿಗೆ ಹಾಗೂ ಈ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಭಾಗವಹಿಸಿರುವ ಪ್ರತಿಯೊಬ್ಬರಿಗೂ ಕೂಡ ಹೃತ್ಪೂರ್ವಕ ಸುಸ್ವಾಗತವನ್ನು ಕೋರ್ತಿದ್ದೀನಿ. ಜೈ ಹಿಂದ್, ಜೈ ಭಾರತಾಂಬೆ, ಜೈ IMA. ವಂದನೆಗಳು.
Thank you so much, sir. Now it is time to mark the formal commencement of this meaningful celebration. As a gesture of respect to nature, we request Shri Basavaprabhu Swamiji to inaugurate this Teachers' Day celebration by watering a plant. We also invite all the dignitaries on the stage to kindly join hands in this symbolic act.
ಒಂದು ಸಸ್ಯವು ಮರವಾಗಲು ಹೇಗೆ ಪೋಷಣೆ ಮತ್ತು ನೀರು ಬೇಕು, ಹಾಗೆಯೇ ನಮ್ಮ ಶಿಕ್ಷಕರು ನಮ್ಮನ್ನು ಜ್ಞಾನದಿಂದ ಪೋಷಿಸಿ ಉತ್ತಮ ನಾಗರಿಕರನ್ನಾಗಿ ರೂಪಿಸ್ತಾರೆ.
Watering this plant symbolizes not only our reverence for teachers but also our commitment to preserving nature and honoring the world that sustains us. Heartfelt thanks to everybody. Thank you to all the dignitaries. We now request Shri Basavaprabhu Swamiji, who inaugurated today's celebration, to deliver the inaugural address. Please welcome him with a round of applause.
ಶ್ರೀ ಗುರು ಬಸವಲಿಂಗಾಯ ನಮಃ. ಸ್ಮರಣೀಯರಾಗಿರುವಂಥ ವಿಶ್ವಗುರು ಬಸವಣ್ಣನವರನ್ನು ಸ್ಮರಣೆ ಮಾಡಿಕೊಳ್ಳುತ್ತಾ ಮಹಾ ಜಂಗಮ ಜ್ಯೋತಿಗಳಾದ ಕರ್ತು ಮುರುಗೇಶ್ವರ ಪಾದಕ್ಕೆ ನಮಸ್ಕರಿಸುತ್ತಾ, ಅರಿವಿನ ಗುರುಗಳಾದ ಮುರುಘಾಶರಣರ ಪಾದಕ್ಕೆ ನಮಸ್ಕರಿಸುತ್ತಾ, ನಮ್ಮ ಬಸವೇಶ್ವರ ವೈದ್ಯಕೀಯ ಮಹಾವಿದ್ಯಾಲಯದಲ್ಲಿ ಇವತ್ತು ಶಿಕ್ಷಕರ ದಿನಾಚರಣೆ ವಿಶೇಷ ಕಾರ್ಯಕ್ರಮವನ್ನು ಇಲ್ಲಿ ಹಮ್ಮಿಕೊಳ್ಳಲಾಗಿದೆ. ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಪಾಲ್ಗೊಂಡಿರುವಂತಹ ವೈದ್ಯರಾಗಿರುವಂಥ ಡಾಕ್ಟರ್ ಶ್ರೀನಿವಾಸ್ ಅವರು, ಶಾಸಕರು ಕೂಡ್ಲಿಗಿ ಅವರಲ್ಲಿಯೂ, ಹಾಗೂ ಅಧ್ಯಕ್ಷತೆಯನ್ನು ವಹಿಸಿರುವಂತಹ ಚಿನಿವಳ್ಳರವರು ಮತ್ತು ವೇದಿಕೆಯಲ್ಲಿರುವಂತಹ ಎಡಭಾಗದಲ್ಲಿರುವಂಥ ಎಲ್ಲ ಗಣ್ಯರು, ಬಲಭಾಗದಲ್ಲಿರುವಂಥ ಎಲ್ಲ ಗಣ್ಯರು, ಮುಖ್ಯವಾಗಿ ಪಾಲ್ಗೊಂಡಿರುವಂತಹ ಎಲ್ಲ ಶರಣರು, ಶರಣೆಯರು, ವಿದ್ಯಾರ್ಥಿಗಳು, ನಿಮ್ಮೆಲ್ಲರಿಗೂ ಶರಣು ಶರಣಾರ್ಥಿಗಳು. ಗುರು ಅಂತಂದರೆ ಅವರು ಒಬ್ಬ ಸೂರ್ಯನಿದ್ದ ಹಾಗೆ ಶಿಷ್ಯನಲ್ಲಿರುವಂತಹ ಅಜ್ಞಾನದ ಕತ್ತಲನ್ನು ಹೊಡೆದೋಡಿಸಿ ಜ್ಞಾನದ ಬೆಳಕನ್ನು ಮೂಡಿಸುತ್ತಾನೆ. ತನ್ನಲ್ಲಿರುವಂತಹ ವಿದ್ಯೆಯನ್ನು ಸಂಪೂರ್ಣವಾಗಿ ಶಿಷ್ಯನಿಗೆ ನೀಡುತ್ತಾನೆ. ಈಗ ನಾವು ಸಸಿಗೆ ನೀರು ಎರೆಯೋದ್ರ ಮುಖಾಂತರ ಈ ಸಮಾರಂಭವನ್ನು ಉದ್ಘಾಟನೆ ಮಾಡಿದ್ವಿ. ವಿದ್ಯಾರ್ಥಿಗಳ ಮನಸ್ಸು ಅನ್ನುವಂತಹದ್ದು ಅದು ಒಂದು ಹದವಾದ ಭೂಮಿ ಇದ್ದ ಹಾಗೆ. ಆ ಭೂಮಿಯಲ್ಲಿ ನಾವು ಏನನ್ನು ಬಿತ್ತುತ್ತೇವೋ ಅದು ಮುಂದೆ ಫಲವನ್ನು ಕೊಡುತ್ತೆ. ಅದಕ್ಕೆ ಕಾಲಕ್ಕೆ ತಕ್ಕಂಗೆ ಗೊಬ್ಬರ ನೀರನ್ನು ಹಾಕಬೇಕು, ಅದನ್ನು ಪೋಷಣೆ ಮಾಡಬೇಕು. ಹಾಗೆ ವಿದ್ಯಾರ್ಥಿಗಳನ್ನು ಸಸಿ ಥರ ಪೋಷಣೆ ಮಾಡಿ ಹೆಮ್ಮರವಾಗಿ ಬೆಳೆಸುವಂತಹ ಶಕ್ತಿ ಯಾರಲ್ಲಿದೆ ಅಂತಂದರೆ ಅದು ಒಬ್ಬ ಶ್ರೇಷ್ಠ ಶಿಕ್ಷಕನಲ್ಲಿದೆ, ಒಬ್ಬ ಗುರುವಿನಲ್ಲಿದೆ ಅನ್ನುವಂತಹದ್ದು. ಹಾಗಾಗಿ ಒಬ್ಬ ಗುರು ಮನಸ್ಸು ಮಾಡಿದರೆ ಏನು ಬೇಕಾದರೂ ನಾವು ತಯಾರಾಗಲಿಕ್ಕೆ ಸಾಧ್ಯ ಆಗತ್ತೆ. ನೀವೆಲ್ಲರೂ ಇಲ್ಲಿ ಡಾಕ್ಟರ್ಸ್ ಇದ್ದೀರಿ, ವೈದ್ಯಕೀಯ ವಿದ್ಯಾರ್ಥಿಗಳಿದ್ದೀರಿ. ಬಹಳ ಮುಖ್ಯವಾಗಿ ನಿಮ್ಮ ಬದುಕಿನಲ್ಲಿನೂ ಗುರು ಅನ್ನುವಂತಹ ಒಬ್ಬ ಶಿಕ್ಷಕ ಅನ್ನುವಂಥವ್ರು ಬಂದು ನಿಮಗೆ ಪ್ರೇರಣೆ ಮಾಡಿದ್ರಿಂದ ನೀವೆಲ್ಲರೂ MBBS ಸೇರಿದ್ದೀರಿ. ನೋಡು, ನೀನು ಚೆನ್ನಾಗಿ ಓದ್ತಾ ಇದೀಯಾ, ನೀನು ಡಾಕ್ಟ್ರ್ ಆಗಬೇಕು. ಮೊದಲ ಗುರು ಯಾರು ಅಂದರೆ ತಾಯಿ, ಮದರ್. ನೀನು ಚೆನ್ನಾಗಿ ಓದ್ತಿದೀಯಾ, ಡಾಕ್ಟ್ರ್ ಆಗು ಅಂತ ಹೇಳಿರು. ಸೆಕೆಂಡ್ ನಿಮ್ಮ ಫಾದರ್, ಆಮೇಲೆ ನಿಮ್ಮ ಪ್ರೌಢಶಾಲೆ ಮೇಷ್ಟ್ರು, ವಿದ್ಯಾರ್ಥಿ ಜೀವನದಲ್ಲಿ ಪ್ರಾಥಮಿಕ ಮೇಷ್ಟ್ರು, ನೀನು ಚೆನ್ನಾಗಿ ಓದ್ತಿದೀಯಾ, ನೀನು ಡಾಕ್ಟ್ರ್ ಆಗ್ಬೋದಾ ಅಂತಂದು ನಿಮಗೆ ಸ್ಫೂರ್ತಿಯನ್ನು ತುಂಬ್ತಾರೆ. ನಿಮ್ಮ ಬದುಕಿಗೆ ಒಂದು ಮಾರ್ಗದರ್ಶನವನ್ನು ಮಾಡ್ತಾರೆ, ಗುರಿಯನ್ನು ಮುಟ್ಟಿಸ್ತಾರೆ. ಅದಕ್ಕೋಸ್ಕರನೇ ಶಿಕ್ಷಕ ಅನ್ನುವಂಥವನು ದೊಡ್ಡವನಾಗ್ತಾನೆ ಅನ್ನುವಂಥದ್ದು. ಅಲೆಕ್ಸಾಂಡರು, ಅರಿಸ್ಟಾಟಲು ಇವ್ರ ಬಗ್ಗೆ ನೀವೆಲ್ಲ ಕೇಳಿದ್ದೀರಿ. ಅರಿಸ್ಟಾಟಲ್ ಒಬ್ಬ ಮಹಾಗುರು. ಅವರು ಶಿಷ್ಯ ಅಲೆಕ್ಸಾಂಡರ್. ಆಗ ಅವ್ರ ಬಗ್ಗೆ ಒಂದು ಮಾತನ್ನು ಹೇಳ್ತಾರೆ ಅಲೆಕ್ಸಾಂಡರ್ ಅವರು. ಗುರು ಏನು ಮಾಡ್ತಾನೆ ನನ್ನ ಬದುಕಿನಲ್ಲಿ ಎನ್ನುವಂತಹದ್ದು. ನಾನು ಮೇಲಿದ್ದೆ, ಪರಮಾತ್ಮನ ಜೊತೆಗಿದ್ದೆ. ತಂದೆ ತಾಯಿಯವರು ನನ್ನನ್ನು ಈ ಭೂಮಿಗೆ ಕರ್ಕೊಂಡ್ಬಂದರು. ಗುರು ಏನು ಮಾಡಿದ ಅಂತಂದರೆ, ನಾನು ಭೂಮಿಗೆ ಬಂದ ನಂತರ ಮತ್ತೆ ಆಕಾಶದಷ್ಟು ಎತ್ತರಕ್ಕೆ ಬೆಳೆಸಿದಂಥ ಒಬ್ಬ ಮಹಾನ್ ವ್ಯಕ್ತಿ ನನ್ನ ಬದುಕಿನಲ್ಲಿ ಬಂದಿದ್ದಾರೆ ಅಂದರೆ ಅದು ಗುರು ಅನ್ನುವಂತಹ ಮಾತನ್ನು ಹೇಳ್ತಾರೆ, ಶಿಕ್ಷಕ ಅನ್ನುವಂತಹ ಮಾತನ್ನು ಹೇಳ್ತಾರೆ. ಅಂದರೆ ನಮ್ಮ ಸಾಧನೆ ಆಕಾಶದಷ್ಟು ಬೆಳೀಲಿಕ್ಕೆ ಸಾಧ್ಯ ಆಗತ್ತೆ. ನೀನು ವಿಶೇಷ ವ್ಯಕ್ತಿ ಇದೆಯಾ, ನೀನು ಒಬ್ಬ ವಿಶೇಷ ಸಾಧಕನಾಗ್ತೀಯಾ, ನೀನು ಗುರಿ ಮುಟ್ತೀಯಾ, ನೀನು ಡಾಕ್ಟರ್ ಆಗ್ಬೋದು, ನೀನು ಏನು ಬೇಕಾದ್ರೂ ಮನಸ್ಸು ಮಾಡಿದರೆ ಆಗಲಿಕ್ಕೆ ಸಾಧ್ಯ ಇದೆ ಎನ್ನುವಂತಹ ಒಂದು ಆತ್ಮವಿಶ್ವಾಸವನ್ನು ನಮ್ಮ ಒಳಗೆ ತುಂಬೋರು ಯಾರಪ್ಪ ಅಂತಂದರೆ ಗುರು ಅನ್ನುವಂತಹದ್ದು, ಶಿಕ್ಷಕ ಅನ್ನುವಂತಹದ್ದು. ತಾಯಿ ನಮ್ಮನ್ನು ಭೂಮಿಗೆ ಕರ್ಕೊಂಡ್ಬಂದರೆ ಈ ಭೂಮಿಯಿಂದ ಆಕಾಶದಷ್ಟು ಎತ್ತರಕ್ಕೆ ಬೆಳೆಸುವಂತಹ ಶಕ್ತಿ ಯಾರಲ್ಲಿದೆ ಅಂತಂದರೆ ಶಿಕ್ಷಕನಲ್ಲಿದೆ ಅನ್ನುವಂತಹದ್ದು. ಇವತ್ತು ನಾವು ನಮ್ಮ ಒಂದು ಒಳ್ಳೆಯ ಹಂತಕ್ಕೆ ಬಂದಿದ್ದೀವಿ ಅಂತಂದರೆ ಅದಕ್ಕೆ ಪ್ರಮುಖ ಕಾರಣ ತಂದೆ ತಾಯಿಯ ಪರಿಶ್ರಮ, ಅವರ ತ್ಯಾಗ, ಗುರುವಿನ ಮಾರ್ಗದರ್ಶನ ಅನ್ನುವಂತಹದ್ದು. ಹಾಗಾಗಿ ಪ್ರತಿಯೊಬ್ಬರು ಗುರುವಿನ ಒಂದು ಮಾರ್ಗದರ್ಶನವನ್ನು ಪಡ್ಕೊಂಡು ಜೀವನದಲ್ಲಿ ನಾವು ಗುರಿಯನ್ನು ಇಟ್ಕೋಬೇಕು. ಅದಕ್ಕೆ ಕುವೆಂಪು ಅವರು ಹೇಳ್ತಾರೆ ಏನಂತಂದರೆ, ಮುಂದೆ ಗುರಿ ಇರಬೇಕು, ಹಿಂದೆ ಗುರು ಇರಬೇಕು, ಅಂದರೆ ನಾವು ಗುರಿ ಮುಡ್ತೇವೆ. ಹಿಂದೆ ಗುರುನೂ ಇಲ್ಲ ಅಂದರೆ ಮುಂದೆ ಗುರಿನೇ ಇರೋದಿಲ್ಲ. ಹಾಗಾಗಿನೇ ಭಾಳಷ್ಟು ಜನ ಇವತ್ತು ಅತಂತ್ರರಾಗಿ ಜೀವನವನ್ನು ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಇತ್ತಾಗ ಸರಿಯಾಗಿ ಓದೂ ಇಲ್ಲ, ಇತ್ತಾಗೆ ಒಂದು ಒಳ್ಳೆಯ ನೌಕರಿನೂ ಇಲ್ಲ, ಕೂಲಿ ಅಥವಾ ಕೂಲಿ ಕಾರ್ಮಿಕರಾಗಿ ಕೆಲಸವನ್ನು ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಅದಕ್ಕೆ ಬದುಕಿಗೆ ಒಂದು ಸ್ಪಷ್ಟತೆ ಬೇಕು, ಸ್ಪಷ್ಟವಾದ ಗುರಿ ಬೇಕು. ಗುರಿಯನ್ನು, ದಿಕ್ಸೂಚಿಯನ್ನು ನಮ್ಮ ಜೀವನದ ಶಿಲ್ಪಿ ನೋಡಪ್ಪ ನೀನು ಹೀಗಾಗ್ತೀಯಾ, ನಿನ್ನಲ್ಲಿ ಇಂಥ ಒಂದು ಒಳ್ಳೆ ಪ್ರತಿಭೆ ಇದೆ, ನೀನು ಮನಸ್ಸು ಮಾಡಿ ಇದನ್ನು ಕಲಿತೆ ಅಂದರೆ ನೀನು ಡಾಕ್ಟರ್ ಆಗ್ತೀಯಾ, ಇಂಜಿನಿಯರ್ ಆಗ್ತೀಯಾ, ವಿಜ್ಞಾನಿ ಆಗ್ತೀಯಾ, ತತ್ವಜ್ಞಾನಿ ಆಗ್ತೀಯಾ, ಒಬ್ಬ ಶ್ರೇಷ್ಠ ಗುರು ಆಗ್ತೀಯಾ. ಈ ರೀತಿಯಾಗಿ ನಮ್ಮೊಳಗಿರುವಂತಹ ಪ್ರತಿಭೆಯನ್ನು ಹೊಕ್ಕಿ ತೆರೆಯೋರು ಯಾರಪ್ಪ ಅಂತಂದರೆ ಗುರು ಅನ್ನುವಂಥದ್ದು. ಹಾಗಾಗಿನೇ ನಾವು ಗುರುವಿನ ಬಳಿ ಬಂದ್ವಿ ಅಂತಂದರೆ ಈ ಬದುಕಿಗೆ ಒಂದು ಸಾರ್ಥಕತೆ ಬರುತ್ತೆ. ಅದಕ್ಕೆ ಬಸವಣ್ಣವ್ರು ಹೇಳಿದರು, ಮಡಕೆಯ ಮಾಡುವರೆ ಮಣ್ಣೆ ಮೊದಲು, ತೊಡಗೆಯ ಮಾಡುವರೆ ಹೊನ್ನೆ ಮೊದಲು, ಶಿವಪಥವ ನರಿವಡೆ ಗುರುಪಥವೇ ಮೊದಲು ಅಂತಂದ್ರು. ಅಂದರೆ ಪರಮಾತ್ಮನನ್ನು ಅರ್ಥ ಮಾಡ್ಕೋಬೇಕಂದ್ರೆ ಗುರುಗಳ ಬಳಿ ಹೋಗ್ಬೇಕು ಅಂತ. ಇಲ್ಲಿ ನಾವು ಸ್ವಲ್ಪ ಅದನ್ನು ಅರ್ಥ ಮಾಡ್ಕೋಬೋದು. ನಾವೇನಾದರೂ ಒಂದು ಜೀವನದಲ್ಲಿ ಒಂದು ಗುರಿಯನ್ನು ಮುಟ್ಟಬೇಕಾದ್ರೆ ಯಾರ ಬಳಿ ಬರಬೇಕು ಅಂದರೆ ನಮಗೆ ಪಾಠ ಮಾಡಿರುವಂಥ ಒಬ್ಬ ಶಿಕ್ಷಕನ ಹತ್ರ ಬರಬೇಕು ನಾವು. ಹಾಗಾಗಿ ಶಿಕ್ಷಕರು ನಮ್ಮೊಳಗೆ ಏನಿದೆ ಅನ್ನೋದನ್ನು ಅವರು ಕಂಡು ಹಿಡಿತಾರೆ ಎನ್ನುವಂಥದ್ದು. ಯಾವ ರೀತಿಯಾಗಿ ಅಡುಗೆ ಮಾಡುವಂಥ ಸಂದರ್ಭದಲ್ಲಿ ತಾಯಿ ಅನ್ನಕ್ಕಿಡ್ತಾರೆ, ಅನ್ನ ಮುಟ್ಟಿ ನೋಡ್ತಾರೆ, ಅನ್ನ ಬೆಂದೈತೆ ಇಲ್ಲಿದು ಅಂಥೇಳಿ. ಅನ್ನ ಬೆಂದಿತ್ತಂದ್ರೆ ಎಲ್ಲರಿಗೂ ಊಟಕ್ಕೆ ನೀಡ್ತಾರೆ. ಹಾಗೆ ವಿದ್ಯಾರ್ಥಿಗಳ ಒಂದು ನಾಡಿ ಮಿಡಿತವನ್ನು ನೋಡು ನೀನು ಡಾಕ್ಟರ್ ಆಗ್ತೀಯಾ, ನೀನು ಇಂಜಿನಿಯರ್ ಆಗ್ತೀಯಾ, ಒಬ್ಬ ಲೆಕ್ಚರ್ ಆಗ್ತೀಯಾ, ಒಬ್ಬ DC ಆಗ್ತೀಯಾ, ಒಬ್ಬ ನಿನ್ನಲ್ಲಿ ಕಾನೂನು ವಿಚಾರ ಚೆನ್ನಾಗಿದೆ, ನೀನೊಬ್ಬ LLB ಆಗಿ ಕಾನೂನು ವಿದ್ಯಾರ್ಥಿ ಆಗಿ ಒಬ್ಬ ಒಳ್ಳೆಯ ವಕೀಲ ಆಗ್ಬೋದು, ಜಡ್ಜ್ ಆಗ್ಬೋದು. ನಿಮ್ಮನ್ನು ಕರೆಕ್ಟಾಗಿ ಅರ್ಥ ಮಾಡಿಕೊಂಡು ನಿಮಗೊಂದು ದಾರಿ ತೋರಿಸೋರು ಯಾರಪ್ಪ ಅಂತಂದರೆ, ನಮಗೆ ದಾರಿ ತೋರಿಸೋರು ಯಾರಪ್ಪ ಅಂದರೆ ಶಿಕ್ಷಕ ಅನ್ನುವಂತಹದ್ದು, ಗುರು ಅನ್ನುವಂತಹದ್ದು. ಹಾಗಾಗಿ ಆ ಶಿಕ್ಷಕ ಶಿವನ ಸ್ವರೂಪನಾಗಿ ಬರ್ತಾನೆ, ಒಬ್ಬ ವ್ಯಕ್ತಿಯಾಗಿ ಬರೋದಿಲ್ಲ. ಎಲ್ಲರೂ ಮೇಷ್ಟ್ರಿದ್ದಾರೆ, ಆದರೆ ನಾವು ಅವರನ್ನು ಯಾವ ರೀತಿಯಾಗಿ ನೋಡ್ಬೇಕಪ್ಪ ಅಂದರೆ ಪೂಜ್ಯ ಭಾವನೆಯಿಂದ ನೋಡ್ಬೇಕು. ನಾವು ವ್ಯಕ್ತಿಯಾಗಿ ನೋಡೋದ್ರಿಂದ ಅಲ್ಲಿ ನಮಗೆ ಜ್ಞಾನ ನಮ್ಮ ಒಳಗೆ ಬರಲಿಕ್ಕೆ ಸಾಧ್ಯ ಇಲ್ಲ. ನಮಗೆ ವಿದ್ಯೆ ಕಲಿಸುವಂಥ ಗುರುಗಳಂದರೆ ಅವರು ಒಬ್ಬ ದೇವರ ಸ್ವರೂಪವಾಗಿ ಬಂದು ನಮಗೆ ಪಾಠವನ್ನು ಹೇಳಿಕೊಡ್ತಾ ಇದ್ದಾರೆ, ತಂದೆಯ ಸ್ವರೂಪರಾಗಿ ಬಂದು ನಮಗೆ ಪಾಠವನ್ನು ಹೇಳಿಕೊಡ್ತಾ ಇದ್ದಾರೆ, ತಾಯಿಯ ಸ್ವರೂಪರವಾಗಿ ನಮ್ಮನ್ನು ರಕ್ಷಣೆ ಮಾಡ್ತಾ ಇದ್ದಾರೆ, ತಂದೆಯಂತೆ ನಮಗೆ ಬುದ್ಧಿಯನ್ನು ಕಲಿಸ್ತಾ ಇದ್ದಾರೆ ಎನ್ನುವಂತಹ ಭಾವನೆಯನ್ನು ನಾವು ಶಿಷ್ಯರಾದವರು, ವಿದ್ಯಾರ್ಥಿಗಳಾದವರು ನಾವು ಬೆಳೆಸ್ಕೊಳ್ಬೇಕು. ಹಾಗಾಗಿ ಇವತ್ತು ಏನಾಗ್ತಾ ಇದೆ ಸಮಾಜದಲ್ಲಿ ಅಂತಂದರೆ ಗುರು ಬ್ರಹ್ಮ ಗುರು ವಿಷ್ಣು ಅಂತ ಕೊನೆಗೆ ಅದೇನಿದೆ, ಗುರುವೇ ನಮೋ ನಮಃ ಅನ್ನುವಂತಹ ಮಂತ್ರದಲ್ಲಿ ಇದೆ. ಆದರೆ ಇವತ್ತು ಎಷ್ಟೋ ಜನ ವಿದ್ಯಾರ್ಥಿಗಳಿಗೆ ಗುರುವೇನ್ ಮಹಾ ಅನ್ನುವಂತಹ ವಿದ್ಯಾರ್ಥಿಗಳು ಸೃಷ್ಟಿಯಾಗ್ಬಿಟ್ಟಿದ್ದಾರೆ. ಹಾಗಾಗಿನೇ ವಿದ್ಯಾರ್ಥಿಗಳಲ್ಲಿ ಸಂಸ್ಕಾರದ ಕೊರತೆ ಆಗ್ತಾ ಇದೆ. ಸಂಸ್ಕೃತಿಯನ್ನು ಕಲಿಸಿಕೊಡಬೇಕಾಗಿದೆ. ಒಳ್ಳೆಯ ಸಂಸ್ಕಾರ, ಗುರುವಿಗೆ ನಮನ ಸಲ್ಲಿಸುವಂತಹದ್ದು, ತಂದೆ ತಾಯಿಗಳಿಗೆ ಗೌರವವನ್ನು ಕೊಡುವಂತಹದ್ದು, ಸ್ನೇಹ ಪ್ರೀತಿಗೆ ಗೌರವಗಳನ್ನು ನೀಡುವಂತಹದ್ದು, ಎಲ್ಲರನ್ನೂ ಪ್ರೀತಿಯಿಂದ ಕಾಣುವಂತಹದ್ದು, ಇಂತಹ ಒಳ್ಳೆಯ ಸಂಸ್ಕಾರವನ್ನು, ಒಳ್ಳೆಯ ವ್ಯಕ್ತಿಗಳನ್ನು ನಿರ್ಮಾಣ ಮಾಡೋರು ಯಾರಪ್ಪ ಅಂತಂದರೆ ಶಿಕ್ಷಕ ಅನ್ನುವಂತಹದ್ದು, ಅರ್ಥಾತ್ ಗುರು ಅನ್ನುವಂತಹದ್ದು. ಅಂತಹ ಗುರುವಿನ ಸ್ಮರಣೆಯನ್ನು ನಾವು ನೀವೆಲ್ಲರೂ ಇಲ್ಲಿ ಮಾಡ್ತಾ ಇದ್ದೀವಿ. ಈ ಒಂದು ಶಿಕ್ಷಕರ ದಿನಾಚರಣೆ ನಮಗೆಲ್ಲರಿಗೂ ಒಂದು ಪ್ರೇರಣೆಯನ್ನು ತುಂಬಲಿ. ಅವರು ಶಿವನ ಸ್ವರೂಪರಾಗಿ ನಮಗೆ ಹೇಳ್ತಾರೆ ಅಂತ. ಅಂದರೆ ಕ್ಷಮಾದಾನ ಮಾಡ್ತಾರೆ. ಏನಾರ ತಪ್ಪಾದರೆ ನಮಗೆ ಬುದ್ಧಿಯನ್ನು ತಿಳಿಸಿ, ನೋಡಪ್ಪ ನೀನು ಹಿಂಗೆ ಮಾಡಿದೀಯಾ, ನೀನು ಚೆನ್ನಾಗಿ ಓದಿಕೋ, ತಿಳುವಳಿಕೆಯನ್ನು ನೀಡಿ ಆ ತಪ್ಪಿಗೆ ಕ್ಷಮೆಯನ್ನು ನೀಡ್ತಾರೆ. ಶಿವನ ಸ್ವರೂಪರಾಗಿ ಕ್ಷಮೆಯನ್ನು ನೀಡಿ ಕಲಿಸುವಂತಹ ವ್ಯಕ್ತಿನೇ ಶಿಕ್ಷಕ, ಟೀಚರ್, ಗುರು ಅನ್ನುವಂತಹ ಮಾತನ್ನು ಹೇಳ್ತಾ ಇಂಥ ಒಂದು ಒಳ್ಳೆಯ ಕಾರ್ಯಕ್ರಮ ಇಲ್ಲಿ ಆಯೋಜನೆಗೊಂಡಿರೋದು ತುಂಬ ಸಂತೋಷವನ್ನು ತಂದಿದೆ. ಅದೇ ರೀತಿಯಾಗಿ 14 ಜನರನ್ನು ಇಲ್ಲಿ ಶಿಕ್ಷಕ ವೃತ್ತಿಯಲ್ಲಿ ಅಪಾರವಾದಂತಹ ಸೇವೆಯನ್ನು ಸಲ್ಲಿಸಿ ವೈದ್ಯರುಗಳಿಗೆ, ಟೀಚರ್ಸ್ಗಳಿಗೆ, ಡಾಕ್ಟರ್ಸ್ಗಳಿಗೆ ಇಲ್ಲಿ ಒಂದು ಅಭಿನಂದನೆಯೂ ನಡೀತಾ ಇದೆ. ಬಹಳ ಒಂದು ಅರ್ಥಪೂರ್ಣವಾದಂತಹ ಕಾರ್ಯಕ್ರಮವನ್ನು ಆಯೋಜನೆ ಮಾಡಿದಿರಿ. ನಿಮ್ಮೆಲ್ಲರಿಗೂ ಒಳ್ಳೆಯದಾಗಲಿ, ಶುಭವಾಗಲಿ. ಮುಂದೆ ನೀವು ಒಳ್ಳೆಯ ಡಾಕ್ಟರ್ಸ್ ಆಗಿ ಹೊರಹೊಮ್ಮಿ ಸಮಾಜ ಸೇವೆಯನ್ನು ಮಾಡಿರಿ, ದೇಶ ಸೇವೆಯನ್ನು ಮಾಡಿರಿ. ನಿಮ್ಮ ಸೇವೆಯೂ ಬಹಳ ದೊಡ್ಡದು ಅನ್ನುವಂಥದ್ದನ್ನು ಇಲ್ಲಿ ಸ್ಮರಣೆ ಮಾಡ್ಕೊಳ್ತಾ ನಿಮಗೆಲ್ಲರಿಗೂ ಶುಭ ಕೋರಿ ಈ ಮಾತುಗಳನ್ನು ಮುಗಿಸ್ತೇವೆ. ಶರಣಾರ್ಥಿಗಳು.
ಧನ್ಯವಾದಗಳು ಸ್ವಾಮೀಜಿಗಳೇ. ತಮ್ಮ ಹಿತನುಡಿಗಳು ನಮಗೆ ಎಂದೆಂದೂ ದಾರಿದೀಪ. ಈ ಕಾರ್ಯಕ್ರಮದ ಮುಖ್ಯ ಅತಿಥಿಗಳಾಗಿ ಆಗಮಿಸಿರುವ ಕಣ್ಣಿನ ವೈದ್ಯರು ಹಾಗೂ ಕೂಡ್ಲಿಗಿ ಕ್ಷೇತ್ರದ ಮಾನ್ಯ ಶಾಸಕರಾಗಿರುವ ಡಾಕ್ಟರ್ NT ಶ್ರೀನಿವಾಸ್ ಇವರನ್ನು ಅತಿಥಿ ಭಾಷಣ ಮಾಡಬೇಕೆಂದು ಕೋರುತ್ತಿದ್ದೇವೆ.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಎಲ್ಲರಿಗೂ ಶಿಕ್ಷಕರ ದಿನಾಚರಣೆ ಹಾರ್ದಿಕ ಶುಭಾಶಯಗಳನ್ನು ತಿಳಿಸುತ್ತಾ, ಇಂಡಿಯನ್ ಮೆಡಿಕಲ್ ಅಸೋಸಿಯೇಷನ್ ಕರ್ನಾಟಕ ಬ್ರಾಂಚ್ ಮತ್ತು ಇಂಡಿಯನ್ ಮೆಡಿಕಲ್ ಅಸೋಸಿಯೇಷನ್ ತುಮಕೂರು ಚಾಪ್ಟರ್ ಇವರ ವತಿಯಿಂದ ಇವತ್ತೇನು ಶಿಕ್ಷಕರ ದಿನಾಚರಣೆ ಆಚರಿಸ್ತಾ ಇದ್ದೀವಿ, ಇದರ ಉದ್ಘಾಟಕರಾಗಿ ಆಗಮಿಸಿರ್ತಕ್ಕಂಥ ಸನ್ಮಾನ್ಯ ಪರಮ ಪೂಜ್ಯ ಗುರುಗಳಾದ ಡಾಕ್ಟರ್ ಬಸವಕುಮಾರ ಸ್ವಾಮೀಜಿ ಅವರುಗಳ ಪಾದಗಳಿಗೆ ನಮಸ್ಕರಿಸುತ್ತಾ, ಮತ್ತು ಅಧ್ಯಕ್ಷತೆ ವಹಿಸುವಂಥ ನಮ್ಮ ಚಿನ್ನಿವಾಲರ್ ಸರ್ ಅವರಿಗೆ, ಮತ್ತು ನಮ್ಮ ಡಾಕ್ಟರ್ ಮಹೇಶ್ ಅವರು, ಮತ್ತು ನಮ್ಮ ನಾರಾಯಣ್ ಸರು, ಸೂರ್ಯರಾಜು ಸರು, ಮತ್ತು ನಮ್ಮ ಪ್ರಹ್ಲಾದ್ ಸರು, ಮತ್ತು ವೇದಿಕೆ ಮೇಲೆ ಇರ್ತಕ್ಕಂಥ ಎಲ್ಲ ನನ್ನ ಗುರುಗಳ ಸಮಾನರಿಗೆ, ಮತ್ತು ವೇದಿಕೆ ಮುಂಬದಲ್ಲಿರ್ತಕ್ಕಂಥ ನಮ್ಮ ಗುರುಗಳ ಸಮಾನರು, ಮತ್ತು ನನ್ನ ನೆಚ್ಚಿನ ವಿದ್ಯಾರ್ಥಿಗಳಿಗೆ ಎಲ್ಲರಿಗೂ ಶಿಕ್ಷಕರ ದಿನಾಚರಣೆಯ ಹಾರ್ದಿಕ ಶುಭಾಶಯಗಳನ್ನು ತಿಳಿಸುತ್ತಾ, ನಾನು ಈಗ ಸುಮಾರು 2.5 ವರ್ಷದಿಂದ ಈ ರಾಜಕೀಯ ಜೀವನದಲ್ಲಿದ್ದೀನಿ. ನಾನು ಡಾಕ್ಟ್ರ್ ಅನ್ನೋದು ಮರ್ತೋಗ್ಬಿಟ್ಟು ಕಳೆದೋಗ್ಬಿಟ್ಟಿದ್ದೀನಿ. ಆದರೆ ಈಗ ಒಂದು ಕೆಲವು ದಿನಗಳಿಂದ ನಮ್ಮ ವಿಶೇಷವಾಗಿ ಇಲ್ಲಿ ಇರ್ತಕ್ಕಂಥ ನಮ್ಮ ತುಮಕೂರಿನ ವೈದ್ಯ ಮಿತ್ರರ ನೆನಪಿಸ್ಕೊಂಡು ನನ್ನನ್ನು, ನೀನು ಕೂಡ ಡಾಕ್ಟ್ರು, ಸ್ವಲ್ಪ ನಿನ್ನ ಕಾಂಟ್ರಿಬ್ಯೂಷನ್ನು ಬೇಕು ಈ ನಮ್ಮ ಡಾಕ್ಟರ್ ಕಮ್ಯುನಿಟಿಗೆ ಅಂತೇಳಿ ಸ್ವಲ್ಪ ಗುರುತಿಸಿ. ಯಾಕೆಂದರೆ ಇಟ್ ಈಸ್ ಸೋ ಡಿಫಿಕಲ್ಟ್ ಟು ಬಿ ಎ ಪೊಲಿಟಿಷಿಯನ್ ಫಾರ್ ಎ 100% ಕ್ಲಿನಿಷಿಯನ್. ನೀವು ರಾಜಕೀಯಕ್ಕೆ ಹೋಗ್ಬೇಕಂತೇಳಿ ಡಾಕ್ಟ್ರ್ ಆಗೋದು ಬೇರೆ, ನೀವು ಡಾಕ್ಟ್ರಾಗಿ ಇದ್ದು ಡಾಕ್ಟ್ರಾಗೆ ಇವಂಟು ಈಗ ಏನು ನಾವು IMAದು ಪ್ರೇಯರು ತುಂಬ ಒಳ್ಳೆ ಪ್ರೇಯರ್ ಹೇಳಿದ್ರಿ. ನಮ್ಮ ವೃತ್ತಿ ಗೌರವನ ಹೆಂಗೆ ಕಾಪಾಡಬೇಕು, ರೋಗಿಗಳನ್ನ ಹೆಂಗೆ ಕಾಪಾಡಬೇಕಂತೇಳಿ. ಬಟ್ಟು ಕರೆಂಟ್ ಸಿಚುಯೇಷನ್ ಹಂಗಿಲ್ಲ. ನಾವು ಡಾಕ್ಟ್ರುಗಳು ಬದುಕಿದ್ರೆ ಸಾಕೀಗ, ಫಸ್ಟು ಪೇಷಂಟ್ ಬಿಟ್ಬಿಡಿ, ಆ ಒಂದು ಜಮಾನದಲ್ಲಿ ನಾವಿದ್ದೀವಿ. ಮತ್ತು ನಮ್ಮ ಗುರುಗಳು ಕೂಡ ಭಾಳ ಒಳ್ಳೆ ಸಲಹೆಗಳು ಕೂಡ ಕೊಟ್ಟರು, ಮತ್ತು ಎಚ್ಚರಿಕೆ ಮಾತುಗಳನ್ನು ಕೂಡ ಆಡಿದ್ರು ನಮ್ಮ ವಿದ್ಯಾರ್ಥಿಗಳಿಗೆ, ಗೌರವ ಕೊಡೋಂಥದ್ದು, ಸಂಸ್ಕೃತಿ ಸಂಸ್ಕಾರ ಇದ್ರ ಬಗ್ಗೆ. ಸೊ ನಾನು ಈಗ ಕಲ್ತಿದ್ದೇನಪ್ಪ ಅಂತಂದರೆ, ನಾನು ಭಾಷಣ ಮಾಡೋದಿನ್ನೇನಿಲ್ಲ. ಈ 2.5 ವರ್ಷ ಅನುಭವಗಳಲ್ಲಿ ವೈದ್ಯಕೀಯ ವೃತ್ತಿಗಿಂತೇನು ಕಷ್ಟ ಇಲ್ಲ ರಾಜಕಾರಣ. ಇಲ್ಲಿ ನೀವು ಕೆಲಸ ಮಾಡಿ ಬಿಡಿ, ಭಾವನಾತ್ಮಕವಾಗಿ ಸ್ಪಂದನೆ ಅಷ್ಟೇ ಅಲ್ಲಿ ಇಂಪಾರ್ಟೆಂಟ್ ಇರ್ತದೆ. ಆದರೆ ನಾವು ಒಂದು ಜೀವಗಳ ಜೊತೆ ಒಂದು ಆಟ ಆಡಬೇಕಾಗ್ತದೆ ನಮ್ಮ ವೃತ್ತಿ. ಆದರೆ ಅದನ್ನು ನಾವು ಎಷ್ಟು ಸೀರಿಯಸ್ಸಾಗಿ ತಗೊಂಡಿರ್ತೀವಿ ಅನ್ನೋದು ಒಬ್ಬ ನಿಜವಾದ ವೈದ್ಯನಿಗೆ ಮಾತ್ರ ಗೊತ್ತಿರ್ತದೆ. ಅಂಥ ಒಂದು ವೈದ್ಯನಾಗಬೇಕಂದ್ರೆ ಈ ಶಿಕ್ಷಕರ ಪಾತ್ರ ಎಷ್ಟು ಮಹತ್ವವಾಗಿರ್ತದೆ ಅನ್ನೋದಕ್ಕೆ ಇವತ್ತೆಲ್ಲ ನಾವೆಲ್ಲ ಇಲ್ಲಿ ಏನಿವತ್ತು ಒಂದು ವೈದ್ಯಕೀಯ ಮೆಡಿಕಲ್ ಕಾಲೇಜಲ್ಲಿದ್ದೀವಿ, ವಿಶೇಷವಾಗಿ ಚಿತ್ರದುರ್ಗ ಕೋಟೆನಾಡು. ನಾನು ಹುಟ್ಟಿ ಬೆಳೆದಿದ್ದು ಪಕ್ಕದಲ್ಲೇ ನಮ್ಮ ಕೂಡ್ಲಿಗಿಲ್ಲಾದರೂ ಕೂಡ ನನ್ನ ತುಂಬ ಸಂಬಂಧಿಕರು ಮತ್ತು ಆತ್ಮೀಯರು ಇರೋಂಥ ಜಾಗ ಇದು ಚಿತ್ರದುರ್ಗ. ಇವತ್ತು ನಾನೊಂದು ಇಲ್ಲಿ ಮುಖ್ಯ ಅತಿಥಿಯಾಗಿ ನನ್ನ ನೆಚ್ಚಿನ ತಾಣಕ್ಕೆ ಬಂದಿದ್ದು ಮತ್ತು ನನಗೆ ಅವಕಾಶ ಕೊಟ್ಟಿದ್ದಕ್ಕೆ ನಿಮ್ಮೆಲ್ಲರಿಗೂ ಮತ್ತೊಮ್ಮೆ ನಾನು ತುಂಬ ಧನ್ಯವಾದಗಳು ತಿಳಿಸ್ತಾ ಇದ್ದೀನಿ. ಇವತ್ತು ಏನು ನಾವು ನಮ್ಮ ಸ್ಟೂಡೆಂಟ್ಸ್ ವಿದ್ಯಾರ್ಥಿಗಳಿಗೆ ಕಳಕಳಿ ಮನವಿ ಇಷ್ಟೇ, ಈ ನಮ್ಮ ಏನು ಈಗ ಇವತ್ತಿನ ಇದರಲ್ಲಿ ಕಾಂಪಿಟೇಟಿವ್ ವರ್ಲ್ಡಲ್ಲಿ ನಾವು ಒಂದು ವೃತ್ತಿ ಗೌರವವನ್ನು ಕಾಪಾಡೋದು ತುಂಬ ಇಂಪಾರ್ಟೆಂಟ್ ಆಗಿರ್ತದೆ. ಅದ್ರ ಬಗ್ಗೆ ಯಾಕೆಂದರೆ ಮುಂಚೆ ಎಲ್ಲ ನಮಗೆ ಬೇರೆ ಬೇರೆ ಯೂನಿವರ್ಸಿಟಿಗಳಿದ್ವು ಮೆಡಿಕಲ್ಗೆ, ಇಂಥ ಕಡೆನೇ ಮಾಡಬೇಕಂತೇಳಿ. ಈಗ ವಿರ್ ಆಲ್ ಅಂಡರ್ ಒನ್ ಕಾಮನ್ ಯೂನಿವರ್ಸಿಟಿ, ರಾಜೀವ್ ಗಾಂಧಿ ಯೂನಿವರ್ಸಿಟಿ ಆಗಿರೋದ್ರಿಂದ ಸೊ ಎಜುಕೇಷನ್ ಎಲ್ಲಾದರೂ ಮಾಡಿರ್ಬೋದು. ಮುಂದಿನ ಇಂಪ್ರೂವ್ಮೆಂಟ್ ಆಫ್ ಸ್ಕಿಲ್ಸ್ ಈಸ್ ಅಟ್ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್. ಸೊ ಸ್ಕಿಲ್ ಡೆವಲಪ್ಮೆಂಟ್ ಬಗ್ಗೆ ನಾವು ಹೆಚ್ಚಿನ ಗಮನ ಕೊಡಬೇಕು. ಅದಕ್ಕೆ ತಕ್ಕಂಥ ಏನು ನಮ್ಮ ಶಿಕ್ಷಕರು ಇರ್ತಾರೆ ಅವ್ರಿಗೆ ಗೌರವ ಕೊಟ್ಟು ಒಳ್ಳೆ ರೀತಿಯಲ್ಲಿ ಕಲಿಯುವಂಥದ್ದನ್ನ ನಾವು, ಯಾಕೆಂದರೆ ನಾನು ಇಂಟರ್ನ್ಶಿಪ್ಪಲ್ಲಿ ನಮ್ಮ ಮೈಸೂರು ಮೆಡಿಕಲ್ ಕಾಲೇಜಲ್ಲಿ ನಮ್ಮ ಪೋಸ್ಟ್ ಗ್ರ್ಯಾಜುಯೇಟ್ಸ್ ಹತ್ರ ನಾವು ಶಿಕ್ಷಕರಿಗಿಂತ ಜಾಸ್ತಿ ನಮ್ಮ ಪೋಸ್ಟ್ ಗ್ರ್ಯಾಜುಯೇಟ್ ಜೊತೆ ಜಾಸ್ತಿ ಬಾಂಧವ್ಯ ಇರ್ತಿತ್ತು, ಅವ್ರ ಜೊತೆ ಜಾಸ್ತಿ ನಾವು ಕಲಿತಾ ಇದ್ವಿ. ಅದೇ ರೀತಿ ಕೂಡ ನಾವು ಎಲ್ಲ ಅಂಡರ್ ಗ್ರ್ಯಾಜುಯೇಟ್ಸ್ ಆಗಿರ್ಬೋದು, ಪೋಸ್ಟ್ ಗ್ರ್ಯಾಜುಯೇಟ್ಸ್ ಆಗಿರ್ಬೋದು, ನಮ್ಮ ಇಂಟರ್ನ್ಶಿಪ್ ಆಗಿರ್ಬೋದು, ತುಂಬ ಒಳ್ಳೆ ಶಿಕ್ಷಕರ ಮಹತ್ವದಿಂದ ಇವತ್ತು ನಾವೆಲ್ಲ ಈ ಸ್ಥಾನಕ್ಕೆ ಬಂದಿದ್ದೇವೆ. ನಮಗೆ ಎಷ್ಟು ನಮ್ಮ ಇದ್ರದ್ದು ಗುರಿ ಯಾವ ಥರ ಇರಬೇಕಂತಂದರೆ, ನನಗೆ MD ಮಾಡಬೇಕಾದ್ರೆ ಡೆಲ್ಲಿಲಿ ನಮ್ಮ ಗುರುಗಳು ಡಾಕ್ಟರ್ ತಿವಾರಿ ಸರು ಹೇಳಿದ್ರು, ನಿಮ್ಮ ತಂದೆ ತಾಯಿಗೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡೋಷ್ಟು ನೀನು ಕೆಪಾಸಿಟಿ ಬೆಳೆಸ್ಕೋಬೇಕು. ಅವ್ರಿಗೆ ನೀನು ಬೀಂಗ್ ಎ ಸರ್ಜನ್, ಇಫ್ ಯು ಕ್ಯಾನ್ ಆಪ್ರೇಟ್ ಯುವರ್ ಫಾದರ್ ಆ್ಯಂಡ್ ಮದರ್, ದೆನ್ ಓನ್ಲಿ ಯು ಆರ್ ಎಲಿಜಿಬಲ್ ಟು ಆಪ್ರೇಟ್ ಎನಿಬಡಿ ಎಲ್ಸ್ ಫಾದರ್ ಆ್ಯಂಡ್ ಮದರ್, ಇಲ್ಲಾಂದರೆ ನೀನು ಅರ್ಹನಲ್ಲ ಅಂತ ಹೇಳಿದ್ರು. ಇವತ್ತು ನಮ್ಮ ತಂದೆಗೂ ಟ್ರೀಟ್ಮೆಂಟ್ ಅಲ್ಲದೆ ಒಂದು ಮೊನ್ನೆ August 22 ನನ್ನ ಮುಖ್ಯಮಂತ್ರಿಗಳು ನನಗೆ ಅಧಿವೇಶನದಲ್ಲಿ ಕರೆದು ನನಗೆ ನೀನು ಡಾಕ್ಟ್ರ್ ಅಲ್ಲ, ನನಗೆ ಕಣ್ಣು ಸ್ವಲ್ಪ ಪರೀಕ್ಷೆ ಮಾಡು ಅಂತ ಹೇಳಿದ್ರು. ಸೊ ನಾನು ನೆಕ್ಸ್ಟ್ 2 ದಿವಸದಲ್ಲಿ ಮೊನ್ನೆ ಮಂಡೇ 24 ಪೂರ ನಾನು ಹಾಸ್ಪಿಟಲ್ ಸೆಟಪೇ ತೊಗೊಂಡೋಗಿ ಕಾವೇರಿ ಅವರು ಮನೆಯಲ್ಲಿ ಎಲ್ಲ ಐ ಚೆಕಪ್ ಮಾಡಿಬಿಟ್ಟು ನಿನ್ನೆ ತಾನೇ ಅವ್ರಿಗೆ ಒಂದು ಒಳ್ಳೆ ಕನ್ನಡಕ ಕೊಟ್ಟು ಬಂದೆ. ತುಂಬ ಪ್ರಶಂಸನೀಯ ಮಾತುಗಳು ಹಾಡಿ ತುಂಬ ಚೆನ್ನಾಗಿದೆ ಅಂತೇಳಿ ಇವತ್ತೆಲ್ಲ ಕಡೆನೂ ಹಾಕ್ಕೊಂಡು ಹೋಗಿ ನನಗೆ ಫೀಡ್ಬ್ಯಾಕ್ ಬಂತು, ತುಂಬ ಒಳ್ಳೆ ಕನ್ನಡಕ ಕೊಟ್ಟಿದೆ, ತುಂಬ ಚೆನ್ನಾಗಿದೆ ಅಂತೇಳಿ. ಸೊ ನನಗೆ ನಮ್ಮ ತಾಲೂಕಿನ ಕಡೆ ವ್ಯಕ್ತಿಗೂ ಕೂಡ ನಾನು ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಟ್ಟಿದ್ದೀನಿ. ಇವತ್ತು ನಮ್ಮ ರಾಜ್ಯದ ಮೊದಲ ಪ್ರಜೆಗೆ ಕೂಡ ನಾನು ಒಂದು ಒಳ್ಳೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಟ್ಟಿದ್ದೆ ಅನ್ನೋ ಕೃತಜ್ಞತಾ ಭಾವ ಈ ಶಿಕ್ಷಕರಿಂದ ನನಗಿದೆಲ್ಲ ಸಾಧ್ಯವಾಯಿತು ಅಂತ ಹೇಳ್ತಾ, ಮತ್ತು ಎಲ್ಲರಿಗೂ ಇಂಥ ಒಳ್ಳೆ ಶಿಕ್ಷಕರು ಸಿಕ್ಕು ಪ್ರತಿಯೊಬ್ಬರು ಸಮಾಜಕ್ಕೆ ಉತ್ತಮ ಕೊಡುಗೆ ಕೊಡೋಂಥವ್ರು ನಮ್ಮ ರಾಜ್ಯದಲ್ಲಿ ಮತ್ತು ದೇಶದಲ್ಲಿ ಹಾಗೆ. ಯಾಕೆಂದರೆ ನಾವೆಲ್ಲ ಇವತ್ತು ಏನಿಲ್ಲಿ ಕೂತಿದ್ದೀವಿ ಇವೆಲ್ಲ ಸಾಮಾನ್ಯರಲ್ಲ, ಇವತ್ತೆಲ್ಲ ಅವ್ರದ್ದೇ ರೀತಿಯಲ್ಲಿ ಕಷ್ಟಪಟ್ಟು. ಯಾಕೆಂದರೆ ನಾನು ಹೇಳಿದೆ ಮೊದಲೇ, ನಾನು 100% ಐ ಆಮ್ ಎ ಕ್ಲಿನಿಷಿಯನ್ ಅಂತೇಳಿ. ಒಬ್ಬ ಕ್ಲಿನಿಷಿಯನ್ ಆಗಬೇಕು, ಮತ್ತು ಅದ್ರ ಜೊತೆಗೆ ವಿಶೇಷವಾಗಿ ಪ್ರೈವೇಟ್ ಪ್ರಾಕ್ಟೀಸ್ ಅಂತಂದರೆ ಈಗಿನ ಕಾಲದಲ್ಲಿ ಎಷ್ಟು ಚಾಲೆಂಜಿಂಗ್ ಆಗಿದೆ. ಈಗ ನಮಗೆ ಒಂದು ಸದ್ಯಕ್ಕೆ ಅದಕ್ಕಿರೋ ಚಾಲೆಂಜಸ್ ಏನು ಈಗ ಫೈರ್ದು ಡಿಪಾರ್ಟ್ಮೆಂಟಿಂದ ಇದೆ. ಅದಕ್ಕೆ ನಾನು ಈಗ ತಾವೇನೋ ಒಂದು ವೇದಿಕೆಯಲ್ಲಿ ನನಗೊಂದು ಒಳ್ಳೆಯ ಅವಕಾಶ ಕೊಟ್ಟಿದ್ರ ಮುಖಾಂತರ ಹೇಳ್ತಾ ಇದ್ದೀನಿ. ನಾನು ಈವನ್ ಡೇ ಬಿಫೋರ್ ಎಸ್ಟರ್ಡೇ ಹೋಲ್ ಡೇ ಫ್ರಮ್ ಮಾರ್ನಿಂಗ್ 11 o'clock ಟು ಈವ್ನಿಂಗ್ 5 o'clock ಅದೇ ಕೆಲಸ ಮಾಡಿದ್ದೀನಿ. ಸಂಬಂಧಪಟ್ಟ ಮಂತ್ರಿಗಳು, ಗೃಹ ಸಚಿವರಾಗಿರ್ಬೋದು, ಆರೋಗ್ಯ ಸಚಿವರಾಗಿರ್ಬೋದು, ಹೋಮ್ ಸೆಕ್ರೆಟ್ರಿ ಆ್ಯಂಡ್ ಹೆಲ್ತ್ ಸೆಕ್ರೆಟ್ರಿ ಆ್ಯಂಡ್ ಹೋಮ್ ಫೈರ್ DG ಅವ್ರನ್ನೆಲ್ಲನೂ ಖುದ್ದಾಗಿ ಭೇಟಿ ಮಾಡಿ ನನ್ನ ಲೆಟ್ರಡ್ಡೆಲ್ಲ ಡ್ರಾಫ್ಟ್ ಮಾಡಿಸಿ, ಮತ್ತು ಹೋಮ್ ಮಿನಿಸ್ಟರ್ ಕೊಂಡಿಂದನೂ ಡ್ರಾಫ್ಟ್ ಮಾಡಿಸಿ ಇವತ್ತೇ ಆರ್ಡ್ರ್ ಇಶ್ಯೂ ಮಾಡ್ತೀವಿ ಅಂದರು. ಮತ್ತು ನಿನ್ನೆ ಸಾಯಂಕಾಲ ನಮ್ಮ DG ಸಾಹೇಬರು ಫೋನ್ ಮಾಡಿದ್ರು, ಒಂದು ಸರಿ ಆರ್ಡ್ರ್ ಪಾಸ್ ಮಾಡಿದ್ರೆ ಮತ್ತೆ ಚೇಂಜ್ ಮಾಡೋಕ್ಕಾಗಲ್ಲ, ಒಂದು ಸ್ವಲ್ಪ ಇನ್ನೊಂಚೂರು ಒಪಿನಿಯನ್ಸ್ ತೊಗೊಂಡು ನ್ಯೂನತೆಗಳು ಸರಿಪಡಿಸಿ ಒಂದೇ ದಿವಸದಲ್ಲಿ ನಾವು ಮಾಡ್ತೀವಿ, ಅದ್ರ ಬಗ್ಗೆ ಏನೋ ಇದು ಇಲ್ಲ ಅಂತೇಳಿ. ಸೊ ತುಂಬ ಸಕಾರಾತ್ಮಕ ಸ್ಪಂದನೆ ಸಿಕ್ಕಿದೆ ನಮ್ಮ ಈ ಫೈರ್ NOC ಬಗ್ಗೆ. ಅದ್ರ ಬಗ್ಗೆ ನಾನು ಯಾವತ್ತೂ ವಾಟ್ ಎವರ್ ಐ ಡೂ ವಿತ್ ಮೈ ಹೋಲ್ ಆ್ಯಂಡ್ ಸೋಲ್ ಹಾರ್ಟ್ ಆ್ಯಂಡ್ 100% ಎಫರ್ಟ್ಸ್ ಹಾಕ್ತೀನಿ ನಾನು. ಸೊ ಅದರಿಂದ ಇದು ಒಂದು ನಮ್ಮ IMA ಕಡೆಯಿಂದ ನಾನು ಖಂಡಿತ ಇದೊಂದು ಶುಭ ಸುದ್ದಿಯನ್ನು ಶೀಘ್ರದಲ್ಲೇ ನಿಮಗೆ ಕೊಡ್ತೀವಿ ಅಂತ ಹೇಳ್ತಾ, ಮತ್ತು ಇನ್ನೂ ಏನೇನು ನಮ್ಮ ಚಾಲೆಂಜಸ್ ಇದೆ ನಮ್ಮ ಮೆಡಿಕಲ್ ಫ್ರೆಟರ್ನಿಟಿಗೆ, ಅದೆಲ್ಲದನ್ನೂ ನಮ್ಮ ಸರ್ಕಾರದ ವತಿಯಿಂದ ಅದನ್ನೆಲ್ಲದನ್ನೂ ಅಸಾಧ್ಯವಾದನ್ನೆಲ್ಲ ಸಾಧ್ಯವಾಗಿಸೋದಕ್ಕೆ ಪ್ರಾಮಾಣಿಕ ಪ್ರಯತ್ನ ಮಾಡ್ತೀನಿ ಅಂತ ಹೇಳ್ತಾ, ಮತ್ತೊಮ್ಮೆ ತಮ್ಮೆಲ್ಲರಿಗೂ ಶಿಕ್ಷಕರ ದಿನಾಚರಣೆ ಶುಭಾಶಯಗಳು ತಿಳಿಸಿ ಇಂಥ ಒಂದು ಉತ್ತಮ ಸ್ಥಳದಲ್ಲಿ ನನಗೆ ಅವಕಾಶ ಮಾಡಿಕೊಟ್ಟಂಥ ತಮ್ಮೆಲ್ಲರಿಗೂ ವಿಶೇಷವಾಗಿ ಪ್ರಹ್ಲಾದ್ ಸರ್, ನನಗೆ ಅವ್ರಿಗೆ ಮಾತಾಡೋಷ್ಟು ಟೈಮ್ ಇರಲಿಲ್ಲ, ಸಭೆಯಲ್ಲಿದ್ದೆ, ಆದರೂ ಅವ್ರು ಬಿಡಲಿಲ್ಲ, ತುಂಬ ಸರಿ. ಮತ್ತು ನಮ್ಮ IMA ಪ್ರೆಸಿಡೆಂಟು, ನಮ್ಮ IMA ಬ್ರ್ಯಾಂಚವರು ಎಲ್ಲರೂ ನನಗೆ ಇಲ್ಲ ತಾವು ಬರಲೇಬೇಕು ಚಿತ್ರದುರ್ಗಕ್ಕೆ ಅಂತ ಹೇಳಿದ್ರು. ಸೊ ನಿಮ್ಮ ಪ್ರೀತಿಗೆ ನಾನು ನಿಜವಾಗ್ಲೂ ಚಿರಣಿಗೆ ಆಗಿರ್ತೀನಿ ಅಂತ ಹೇಳ್ತಾ, ಮತ್ತು ನಮ್ಮೆಲ್ಲ ವೈದ್ಯಕೀಯ ಕಷ್ಟಗಳಿಗೆ ನಾವೆಲ್ಲರೂ ಸೇರಿ ದನಿಯಾಗಿ ಒಂದು ಸಮಾಜಕ್ಕೆ ಉತ್ತಮ ಕೊಡುಗೆ ಕೊಡೋಣ ಅಂತ ಹೇಳ್ತಾ ನನ್ನ ಮಾತು ಮುಗಿಸ್ತೀನಿ. ಜೈ ಹಿಂದ್.
Thank you, sir. We are ever grateful for your tireless efforts to safeguard and support small and medium-sized hospitals. We now invite our distinguished guest, senior and eminent physician, Dr. Mahesh sir, to share a few words of wisdom.
ಮೊದಲನೇದಾಗಿ ಪೂಜ್ಯ ಶ್ರೀ ಬಸವಕುಮಾರ ಸ್ವಾಮಿಗಳ ಪಾದಕ್ಕೆ ನಮಸ್ಕರಿಸುತ್ತಾ, KSB Indian Medical Association, KSB governing body, members, also the Chitradurga IMA body members, I congratulate you to celebrate this Teachers' Day with the IMA. IMA has started about 1928 by Bidhan Chandra Rai and the team. There will be about 1,700 to 800 branches. More than 3.5 lakhs members are there, biggest body of the India. And basically, what I want to tell you is, two things you have to follow. This is my 72 years. All the time I have become a Pakka teacher. Rather, what I want to tell you is to keep or do the two things. One is to follow the time. Once the teacher or a profession, whatever it is, whether you are a doctor or you are a teacher or whatever you are, follow the time correctly. Automatically, if you are a teacher, you will go on reading, you will knowing the things. A teacher is always a teacher, lifelong student he is. And of course, a medical doctor also, lifelong lesson or lifelong learning is also there, should be there. So one thing is keep the time, whether you are a teacher or a medical professionalist, so that automatically you will go on doing the works. That knowledge will come to you, that will be implemented to the students or to the patients. Second thing, love the thing what you are doing. Anything which you love, you will sacrifice. We are loving our parents, we are loving our wife, we are loving our children, we do everything, we sacrifice everything to them. Like that, we have to love our profession, our subject. We are students. Suppose if I am a teacher, I should love my students. If I am a medical professional, I should love my profession. So like that, time and love will always make you genius or whatever that respectful nature. I am here because of this 20 years. I came here about Chitradurga, took here as a principal and other things I have done. But the thing is, all of here, including principal and other HODs are my students. They are loving me so much, respecting me so much. I don't want to leave this also. And luckily, management is also continued my service here. So I am thankful to everyone and wish you all the good luck, particularly to the awardees who are celebrating or who are awarded here are probably, as I told, they are doing their work about the time and love. So that's why they are getting awards. Please continue your services to the society and become good, and ultimately you will get the satisfaction. Thank you very much. God bless you all.
Dr. Mahesh sir, known for making even the toughest chapters simple for us. Thank you so much. We now request our beloved President of IMA, Karnataka State Branch, Dr. V.V. Chinivalar sir, to deliver his presidential address.
ಈ ಶುಭ ಸಂಜೆಯ ಸಮಾರಂಭದ ಶಿಕ್ಷಕ ದಿನಾಚರಣೆಯ ಸಮಾರಂಭಕ್ಕೆ ಸೇರಿದ ತಮಗೆಲ್ಲರಿಗೂ ಸ್ವಾಗತ, ಸುಸ್ವಾಗತ ಮತ್ತು ಶಿಕ್ಷಕ ದಿನಾಚರಣೆಯ ಶುಭಾಶಯಗಳು. ಇಂದಿನ ಈ ಶಿಕ್ಷಕರ ದಿನಾಚರಣೆಯ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಉದ್ಘಾಟಕರಾಗಿ ಆಗಮಿಸಿರುವ ಡಾಕ್ಟರ್ ಶ್ರೀ ಶ್ರೀ ಬಸವಕುಮಾರ ಸ್ವಾಮಿಗಳ ಚರಣಕಮಲಗಳಿಗೆ ನಮಿಸುತ್ತಾ, ಮುಖ್ಯ ಅತಿಥಿಗಳಾಗಿ ಆಗಮಿಸಿದ ಡಾಕ್ಟರ್ NT ಶ್ರೀನಿವಾಸರವರೇ, ಅತಿಥಿಗಳಾದ ಡಾಕ್ಟರ್ ಮಹೇಶ್ರವರೇ, ಸನ್ಮಾನಿತ ಶಿಕ್ಷಕ ವೃಂದವೇ, ವೈದ್ಯ ಸಹೋಗಿಗಳಿಗೆ ಮತ್ತು ಚಿತ್ರದುರ್ಗ IMA ಪದಾಧಿಕಾರಿಗಳೇ, ಸದಸ್ಯರೇ, ತಮಗೆಲ್ಲರಿಗೂ ಶಿಕ್ಷಕರ ದಿನಾಚರಣೆಯ ಶುಭಾಶಯಗಳು. ವೇದಿಕೆಯ ಮೇಲಿರುವ ಎಲ್ಲ ಗಣ್ಯಮಾನ್ಯರಿಗೆ, ವೇದಿಕೆಯ ಮುಂಭಾಗದಲ್ಲಿರುವ ಎಲ್ಲ ಗಣ್ಯಮಾನ್ಯರಿಗೆ, ವಿದ್ಯಾರ್ಥಿನಿಯರಿಗೆ ಮತ್ತು ಮಹಿಳೆಯರೇ ಎಲ್ಲರಿಗೂ ಶಿಕ್ಷಕರ ದಿನಾಚರಣೆಯ ಶುಭಾಶಯಗಳು. ತಮಗೆಲ್ಲರಿಗೆ ಗೊತ್ತಿರುವಂತೆ ಗುರುವಿನ ಗುಲಾಮನಾಗುವ ತನಕ ದೊರೆಯದಣ್ಣ ಮುಕುತಿ ಅಂಥೇಳಿ, ಹಾಗೆಯೇ ನಮ್ಮ ಜೀವನದಲ್ಲಿ ಮುಂದೆ ಗುರಿ, ಹಿಂದೆ ಗುರುವಿರಬೇಕು ಎಂಬ ಒಂದು ಆಸೆ ಆಕಾಂಕ್ಷೆಗಳು, ಇದರ ಬಗ್ಗೆ ನಮ್ಮ ಬಸವಕುಮಾರ ಸ್ವಾಮಿಗಳು ಒಳ್ಳೆಯ ಒಂದು ಸಂದೇಶವನ್ನು ನಮಗೆಲ್ಲರಿಗೆ ಈಗ ನೀಡಿದ್ದಾರೆ. ಜೀವನದಲ್ಲಿ ಮುಕ್ತಿ ದೊರೆಯಬೇಕಾದರೆ ಗುರುಗಳು ಸಹ ಬೇಕೇ ಬೇಕು. ಗುರುಗಳ ದಿನವನ್ನೇ ನಾವುಗಳು ಇಂದು ಶಿಕ್ಷಕರ ದಿನವನ್ನಾಗಿ ಆಚರಿಸುತ್ತಿದ್ದೇವೆ. ನಮ್ಮ ದೇಶದ ದ್ವಿತೀಯ ರಾಷ್ಟ್ರಪತಿ, ಮಹಾನ್ ತತ್ವಜ್ಞಾನಿ ಹಾಗೂ ಅಪ್ರತಿಮ ಆದರ್ಶ ಶಿಕ್ಷಕರಾದಂಥ ಡಾಕ್ಟರ್ ಸರ್ವೇಪಲ್ಲಿ ರಾಧಾಕೃಷ್ಣನವರ ಜನ್ಮದಿನವನ್ನೇ ನಾವು ಶಿಕ್ಷಕರ ದಿನವನ್ನಾಗಿ ಆಚರಿಸುತ್ತಿದ್ದೇವೆ. ಶಿಕ್ಷಕರು ಎಂದರೆ ಕೇವಲ ಪಾಠ ಹೇಳುವ ಮಾಸ್ತರುಗಳು ಅಲ್ಲ, ಅವರು ನಮ್ಮ ಚಿಂತನೆಗೆ ದಾರಿ ತೋರಿಸುವವರು, ಜೀವನದಲ್ಲಿ ಮೌಲ್ಯಗಳನ್ನು ಬಿತ್ತುವವರು, ನಮ್ಮನ್ನು ಒಳ್ಳೆಯ ಮನುಷ್ಯರನ್ನಾಗಿಸುವವರು, ಮಾರ್ಗದರ್ಶಕರು. ನಾವು ವೈದ್ಯಕೀಯ ಕ್ಷೇತ್ರಕ್ಕೆ ಬಂದಿರುವ ಪ್ರತಿಯೊಬ್ಬರೂ ನಮ್ಮ ಬದುಕಿನಲ್ಲಿ ಮಾರ್ಗದರ್ಶಕರಾದ ಗುರುಗಳ ಋಣಿಗಳು. ವೈದ್ಯರಾಗಿರುವ ನಮಗೆಲ್ಲ ಶಿಕ್ಷಕರು ಕೇವಲ ಜ್ಞಾನವನ್ನೇ ನೀಡಿಲ್ಲ, ಬದಲಿಗೆ ಶ್ರದ್ಧೆ, ನೈತಿಕತೆ ಮತ್ತು ಮಾನವೀಯತೆ ಎಂಬ ಶಕ್ತಿಯನ್ನು ನೀಡಿದ್ದಾರೆ. ಆಸ್ಪತ್ರೆಯಲ್ಲಾಗಲಿ ಕಾಲೇಜಿನ ತರಗತಿಗಳಲ್ಲಾಗಲಿ ಅವರ ಪಾಠಗಳು ಜೀವನ ಪಾಠಗಳಾಗಿವೆ. ಇಂದು ನಮ್ಮ ಕರ್ತವ್ಯ ಏನೆಂದರೆ ನಾವು ಪಡೆದ ಜ್ಞಾನವನ್ನು ಮುಂದಿನ ತಲೆಮಾರಿಗೆ ಹಂಚುವುದು, ಯುವ ವೈದ್ಯರಿಗೆ ಮಾರ್ಗದರ್ಶಕರಾಗುವುದು, ನಮ್ಮ ಕೆಲಸದ ಮೂಲಕ ಸಮಾಜಕ್ಕೆ ಮಾದರಿಯಾಗುವುದು. IMA ಕುಟುಂಬವೇ ಒಂದು ಶ್ರೇಷ್ಠ ಶಿಕ್ಷಣದ ವೇದಿಕೆಯಾಗಿದೆ. ಇಲ್ಲಿ ನಾವು ಪರಸ್ಪರ ಕಲಿಯುತ್ತೇವೆ. ಹಿರಿಯ ವೈದ್ಯರು ಕಿರಿಯ ವೈದ್ಯರಿಗೆ ದಾರಿ ತೋರಿಸುತ್ತಾರೆ ಮತ್ತು ಶೃಂಗಾರೋಹಣವು ಎಂದಿಗೂ ನಿಲ್ಲುವುದಿಲ್ಲ. ಪ್ರತಿಯೊಬ್ಬ ವೈದ್ಯನೂ ತನ್ನೊಳಗೆ ಒಬ್ಬ ಗುರು ಆಗಿರಬೇಕು. ರೋಗಿಗೆ ಆರೋಗ್ಯದ ದಾರಿ ತೋರಿಸುವ ಗುರು, ಸಮಾಜಕ್ಕೆ ಆರೋಗ್ಯ ಶಿಕ್ಷಣ ನೀಡುವ ಗುರು, ಮುಂದಿನ ತಲೆಮಾರಿನ ವೈದ್ಯರಿಗೆ ಮಾರ್ಗದರ್ಶಕರಾಗುವ ಗುರು. ಗುರುವಿನ ಸ್ಥಾನ ಗಗನಕ್ಕಿಂತ ಉನ್ನತ. ತಾಯಿ ತಂದೆಯರಂತೆ ಜೀವನ ಕಟ್ಟಿಕೊಡುವವರು, ಅಜ್ಞಾನದ ಕತ್ತಲನ್ನು ಕಳಚಿ ಜ್ಞಾನದ ಬೆಳಕಿನಿಂದ ದಾರಿ ತೋರಿಸುವವರು ಶಿಕ್ಷಕರು. ನಿಮ್ಮ ತಾಳ್ಮೆ, ತ್ಯಾಗ, ಶ್ರಮ ಹಾಗೂ ಮಮತೆಯಿಂದ ರೂಪುಗೊಂಡ ಪ್ರತಿಯೊಬ್ಬ ಶಿಷ್ಯನು ಸಮಾಜದಲ್ಲಿ ಬೆಳಕಾಗುತ್ತಾನೆ. ಜ್ಞಾನವನ್ನು ಹಂಚುವ ನಿಮ್ಮ ದಾರಿಯೇ ಅತಿ ಮಹತ್ತರವಾದ ಸೇವೆಯಾಗಿದೆ. ನಿಮ್ಮ ಮಾತುಗಳಲ್ಲಿ ಮಂತ್ರ, ನಿಮ್ಮ ನಡೆಗಳಲ್ಲಿ ಪಾಠ, ನಿಮ್ಮ ಜೀವನವೇ ಶಿಷ್ಯರಿಗೆ ಪ್ರೇರಣೆಯಾಗಿದೆ. ಸಮಾಜವನ್ನು ಸಜ್ಜನಿಕೆಗೆ, ನೈತಿಕತೆಗೆ, ಮಾನವೀಯತೆಗೆ ಕೊಂಡೊಯ್ಯುವ ಹಾದಿ ತೋರಿಸುವ ಸನ್ಮಾನಿತ ಶಿಕ್ಷಕರಿಗೆ ಹೃತ್ಪೂರ್ವಕ ವಂದನೆಗಳು ಮತ್ತು ಪ್ರಣಾಮಗಳು. ಇಂದು ಈ ಶಿಕ್ಷಕರ ದಿನದಂದು ಗುರುಗಳಿಗೆ ಗೌರವ ಸಲ್ಲಿಸೋಣ. ಇಲ್ಲಿವರೆಗೆ ಈಗ ನಮ್ಮ ಅತಿಥಿಗಳಾದಂಥ ಡಾಕ್ಟರ್ NT ಶ್ರೀನಿವಾಸ್ ಅವರು ಫೈರ್ NOC ಬಗ್ಗೆ ಹೇಳಿದರು. ನಾವು ಕನಿಷ್ಠ ಮಾರ್ಚ್ ತಿಂಗಳಿಂದ ಈ ಫೈರ್ NOC ಸಲುವಾಗಿ ಏನಂತಲ್ಲ ಆರೋಗ್ಯ ಸೌಧದ ಸುತ್ತಲೇ ನಾವು ಸುತ್ತುತ್ತಾ ಇದ್ವಿ, ನಮ್ಮ IMAದವರು ಮತ್ತು ಫಾನಾದವರು. ಆದರೆ ಅಕಸ್ಮಾತಾಗಿ ನಮಗೆ ಡಾಕ್ಟರ್ಸ್ ಡೇ ದಿವಸ ನಮ್ಮ NT ಶ್ರೀನಿವಾಸರವರು ಮುಖ್ಯ ಅತಿಥಿಗಳಾಗಿ ದೊರೆತ ನಂತರ ನಾವು ಆರೋಗ್ಯ ಸೌಧದಿಂದ ವಿಧಾನಸೌಧಕ್ಕೆ ಬರುವಂತಾಯಿತು. ಸೊ ನಮ್ಮ ಕೆಲಸಗಳಿಗೆ ಅವರು ನಿಜವಾದ ಒಂದು ಏನಂತಲ್ಲ ಮಾರ್ಗದರ್ಶಕರಲ್ಲದೆ ಸಲಹೆ ಸೂಚನೆ ಕೊಡುತ್ತಾ ಅಲ್ಲಿಂದ ಇಲ್ಲಿಯವರೆಗೂ ನಮ್ಮ ಸಲುವಾಗಿ ವೈದ್ಯರ ಸಲುವಾಗಿ ನಿಜವಾಗಿ ದಿನಾಲೂ ಏನಂತ ಪ್ರತಿಯೊಬ್ಬ ಕನ್ಸರ್ನ್ ಮಿನಿಸ್ಟರ್ಸನ್ನು, ಪದಾಧಿಕಾರಿಗಳನ್ನು, ಆಫೀಷಿಯಲ್ಸ್ ಎಲ್ಲ ಭೇಟಿಯಾಗಿ ಈಗ ಒಂದು ಹಂತಕ್ಕೆ ಬಂದಿದೆ, ಒಂದು ಶೇಪ್ ಬಂದಿದೆ. ಇನ್ನು ಕೆಲವೇ ದಿವಸಗಳಲ್ಲಿ ನಾವು ನಂತರ ಅವರ ಹೇಳಿಕೆಯ ಪ್ರಕಾರ ಒಂದು 8-10 ದಿವಸಗಳಲ್ಲಾಗಲಿ 10 ದಿವಸಗಳಲ್ಲಿ ಒಂದು ಶುಭ ಸಂದೇಶವನ್ನು ನಾವು ಸರ್ಕಾರದ ವತಿಯಿಂದ ಪಡೆಯುತ್ತಿದ್ದೇವೆ ಅಂಥೇಳಿ ನಾನು ಹೇಳ್ತಾ ಇದ್ದೀನಿ. ಅಲ್ಲದೆ ಈಗ ಇತ್ತೀಚೆಗೆ ಒಂದು ಸರ್ಕಾರದ ಆದೇಶ, ಅದನ್ನು ನಾನು ಡಾಕ್ಟರ್ NT ಶ್ರೀನಿವಾಸ್ ಅವರ ಗಮನಕ್ಕೆ ತರ್ತಾ ಇದ್ದೀನಿ. ಅಪಘಾತದಲ್ಲಿ ಗಾಯಗೊಂಡಂಥ ರೋಗಿಗಳು ಆಸ್ಪತ್ರೆಗಳಿಗೆ ಬಂದಾಗ ಚಿಕಿತ್ಸೆಗೆ ಮುನ್ನ ಹಣ ಕೇಳಿದರೆ ಖಾಸಗಿ ವೈದ್ಯರಿಗೆ ಜೈಲು ಶಿಕ್ಷೆ ಎನ್ನುವಂಥ ಒಂದು ಆದೇಶ ಹೊರಡುವ ಸ್ಥಿತಿಯಲ್ಲಿದೆ. ದಯವಿಟ್ಟು ಇದರ ಬಗ್ಗೆ ಈ ಸುತ್ತೋಲೆ ಹೊರಡೋದಕ್ಕಿಂತ ಮೊದಲು ತಮ್ಮ ತಿಳುವಳಿಕೆಗೆ ಬರಲಿ. ಇದನ್ನು ಆದಷ್ಟು ಏನಂತಲ್ಲ ಈ ಲೆವೆಲಲ್ಲಿ ಅದನ್ನು ಆದಷ್ಟು ಖಂಡಿಸಿ ಅದನ್ನು ಆ ಸುತ್ತೋಲೆಯನ್ನು ತೆಗೆದು ಹಾಕಬೇಕಾಗಿ ಕೇಳಿಕೊಳ್ಳುತ್ತಿದ್ದೆ ನಾನು. ಅಪಘಾತದಲ್ಲಿ ದಯವಿಟ್ಟು ಏನಂತಲ್ಲ ಸಾಕಷ್ಟು ರೋಗಿಗಳು ಬರ್ತಿರ್ತಾರೆ, ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡ್ತಿರ್ತಾರೆ. ಯಾರು ಬಂದ ತಕ್ಷಣವೇ ಅವರಿಗೆ ಏನಂತಲ್ಲ ಯಾವ ವೈದ್ಯರು ದುಡ್ಡು ಕೇಳೋದು, ಮೊದಲು ಪ್ರಥಮ ಚಿಕಿತ್ಸೆ ನೀಡ್ತಾರೆ, ನೀಡಿದ ನಂತರ ಏನಂತಲ್ಲ ಇದಿರುತ್ತೆ. ಆದರೆ ಅಂಥ ಒಂದು ವೈದ್ಯರು ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡಲಿಲ್ಲದ್ರೆ ಅವರಿಗೆ ಜೈಲು ಶಿಕ್ಷೆ ಎಂಬುದೊಂದು ಈ KPME ಅಡಿಯಲ್ಲಿ KPME ಯಾವಾಗ ಪ್ರಾರಂಭವಾಯಿತು ಆವತ್ತಿನಿಂದ ಇದು ಒಂದು ಡಾಕ್ಟ್ರಿಗೆ ಮೂಗುದಾಣ ಹಾಕಿದಂಗೆ ಪ್ರತಿಯೊಂದು ಹಾಕಿ ಏನಂತಲ್ಲ KPME ಅಡಿಯಲ್ಲಿ ನಿಮಗೆ ಶಿಕ್ಷೆ ವಿಧಿಸ್ತೀವಿ, ಇಷ್ಟು ವರ್ಷ ಇದಾಗ್ತೀವಿ, ಜೈಲು ಶಿಕ್ಷೆ ಕೊಡ್ತೀವಿ ಅಂತ. ಸೊ ಇಂತಹ ಒಂದು ಸುತ್ತೋಲೆಗಳನ್ನು ಸರ್ಕಾರದಿಂದ ಕಿತ್ತೊಗೆಯಬೇಕು ಅಂತೇಳಿ ನಾನು NT ಶ್ರೀನಿವಾಸ್ ಅವರು ಇದನ್ನು ಸರ್ಕಾರದ ಮಟ್ಟದಲ್ಲಿ ಎತ್ತಿ ಅದಕ್ಕೆ ಆದಷ್ಟು ತಡೆ ಒಡ್ಡಬೇಕು ಅಂತೇಳಿ ತಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ಪರವಾಗಿ ತಮ್ಮಲ್ಲಿ ಮನವಿ ಮಾಡಿಕೊಳ್ತಾ ಇದ್ದೀನಿ. ಇದಲ್ಲದೆ ಇಂದಿನ ಒಂದು ಶಿಕ್ಷಕರ ದಿನಾಚರಣೆಯ ದಿವಸ ಎಲ್ಲ ಶಿಕ್ಷಕರು ಇಲ್ಲಿ ನೆರೆದಂಥ ಎಲ್ಲ ಶಿಕ್ಷಕರಿಗೆ ಮತ್ತು ವಿದ್ಯಾರ್ಥಿನಿಯರಿಗೆ ಎಲ್ಲರಿಗೂ ಶಿಕ್ಷಕರ ದಿನಾಚರಣೆಯ ಶುಭಾಶಯಗಳನ್ನು ಕೋರುತ್ತಾ ನನ್ನ 2 ಮಾತುಗಳನ್ನು ಮುಗಿಸ್ತಾ ಇದ್ದೀನಿ.
ಧನ್ಯವಾದಗಳು ಸರ್. ಈಗ ಈ ಸಮಾರಂಭದ ಪ್ರಮುಖ ಘಟ್ಟ, ಉತ್ತಮ ವೈದ್ಯ ಶಿಕ್ಷಕರಿಗೆ ಸನ್ಮಾನ ಕಾರ್ಯಕ್ರಮ. ವೇದಿಕೆ ಮೇಲಿರುವ ಎಲ್ಲ ಗಣ್ಯರು ಇದನ್ನು ನಡೆಸಿಕೊಡಬೇಕೆಂದು ಮನವಿ ಮಾಡಿಕೊಳ್ತೇವೆ. Starting with our first awardee, Professor Dr. Amareshwara M. Malagi, HOD, Department of Biochemistry, KIMS Koppal. Sir has completed his MBBS, MD Biochemistry, FAGE and CCTM. He has played several roles such as that of Permanent Assessor, Medical Council of India, New Delhi, Nodal Officer, DME, Government of Karnataka, Bangalore. Sir also published various national and international journals. A big round of applause for sir.
Next we have Dr. Amruta S. Bennal, Assistant Professor Physiology, Raichur. Next we have Dr. Amruta S. Bennal, Assistant Professor Physiology, Raichur, and an active member of IMA Raichur branch. She has 16.5 years of teaching experience. She has got various state-level felicitations for teaching, including state-level Best Tutor Award. She is a gold medalist in her post-graduation and a peer reviewer for various journals. She's been felicitated with several awards like Women Achievers Award from Jawahar Navodaya Vidyalaya, Alumni Karnataka, etc. A huge round of applause for this inspiration in front of us for all the young female doctors like me here.
Hello.
Next, we have Dr. Bharati Bhavikatti, Associate Professor Pathology in KIMS Hubli, life member of the IMA Hubli branch. She's conducted around 16 CMEs, blood donation camps, and free health checkups as a part of IMA. She's received IMA Women Doctors Wing Best Branch Award twice in her leadership. Let's welcome the wonderful Dr. Bharati ma'am on stage.
ಕನ್ನಂಬಾಡಿಯ ಕಟ್ಟಿಸಿದ ಭಾರತ ರತ್ನಕ್ಕೆ ಚಪ್ಪಾಳೆ ಕನ್ನಡ ಡಿಂಡಿಮ ಬಾರಿಸಿದ ಕವಿಗಳೇ ನಿಮಗಿದ ಚಪ್ಪಾಳೆ ದೇಶವ ಕಾಯುವ ಯೋಧರಿಗೆ ನಮ್ಮೆದೆಯಾಳದ ಚಪ್ಪಾಳೆ ಅನ್ನವ ನೀಡುತ್ತ ಸಲಹಿರುವ ನೇಗಿಲ ಯೋಗಿಗೆ ಚಪ್ಪಾಳೆ 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 ಚಪ್ಪಾಳೆ
Now we call Dr. Geeta H.S. Ma'am, Professor and Unit Chief, Department of Obstetrics and Gynecology, Basaveshwara Medical College and Hospital. Ma'am has completed MBBS and PG from JJMMC Davangere, trained in laparoscopy and UST, with a teaching experience of more than 20 years. Served as a member of RGHS Board of Studies for the year 2017-18 and 2025. She is the past president and past secretary in OBG Society. Ma'am never just sits. She makes students sing. A big round of applause for the ma'am.
ಕೀರ್ತನೆ ವಚನವ ಬೋಧಿಸಿದ ಯೋಗಿ ವರೇಣ್ಯರ ಚಪ್ಪಾಳೆ ಕ್ರೀಡಾ ಲೋಕದ ಸಾಧಕರೇ ನಿಮಗಿದ ಸ್ಫೂರ್ತಿಯ ಚಪ್ಪಾಳೆ ಬೆಳ್ಳಿ ತೆರೆಯ ತಾರೆಗಳೇ ನಿಮಗಭಿಮಾನದ ಚಪ್ಪಾಳೆ ನಾಡಿಗೆ ಅಣ್ಣನೇ ಆಗಿರುವ ರಾಜಣ್ಣನಿಗೆ ಚಪ್ಪಾಳೆ 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 ಚಪ್ಪಾಳೆ
Now we welcome Dr. Geeta J.P. Ma'am, Professor and HOD, Department of Pathology, Sri Siddhartha Medical College, Tumkuru. Ma'am has completed her MBBS from Sri Siddhartha Medical College, Tumkuru, MD Pathology from JJM Medical College, Davangere. She has a teaching experience of around 18 years with 21 publications. Ma'am also received Best Poster Award and winner of Poster Quiz in National Pathology Conference during post-graduation. She has presented several papers in various national level conferences. A big round of applause for the ma'am.
ಕನ್ನಂಬಾಡಿಯ ಕಟ್ಟಿಸಿದ ಭಾರತ ರತ್ನಕ್ಕೆ ಚಪ್ಪಾಳೆ ಕನ್ನಡ ಡಿಂಡಿಮ ಬಾರಿಸಿದ ಕವಿಗಳೇ ನಿಮಗಿದ ಚಪ್ಪಾಳೆ ದೇಶವ ಕಾಯುವ ಯೋಧರಿಗೆ ನಮ್ಮೆದೆಯಾಳದ
Next, we have Dr. Jyoti Swaroop R, MBBS, DLO, DNB with 26 years of undergraduate and postgraduate experience. He is the organizing secretary of annual state conference of AOI Karnataka State Branch, scientific committee member of annual All India Conference of AOI, invited guest faculty during state and national conferences and surgical workshop, organized many CME programs and hands-on surgical workshop. Sir has published numerous articles in international and national journals. He is a life member of AOI Karnataka and All India Otology and All India Otology Society of India, IMA, IMA AMS, IAO, OHNS and Otology Society of India. We have Dr. Mamata H, Additional Professor of KMC, life member of IMA, Udupi Karavali branch, 15 years of teaching experience and 96 journals published. She has participated and won prizes in competitions like Invictus, part of advisory board of Inderbir Singh textbook of clinical anatomy. A huge round of applause for Dr. Mamata H. Ma'am.
Now we call upon Dr. Mohammad Arif sir, Professor and HOD in General Surgery, Shumaga Institute of Medical Science, Shumaga. Sir has completed his MBBS from JSS Medical College, Mysore, MS General Surgery from Bangalore Medical College. He has a total teaching experience of 22 years with 22 publications. He has been a PG guide for past 4 years as well as NBEMS thesis evaluator. A big round of applause for his contribution as a teacher in the field of surgery. Thank you, sir.
He started his career at BMC at Chitradurga.
Next up, we have Dr. Manjunath Nekar sir, Professor of Community Medicine, KIMS Hubli, life member of IMA Hubballi branch with 17 years of teaching experience, 11 indexed international and 9 indexed national publications. He's been a chairman and vice president of various student committees. He's conducted several PG refresher courses for PG students of community medicine, BCLS course for 600 nursing students and faculty at a time, and awarded Best Secretary of Local IMA branch for 2021-22 from IMA National President. Next up, we have Dr. Prabha Adhikari, MR, from Yenapoya Medical College, Mangalore, Professor and HOD Geriatric Medicine, specialty being General Medicine and Geriatrics. She has had a total of 41 years of teaching experience with 305 publications. She funded projects 53 and non-funded research projects 45. Academic administration and leadership, she has been the HOD of General Medicine in KMC Mangalore for 5 years, HOD of General Medicine in Yenapoya College for 4 years, and HOD of Geriatric Medicine for 4 years. Can we hear it louder for Dr. Prabha ma'am? Next up, we have Dr. K. Rajgopal Shenoy sir, huge list of accolades, MBBS, MS, FRCS in Glasgow. He's a Professor General Surgery, Kasturba Medical College, Manipal, a life member of Udupi Karavali branch of IMA. He's been teaching since 1986, that marks 39 years in teaching. He has distinction with 3rd rank in pharmacology in his MBBS days. He's a literary champion and chess champion, a singer and a member of his college orchestra. He's guided 54 PG thesis topics. He's been an observer in GI surgery unit in the year 2000 in Glenfield Hospital, UK, and Massachusetts General Hospital, Boston in 2005. He's the author of the very famous Manipal Manual of Surgery 7th edition, and also the author of chapters in several books, including his contribution in many learning materials. He's published 65 journals and present in more than 70 papers. He's been awarded with several prestigious awards, including Lions International Mahadevan's Best Paper Award. Despite all this, Sir is very friendly to all the students and actively involved in Association of Surgeons of India. I'm sure that deserves another round of applause.
Now we welcome Dr. Revati Devi ML ma'am, Professor, Department of Physiology, Mysore Medical College. Ma'am has completed MBBS from Vijayanagara Institute of Medical Sciences, Ballari, MD from Mysore Medical College. Joined as a lecturer in physiology at Mysore Medical College in 2000 and serving for 12 years. Ma'am has served as a member of Board of Studies for PG courses in physiology at Rajiv Gandhi University of Health Sciences. A big round of applause for ma'am. Now we call upon Dr. H.P. Shivkumar sir, Dean and Principal of KIMS, Bengaluru. Sir studied MBBS and MS Ortho from Kempegowda Institute of Medical Sciences, Bengaluru. Sir is also managing partner of Ashwini Hospital, Yelahanka for the past 26 years, a founder member of IMA Yelahanka, executive committee member of at both central and state level of IMA. Sir also organizing chairman for both the Bangalore Orthopedic Society Conference and Karnataka State Orthopedic Conference, which were conducted successful under Sir's leadership. Thank you so much for your contribution for the orthopedics, sir.
Next up, we have Dr. Vidyadhar Kinhal. He is an MBBS MS and has done his FAIS in ASI Bhubaneswar. He is a professor and HOD of surgery in SR Patil Medical College, Badangandi, and has a total of 29 years of teaching experience. He has presented numerous papers at international and national conferences and has been a part of social activities with significant role in IMA Ballari branch and Malpractice Inquiry Committee, Bangalore, etc. We welcome sir on the dais.
ನಿಮಗಭಿಮಾನದ ಚಪ್ಪಾಳೆ ನಾಡಿಗೆ ಅಣ್ಣನೇ ಆಗಿರುವ ರಾಜಣ್ಣನಿಗೆ.
Next up, we have Dr. Vinay M., Associate Professor of PSM, Mandya Institute of Medical College, Mandya. Sir has been in teaching since 2003 as a tutor, assistant professor, associate professor with 14 years of teaching experience. He has worked in the fields of safe abortion, national immunization program and intradermal rabies vaccination. He has been a life member of IMA from 2008 and under his presidency, IMA Ballari won the Best Branch Award in 2012.
ಯೋಗಿಗೆ ಚಪ್ಪಾಳೆ 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 ಕಣ್ಣನ್ನು ನೀಡುವ ಅಣ್ಣನಿಗೆ ನಮ್ಮಯ ಪ್ರೀತಿಯ ಚಪ್ಪಾಳೆ ದೇಶವಾಡಿದ ನಾಯಕರೇ ನಿಮಗಿದು ಗೌರವ ಚಪ್ಪಾಳೆ ನಾದದ ಸುಳೆಯನ್ನು ಹರಿಸಿರುವ ನಾಯಕರೇ ಇದು ಚಪ್ಪಾಳೆ ಧೈರ್ಯ ಶೌರ್ಯವ ಮೆರೆಸಿರುವ ವೀರ ವನಿತೆಯರ ಚಪ್ಪಾಳೆ.
Truly, no words or honors can ever match the role these teachers have played in shaping lives. I request everybody, all the felicitated teachers, a big round of applause first of all. Let us put our hands together. We'll be taking a group photo.
ರತ್ನಕ್ಕೆ ಚಪ್ಪಾಳೆ ಕನ್ನಡ ಡಿಂಡಿಮ ಬಾರಿಸಿದ ಕವಿಗಳೇ ನಿಮಗಿದ ಚಪ್ಪಾಳೆ ದೇಶದ ಕಾಯುವ ಯೋಧರಿಗೆ ನಮ್ಮೆದೆಯಾಳದ ಚಪ್ಪಾಳೆ ಅನ್ನವ ನೀಡುತ್ತ ಸಲಹಿರುವ ನೇಗಿಲ ಯೋಗಿಗೆ ಚಪ್ಪಾಳೆ 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 ಕಣ್ಣನ್ನು ನೀಡುವ ಅಣ್ಣನಿಗೆ ನಮ್ಮಯ ಪ್ರೀತಿಯ ಚಪ್ಪಾಳೆ ದೇಶವಾಡಿದ ನಾಯಕರೇ ನಿಮಗಿದು ಗೌರವ ಚಪ್ಪಾಳೆ ನಾದದ ಸುಳೆಯನ್ನು ಹರಿಸಿರುವ ನಾಯಕರೇ ಇದು ಚಪ್ಪಾಳೆ ಧೈರ್ಯ ಶೌರ್ಯವ ಮೆರೆದಿರುವ ವೀರ ವನಿತೆಯರ ಚಪ್ಪಾಳೆ 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 ಕೀರ್ತನೆ ವಚನವ ಬೋಧಿಸಿದ ಯೋಗಿ ವರೇಣ್ಯರ ಚಪ್ಪಾಳೆ ಕ್ರೀಡಾ ಲೋಕದ ಸಾಧಕರೇ ನಿಮಗಿದ ಸ್ಫೂರ್ತಿಯ ಚಪ್ಪಾಳೆ ಬೆಳ್ಳಿ ತೆರೆಯ ತಾರೆಗಳೇ ನಿಮಗಭಿಮಾನದ ಚಪ್ಪಾಳೆ ನಾಡಿಗೆ ಅಣ್ಣನೇ ಆಗಿರುವ ರಾಜಣ್ಣನಿಗೆ ಚಪ್ಪಾಳೆ 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 ಚಪ್ಪಾಳೆ
We request the organizers to felicitate our chief guests, Dr. N.T. Srinivas sir. Thank you, sir, for being with us here today. Students will be there. It's okay.
Ma'am, it's not. Proper organization. Last minute.
It's okay.
How was it actually?
Let it finish. Yeah. All sentences how was it?
ಹೇಳಿದೆ ನನಗೆ. I'm not satisfied. What? Not good.
It's fine.
After this.
15 minutes. Felicitating Dr. Mahesh sir. Thank you, sir, for being with us here today. Last one. Sir, Prabhu Swamiji, we request the dignitaries on the stage to stay back on the stage for prize distribution, for poster presentation and paper presentation. Let us felicitate our Swamiji, Shri Basava Prabhu Swamiji. Thank you, Swamiji, for being with us. Now, carrying forward the spirit of inspiration, let's celebrate today's bright minds through prize distribution for poster and paper presentation.
We extend a heartfelt welcome to our esteemed judges who have kindly accepted our invitation and joined us today to evaluate and inspire all of us. Your presence adds immense value to this academic gathering. I request all the judges to assemble on the dais. Dr. Nagendra Gowda sir, Dr. Sharad BV sir, Dr. Manjunath Rao sir, Dr. Shri Krishna HK sir, Dr. Kaushal MD sir, Dr. Ranjit Kumar RT sir, Dr. Pradeep BS sir, Dr. Kotresh M sir, Dr. Lagu SP sir, Dr. Basavaraju Sangolli sir to come up on the stage. I request Dr. Narayan Murthy sir to felicitate Dr. Nagendra Gowda sir. Thank you, sir.
Starting with the prize distribution, we will first start with the poster presentation. For the poster presentation, the second prize goes to Dr. Abhiraj Saharia, JJM Davangere. Please come up on the dais. Dr. Abhiraj Saharia, JJM Davangere, second prize for the poster presentation. Big round of applause. The first prize for the poster presentation goes to Dr. Tanmay Madhukar, JJM Davangere.
The audience are requested to please be seated.
The audience is requested to please be seated. Dr. Tanmay Madhukar, JJM Davangere, first prize for the poster presentation. Going forward with the pathology paper presentation, there were two halls, Hall A and Hall B. There are two prize winners for both of them. Hall A paper presentation for pathology, second prize goes to Dr. Meghana Shri, JJM Davangere. Please come forward to the dais. The first prize for Hall A pathology paper presentation goes to Dr. Aneet Varghese, SS Davangere. This is Dr. Meghana Shri, JJM Davangere, second prize. First prize, Dr. Aneet Varghese, SS Davangere. Moving on with the Hall B paper presentations. Second prize goes to Dr. Uma Bharati, SS Davangere. The first prize for pathology paper presentation Hall B goes to Dr. Nevizuno Rio, Siddhartha Medical College, Tumkur. Second prize to Dr. Uma Bharati, SS Davangere. And the first prize to Dr. Nevizuno Rio, Siddhartha Medical College, Tumkur. Moving on with the paper presentations in the lecture hall 1. Oral PG presentation, the third place goes to Dr. Srinivas Rathod. Please come over to the dais. Dr. Srinivas Rathod, third place. The second place goes to Dr. Smita SB. I repeat, the second place goes to Dr. Smita SB. Moving on to the first place. The first place for oral PG presentation goes to Dr. Puneet Nagraj Moolimani. Moving on, e-poster presentation winners for lecture hall 1. The second place goes to Dr. Varsha MR, SS Davangere. The first place for e-poster presentation goes to Surya Prakash Reddy Nandayala, Tumkur. Please come over to the dais. This is Dr. Surya Prakash Reddy Nandyala, Tumkur, the first place for e-poster presentation. Next, moving on, for oral PG presentations conducted in the lecture hall 2, the third place goes to Dr. Prajwal CM, Department of Forensic Medicine. The second place goes to Dr. Nitin K.S., Department of Community Medicine. The first place goes to Dr. Lokesh Nayak, Department of Pulmonary Medicine. Big round of applause. Dr. Lokesh Nayak, Department of Pulmonary Medicine, Basaveshwara Medical College, first prize for oral PG presentation. Next up, the undergraduates. The second place goes to Sheetal Kumar K, Basaveshwara Medical College. The first place goes to Kritika S. These are our winners for today.
Now, vote of thanks by Dr. Malvegoda, sir.
What is the bad banquet venue?
Banquet will be arranged for the awardees. This is at the Murugan Mills, Industrial Estate, Bangalore Road. To all the awardees, you are welcome to the banquet at the Murugan Mills, Industrial Road, Old Bangalore Road.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಗುರು ಬ್ರಹ್ಮ ಗುರು ವಿಷ್ಣು ಗುರುದೇವೋ ಮಹೇಶ್ವರ ಗುರು ಸಾಕ್ಷಾತ್ ಪರಬ್ರಹ್ಮ ತಸ್ಮೈ ಶ್ರೀ ಗುರುವೇ ನಮಃ. ನಾವು ತಂದೆ ತಾಯಿ ಆದಿಯಾಗಿ ನಮ್ಮ ಜೀವದ ಪ್ರತಿಯೊಂದು ಹಂತದಲ್ಲಿ ಅನೇಕರ ಸಂಪರ್ಕಕ್ಕೆ ಬರ್ತೀವಿ. ಪ್ರತಿಯೊಬ್ಬರು ಕೂಡ ನಮಗೊಂದಲ್ಲ ಒಂದು ರೀತಿಯಲ್ಲಿ ಶಿಕ್ಷಣವನ್ನು ನೀಡಿರ್ತಾರೆ, ಒಂದು ಇದನ್ನು ನೀಡಿರ್ತಾರೆ. ಆದ್ದರಿಂದ ಎಲ್ಲರೂ ಒಂಥರ ಶಿಕ್ಷಕರೇ ಆಗಿರ್ತಾರೆ. ಅವರೆಲ್ಲರಿಗೂ ವಂದಿಸುತ್ತಾ ಈ ದಿನದ ಶಿಕ್ಷಕರ ದಿನಾಚರಣೆಯ ಕೊನೆಯ ಹಂತಕ್ಕೆ ಬಂದಿದ್ದೀವಿ. ಸೊ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಆಗಮಿಸಿ ಕಾರ್ಯಕ್ರಮವನ್ನು ಉದ್ಘಾಟನೆ ಮಾಡಿ ಮತ್ತು ಗುರುಗಳಂದರೆ ಹೇಗಿರಬೇಕು, ಅವರು ಪ್ರತಿಯೊಬ್ಬರ ಬಾಳಲ್ಲಿ ಏಕೆ ಬಹಳ ಮುಖ್ಯ ಆಗಿರ್ತಾರೆ ಅಂತ ಒಂದು ಆಶೀರ್ವಚನವನ್ನು ನೀಡಿದಂತಹ SJM ವಿದ್ಯಾಪೀಠದ ಸದಸ್ಯರು, ಆಡಳಿತ ಸಮಿತಿಯ ಸದಸ್ಯರಾದಂಥ ಡಾಕ್ಟರ್ ಬಸವಪ್ರಭು ಸ್ವಾಮೀಜಿಯವರು ಆಗಮಿಸಿದ್ದಾರೆ. ಅವರಿಗೆ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ಪರವಾಗಿ ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಿಸೋಕ್ಕೆ ಇಷ್ಟಪಡ್ತೀನಿ. ಆನಂತರ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮದ ಮುಖ್ಯ ಅತಿಥಿಗಳಾಗಿ ಡಾಕ್ಟರ್ NT ಶ್ರೀನಿವಾಸರವರು ಬಂದಿದ್ದಾರೆ. ಅವರು ಇಲ್ಲಿ ಕೇವಲ ಶಾಸಕರಾಗಿ ಬಂದಿಲ್ಲ, ನಮ್ಮ ವೈದ್ಯರಾಗಿ ಕಳೆದ ಒಂದು ವರ್ಷದಿಂದ ನಮ್ಮ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸಂಪರ್ಕದಲ್ಲಿದ್ದಾರೆ. ಅವರು ಮೊನ್ನೆ ವಿಧಾನಸಭೆಯಲ್ಲಿ ನಮ್ಮ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ವೈದ್ಯರು ಯಾವ ಒಂದು ತೊಂದರೆಯನ್ನು ಅನುಭವಿಸ್ತಾರೆ ಅನ್ನೋದನ್ನು ಭಾಳ ವಿಚಾರವನ್ನು ಪ್ರಸ್ತುತಪಡಿಸಿರ್ತಾರೆ. ಸೊ ಅದರ ಜೊತೆಗೆ ಅವರು ಇನ್ನು ಮುಂದೆ ಕೂಡ ನಾನು ವೈದ್ಯರಿಗೆ ಸಮಸ್ಯೆಗಳಿಗೆ ಸ್ಪಂದಿಸ್ತೀನಿ ಅಂತ ಹೇಳಿ ಈ ಮುಖೇನ ಹೇಳಿದ್ದಾರೆ. ಸೊ ಅವರಿಗೆ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ಪರವಾಗಿ ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಿಸೋದಕ್ಕೆ ಇಷ್ಟಪಡ್ತೀನಿ. ಆನಂತರ ಈ ದಿನದ ವಿಶೇಷ ಆಹ್ವಾನಿತರಾದಂತಹ ಡಾಕ್ಟರ್ ಮಹೇಶ್, ಇವರು ಮಾಜಿ ಪ್ರಾಂಶುಪಾಲರು ಮತ್ತು ಡೀನ್ BMC NH ಅವರು ನಾವು ವೈದ್ಯರಾಗಿ ಏನು ಮಾಡಬೇಕು ಅಂತ ಹೇಳಿ ಒಂದು ನುಡಿಗಳನ್ನು ನೀಡಿದ್ದಾರೆ. ಅವರಿಗೂ ಕೂಡ ಒಂದು ಧನ್ಯವಾದಗಳನ್ನ ಅರ್ಪಿಸ್ತೀವಿ. ಆನಂತರ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮದ ಅಧ್ಯಕ್ಷತೆಯನ್ನು ವಹಿಸಿದಂಥ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ಡಾಕ್ಟರ್ ಚಿನಿವಾಲರ್ ಅಧ್ಯಕ್ಷರು ಅವರು ಭಾಗವಹಿಸುತ್ತಾರೆ. ಅವರಿಗೂ ಕೂಡ ನಮ್ಮ ಸಂಘದ ಪರವಾಗಿ ಒಂದು ವಂದನಾರ್ಪಣೆಯನ್ನು ಅರ್ಪಿಸ್ತೀವಿ. ಜೊತೆಗೆ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮದ ಕೇಂದ್ರ ಬಿಂದುಗಳಾದಂಥ ವೈದ್ಯಕೀಯ ಕ್ಷೇತ್ರದಲ್ಲಿ ವಿವಿಧ ವಿಭಾಗಗಳಲ್ಲಿ ಬೋಧಕರಾಗಿ ಕೆಲಸ ಮಾಡ್ತಾ ಇವತ್ತು ಈ ಸನ್ಮಾನಿತರಾಗಿ ಬಂದಂಥ ಎಲ್ಲ ಸನ್ಮಾನಿತರಿಗೂ ಕೂಡ ರಾಜ್ಯ ಶಾಖೆಯ ಪರವಾಗಿ ಮತ್ತೊಮ್ಮೆ ಅಭಿನಂದನೆಗಳನ್ನು ತಿಳಿಸೋದಕ್ಕೆ ಇಷ್ಟಪಡ್ತೀನಿ. ಮತ್ತು ಈ ಕಾರ್ಯಕ್ರಮವನ್ನು ಆಯೋಜನೆ ಮಾಡಿದಂಥ ಚಿತ್ರದುರ್ಗ ಶಾಖೆಯ ಎಲ್ಲ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಚಿತ್ರದುರ್ಗ ಶಾಖೆಯ ಎಲ್ಲ ಪದಾಧಿಕಾರಿಗಳಿಗೂ ಮತ್ತು ಚಿತ್ರದುರ್ಗ ಜಿಲ್ಲೆಯ ಎಲ್ಲ ಶಾಖೆಯ ಪದಾಧಿಕಾರಿಗಳಿಗೂ ಕೂಡ ಈ ಸಮಯದಲ್ಲಿ ವಂದನಾರ್ಪಣೆಯನ್ನು ತಿಳಿಸೋಕ್ಕೆ ಇಷ್ಟಪಡ್ತೀನಿ. ಮತ್ತು ಈ ಒಂದು ಸಭೆಯಲ್ಲಿ ಬೆಳಗ್ಗೆ ಮುಂಜಾನೆಯಿಂದ ಇಲ್ಲಿವರೆಗೂ ಈ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಭಾಗವಹಿಸಿ ಈ ಸಭೆಯನ್ನು ಬಹಳ ಯಶಸ್ವಿಯಾಗಿ ನಡೆಸಿಕೊಟ್ಟಂಥ ಎಲ್ಲರಿಗೂ ಕೂಡ ಮತ್ತು ಈ ಕಾರ್ಯಕ್ರಮ ಯಶಸ್ವಿಯಾಗೋದಕ್ಕೆ ಪ್ರತ್ಯಕ್ಷವಾಗಿ ಮತ್ತು ಪರೋಕ್ಷವಾಗಿ ಭಾಗವಹಿಸಿದಂಥ ಎಲ್ಲರಿಗೂ ಕೂಡ ವಂದಿಸಿ ವಂದನಾರ್ಪಣೆಯನ್ನು ಮುಗಿಸ್ತೀನಿ. ಜೈ ಹಿಂದ್, ಜೈ ಕರ್ನಾಟಕ.
Thank you so much, everyone. We'll see all the delegates, the organizers, and the awardees at the banquet. Thank you. Everybody, please stand up for the national anthem. Jana Gana Mana Vinay Bhagavidata Pancham Sindhu Gujarat Maratha Dravida Utkala Vanga Vindhya Himachala Yamuna Ganga Uchala Jala Vitaranga Tava Shubhaname Jage Tava Shubhashishamage Gahe Tava Jaya Gata Janagana Mangaladayaka Jaya He Bharata Bhagya Vidhata Jaya He Jaya He Jaya He Jaya 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 He Jai